చెప్పండి రామకృష్ణ సార్ చేయండి ఇంజెక్షన్. ఓకే ఓకే, ఆయనకు సాటిస్ఫాక్షన్ ఉండదు లైఫ్లో. అప్పుడు చెయ్యి నొప్పి వచ్చేదాకా నా బుర్ర తింటాడు. ఓకే, ప్రెషర్ చెక్, ప్రెషర్ చెక్, ప్రెషర్ చెక్. ఇస్ ఇట్ రాంగ్? నో నో నో, 1 minute. చెప్పాను కదా, ప్రెషర్ వచ్చేదాకా నా బుర్ర తింటాడని. ఇప్పుడు వెయిట్, ఐ హ్యావ్ టు పుల్ బ్యాక్ ది గైడ్ ఆల్సో. ఓకే, లిటిల్ right?
We are live, ma'am.
Yeah, greetings from India to everybody. And the much awaited academic extravaganza is now here to rock. With all the lady cardiologists with all their strength coming in, I would now like to welcome our organizing secretary for Women Cardiac Care WCC Conference by the WinCars 2022, Dr. Sarita Rao, to please come over and take over the proceedings of the session.
Good morning, everybody, and a very warm welcome to WCC 2022. And we will be starting with our live case session. The moderators for the live case, I would like to invite Dr. Mary Claude, Dr. Zakia Khan from Fortis Mumbai, Dr. Mirvat Alasnag. Our chairpersons for the live case event will be Dr. Asha Mehran, Dr. Betty T, Dr. Lalita, and Dr. Mashadi Mahapekar. So we will be starting with our first live case. We will be going live from Indus Hospital, Visakhapatnam. Can we go over to Dr. Sujata and her team?
Good
Dr.
morning.
Sujata?
Can you hear me?
Yes, Dr.
Morning.
Sujata, we can hear you. Good
Okay,
morning.
very good morning on a very ambitious conference, WCC 2022. So I welcome all the delegates. And I have a very big team with me. I have Anil, I have Rakesh, Santosh, Shivdayal, then I have Tapti on the anesthesia. Then I have nurses, Rama and Somu. Then I've got technicians, Ramakrishna, Lavanya. So it's a big team here. We are trying to showcase one case. I don't know whether it will meet the standards of Sarita, who is always the most complex cases. So let me have my presentation.
Dr.
So
Sujata, I'm sure it will be amazing.
What? Okay. So the next slide, please. Next slide. So I have a 69-year-old lady, diabetic, hypertensive, clinical presentation is unstable angina, normal LV function. The creatinine clearance is 60 ml per minute. She has obstructive lung disease. Her hemoglobin is 10 grams per deciliter. Next slide, please. So I'll show you the angiography. The angiography was done outside, and it was, Ramakrishna, can you show the angiogram? The angioplasty surgery was advised. So you can see that there is a superdominant right coronary artery lesion at the crux, which is predominantly extending into the PLV. There is some plaque burden even in the PDA. Next slide, next shot. So that's the LED. Then you can see the OM. The OM is diseased. There is a tortuous OM, and OM1 has showing around 70-80% stenosis. Next slide. Next shot. Next shot, Ramakrishna. Next angiolo. Okay, so now you can see that I have a very diffuse disease in the LAD. I've got almost more than 30 millimeter lesion. Then I have got two diagonals which are arising there, a D1 and a D2. Both are having ostial stenosis. So now, CABG was advised. So we thought we'll go systematically and try to analyze as to what to do for this lady. She's 52 kgs and 152 centimeters, and her BMI is around 25. So this is the history. Next slide. So the questions before me are, should I do a CABG? Should I do a PCI? Already PCI has been advised, CABG has been advised outside. So she came to us. Then FFR guided, what should I do? Should I do an physiology guided PCI or an angiography guided PCI? Should I use imaging? So how do I reduce my MACE over the long term? Next slide. So we calculated the syntax score. The syntax 1 score was 27. We did the syntax 2 score, and there is, you can see that there's almost equivalent mortality with both CABG and PCI. The game changer was the obstructive lung disease. So this has changed in this 69-year-old lady with diabetes, hypertension. These comorbidities, as you know, they change the game. Next slide. So what are the FAME-3 trial? Sorry for the slide. The FFR guided versus angiography guided. They found that CABG, you have the randomized control trials, very what do you call, very population, very select population. And you find that the CABG is, what they said was, PCI was not non-inferior to CABG, double negative. Next slide. But what are how many women are there in the trial? Only 20% are women. And you can see that females, they're tending to do better than the males. But that is not enough. There's not enough data to glean information with only 20% women in the trial. Then you can see that the more complex the syntax score, the score more anatomic atherosclerotic burden that is, there will be more use of CABG rather than PCI. We have an intermediate syntax score around 27. Next slide. So what about the impact of revascularization, the extended syntax score? So interestingly, after 5 years, women had higher mortality with PCI compared to CABG, and syntax 2 score, what they did was, one of the 6 risk factors was women, and they included women. But last year, the data was published with the syntax 2 extended survival, the 10-year data, and there's no difference between men and women. So should that female sex be removed from the syntax 2 score is the question before us. Only 22% again are women. Next slide. So again, there's a very few meta-analysis, 6 trials, endpoint of trials, women, CABG versus PCI, 6 trials, only meta-analysis, only 25% are women. And you can see the data is more in favor of CABG than PCI because most of the data is from the Excel trial, the syntax, and the Freedom trial. So in all these trials, there was a trend towards reduced mortality with CABG as compared with PCI. Next slide. So what about physiology in women? Women comprise again 25%. I think Dr. Miravat will enlighten us on this. Women comprise only 25% in physiology trials. With similar rate of angiographic stenosis, women fewer ischemic lesions by FFR, women older, more hypertension, more unstable angina. So proportion with FFR is less than 80 is lower in women than men with CS coronary stenosis between 50 to 90%. And 2-year MACE, though, in spite of these differences, is similar between men and women. Next slide. So what about the sub-study of women in defined flare? No difference in IFR between men and women, but higher FFR in women. Revascularization was not different between whatever the strategy in women, but in men, IFR guided strategy, less revasc. No difference in MACE according to sex or the strategy. Next slide. Intracoronary imaging, we have even less data, less enrollment of women, no analysis of outcomes by sex, sex-specific measurements are lacking. So with this data in hand, so I would like to access the panel and ask them what they would suggest. What do they want me to do? FFR? Do they want me to do CABG? What is the thoughts of the panel?
So, Dr. Asha, your comments, please. Dr. Asha, can you hear me?
Yeah, I can hear you. This is a youngish female, 52-year-old female, and she has comorbidities like COPD, anemia, and the patient's preference also is PCI. I think we can go ahead and do a PCI. And the long-term MACE should be prevented, and we definitely have to use imaging. I think I would first do the LAD diagonal bifurcation and then tackle the LCX, probably FFR to the RCA. The RCA does not look very tight, the crux, maybe FFR to the RCA and then take a call.
Okay. Your comments, Dr. Alasnag? Is Dr. Alasnag here? Dr. Betty?
Hi, I would definitely go ahead with the PCI. They are all quite simple to do. And I think that at her age, right, if we were to do a cabbage and it lasts 10 years, it would be difficult by then. So I would go ahead with the PCI. I would start with the LAD. I don't think I would touch the diagonal at all. It's not very big.
Yeah.
I closed it.
So you would do straight away LAD and won't worry
LAD,
about
then
the diagonal.
yeah.
It's a very
Yeah.
small lesion, very short lesion.
I think
Yeah.
forget about the diagonal, both diagonal, yeah.
Yeah. We also need to look into the amount of contrast we are using in this
Yeah, that's right.
overweight
So
lady.
do bifurcation and yeah.
Try to be simpler and do as many lesion as we can with the
I
low
think we can
amount of
complete
contrast.
those whole three vessels in
Mm.
just one sitting, yeah.
Yeah. So no need of physiology, we feel, Dr. Lalta. No need at all. We just want to go ahead, do the plasty and do it image guided and see that the stents are implanted and oppose well. That should be our aim.
So you mean to say that physiology is redundant in this patient, though one in the panel, Asha, felt that we should look at the physiology in the RCA. Why don't you connect and see the...
So let's go ahead and do the LAD and LCX and then take
Okay, so we decided to follow the FAME3 strategy. We did the FFR of all the three, RFR of all the three vessels. I'll show you. Show the RFR of the... we first put it into the PDA and PDA was 0.93. Are you showing? Okay, come on, Ramakrishna. Next, we put it into the PLV. So this is the PLV FFR. Okay, next. PLV RFR with pullback. So that's the pullback. So you can see it gives you, because it is a very abrupt jump and it's not diffuse disease. Can you show Ramakrishna? Okay, that's the, show it, no? Okay, next slide. Next, circumflex OM. So RFR is 0.86 in the OM, pullback. Next, pullback LCX. So that's the RFR pullback. Again, you have discrete lesion that is a little more in favor of a PTCA. Next, LAD. LAD. So this is the RFR in the LAD. So as you can see, LAD is contributing most and we decided to do the LAD. So we pre-dilated, we wired. Show the angio. So we pre-dilated with a 2.512. Oh, before doing that, we did the OCT. Can you show the OCT, Ramakrishna? We'll show you the OCT, pre-OCT. So you can see there is a significant plaque burden and you can see very critical lesions as it comes back. Because we didn't pre-dilate, you can see that there is less clearance. So fibrous plaque there, specks of calcium, not much calcium. And as you come, you can see there are focal, again, you can see macrophages at the 30 position. And as you come proximally, you can see there was a stop there. So there is a plaque erosion there. at 40, 45, between 40 and 45. So that is contributing actually by that haziness which we are seeing. So that was plaque erosion. Basically, it's an unstable plaque, and we also saw macrophages. So all these data are suggestive of a high-risk plaque. Okay. So we measured actually at 10. Can you show the EL to EL measurement at 10? So the EL to EL measurement was only 2.3. So we decided to take a 2.5 stent. Okay. And actually we thought we would take a 38 stent coming from 10 to 48. So we pre-dilated. Next slide. Next runs. We pre-dilated.
Can you show us the angio, please?
Yeah, we are showing the angio now.
Yeah.
We wired the diagonal, as you can see. We left the first diagonal. We wired the second diagonal. We felt it was more larger. So in case it closes, we are ready. We pre-dilated. Next. Next. So after pre-dilatation, this is the result. So actually, we wanted to stent just below the diagonal, take a 38 millimeter stent, but then we decided to take a 48 millimeter stent. We took a 2.5 expedition. Next. So this is the 2.5 48 expedition. We stented.
What was the diameter of the proximal vessel, doctor?
The proximal vessel came up to 2.75.
Okay.
Or 3, I think.
Yeah,
Can you measure the?
Looks bigger.
Because the lumen to there was no EL to EL measurement which we can do proximally. We did the lumen measurement. Lumen measurement came around 2.7. Go to 40. Do the lumen measurement. Go do the lumen measurement. So it's 2.7. So I upsized. I thought down. I already have a 2.5 N balloon down. So I decided to use a 3 balloon for post dilatation above. So I used a 2.548 stent. Next slide. Next angio. Next. So after that, you saw that the proximal diagonal has closed. So we did a distal dot with the 2.5. We went to high pressures. Next. Next. So we went, because we had already a 2.5 stent on board. This is a 315 stent. We did a pot. We proximally also we did a pot. And after the thing, so we are at this point of time. Our diagonal is closed. So the questions are, should we access the diagonal? So we did a OCT at this point of time. Show the
So
OCT.
can we shift over for a couple of minutes, ma'am, to
Yeah,
and then come back to you?
Yeah.
So by the time you settle the issues of diagonal,
you think you want me to access the diagonal, or you want me to sacrifice the diagonal?
I think it's small. Give some Nicoran, some intracoronary Nicoran, NTG might come.
Dr. Zakia, it won't come back.
Yeah.
Take it from me, it won't come back.
We check.
It's very difficult to wire. Actually, mentally, I'm prepared to leave it, as Dr. Betty has already pointed out. So
it's small, but maybe after you take out the wire and give ECG and all, some flow might be still established in that. So you can try your luck.
Anyway, I've done the, you can see the OCT. So the OCT is showing good MSAs. Can you show the MSA, the rendered stent? So there's no malapposition. We just have to see the expansion. Can you go step by step? So 4, more than 4.5 we can see. So the other issue is, should we post dilate here again, because the areas are less. They're coming around 4.3. So there is definitely an under expansion of the stent. Come proximally. So after that, it is more than 5. Okay. So proximally, it's more than 5, only distally. But I'll compare, if I compare with the distal, can you show me the area at 10, Ramakrishna? I don't want to look at the diagonal. Don't do 3D and all. Go beyond 10. Go beyond the stent. Go beyond the stent. Go beyond the stent. So you can see the areas, if I compare with the distal area and look at the expansion rather than the MSA on its own, you can see that the distal area is only 1.92 millimeter and my areas are all more than 3.5. So do you want me to post dilate or do you want me to leave it at that? Because I already did with a 2.5 and I did at 22 atmospheres.
I think angiographically it looks a little actually over dilated distally. I would stop with that. And
can I ask, why did you choose such a long stent and not just target that lesion?
Yeah, so I chose a long stent because proximally you have seen that my actual initial diameter was 38 was what I had to take. But after that, there was haziness below, which I had to extend 5. And actually, it was touch go. And I have good news for you. My RFR post procedure is 0.97.
No, I was not even talking about 38. I was thinking about maybe 18.
Oh,
just target near the diagonal, first diagonal.
No.
So
because
awesome,
above the
results
first
and-
diagonal, there is lesion below the diagonal. There is I also showed at 40 there was plaque erosion, unstable plaque. So all these factors with a high risk plaque, I cannot leave the high risk plaque. So that's the reason why. And this is the RFR post PCI. Just now we connected is 0.98, so I don't want to do anything.
So great, ma'am. I think we are catching up fast and great interaction, but Hyderabad is also waiting. So
I'll
can you
leave the
switch over
diagonal and I will
we'll just get back to you. Get back to you with the file. Yeah.
Right. Okay, we'll do up the diagonal.
Yeah, Shekhar, you can do over now.
Okay.
So we are at NIMS. Request the chairpersons and the moderators to please get in touch with the faculty at NIMS.
Yeah. Hi. Hello to everyone.
Good evening.
Hello, Dr. Jyotsna. Can you hear us?
Yeah. Thank you. Thank you very much. And so nice meeting. A very good case was started by the Dr. Sujata. I'm very helpful. Panel is there for me to guide me properly. And I welcome each and everyone. Dr. Teh and Dr. Mehran, Dr. Sarita, and of course Sujata is also doing the case, and with other people. I'm very, very happy to be here. So now you can see the atmosphere of an institute. You can see so many people of us along with us. With me, the Daya is my fellow, and Dr. Sri Krishna, and you can see that the 7 technicians are then waiting, and all of them the experts who has an experience more than 30 years. And of course the sisters group, you can see it. So this is the feature of an institute. So I'm very happy that I need not to worry for anything. Everyone is available for the every event. Now I'll request Daya to tell about the case. Daya, please.
So here we have a 68-year-old male, and he was
Sorry, we can't hear
Can't
you.
hear you.
Can't hear you.
Okay, mic is not kept to her. Okay. So then can I have the slides? Can I have the slides? Please send.
check.
Is she audible? Is Daya is audible?
Check.
Yes, we can hear.
Yes, we can hear the check.
Yeah, please go ahead there.
So here we have a 68 years old male who was a smoker and alcoholic. just 1 month back, he was diagnosed to have right lower limb
Freeze the
DVT
same one.
into the right popliteal vein. And then he was diagnosed to have pulmonary thromboembolism just 1 month back and was started
Leave it.
on
Good to
acetrom then. But later, the patient started having chest pain since 15 days,
Run.
which was typical anginal pattern and shortness of breath, NYHA function
C
class
minus.
2. So he came to us with the same
Freeze.
findings 15 days back. And at that time, ECG, it was
That's
showing QS in lead 3 and AVF.
Length will
And
be
at the
different.
same time, patient had T-wave inversions from V1 to V6 pattern. 2D echo did not show any
2.75.
RWMA. It was fair LV
33.
function,
To this
but
distance.
patient had moderate TR and moderate PH with RV dysfunction. TROP-T was negative. So after that, CT pulmonary angiogram was done, which showed only partial thrombus was there in distal MPA, which was going into RBA and LPA, but causing only 30% of luminal narrowing. So it had become a subacute pattern. So later we posted the patient for angiogram. Can we have angiogram videos, please?
Just I wanted to break you here. This is the COVID situation where we have the significant pulmonary arteries with the thrombus and as well as the acute coronary syndromes. So I wanted the panel discussion on this point. What do you think that it is in a COVID related or un-COVID related? Because I thought this is an appropriate case now to discuss in this era. What do you feel about it? So extensive pulmonary thrombosis and as well as the presentation of the acute coronary syndrome simultaneously. May I have the opinion of Dr. Sarita, please?
Dr. Betty, can you comment? Dr. Sarita is being busy. Yeah. Your comments, please, Dr. Betty.
Okay, this is quite a difficult case, I must say.
Yeah.
Yeah, I think that have we considered a bypass? Because the distal vessel looks good.
Our point of the discussion now is pulmonary thrombosis and simultaneous presentation of the acute coronary syndrome. So how do we approach and the strategies to take for the revascularization?
We treated his pulmonary embolism. How long into the treatment?
It is simultaneous presentation of the both pulmonary embolism and acute coronary syndrome.
I think we should treat the pulmonary embolism first and then really consider a bypass for him. But since we are, I think that.
So it's more like a thrombotic situation. So maybe consider thrombolysis, anticoagulation, stabilize the patient, and then take call on the other issues. Dr. Asha, are you there? Can you have your comments, please?
Yeah, we have seen quite a few cases of COVID-related thrombosis in multiple territories. A combination of pulmonary thromboembolism along with coronary events as well we have seen. So this is not a very uncommon situation in this condition. And sometimes we've also 1 or 2 reports after COVID vaccination as well. Probably this could be COVID related. We can look for the COVID antibodies, but whatever it is, this pulmonary embolism is 1 month old. Now I will go ahead and fix the coronaries, probably the LAD first, and then probably attempt the CTO of the RCA.
The problem sorry.
Yeah, thank you for the advice. Yes, we went in the same way. So because of the pulmonary embolism is not a massive, it is a submassive. So we offered a catheter-directed thrombolysis, but the patient preferred to go for the anticoagulation. So we gave the anticoagulation for the 1 week, and then we repeated the CT angio. There is a resolution of the saddle embolus, which was a significant to 70% to 30% now. And that's what is the Dr. Daya is presenting it. And the patient was started on the rivaroxaban. And now we shifted from the rivaroxaban to the heparin for the acute coronary syndrome management. He had then 1 episode of the rest episode of an angina in this 1 week. So now this is an angiogram. May I ask Daya once again to tell about the angio?
Just one question, Dr. George. Now, what is your antiplatelet strategy for this case? Are you going to go obviously you have to go for triple therapy for a short while. So you're going to use ticagrelor with aspirin, or you're going to use clopidogrel with aspirin with rivaroxaban. And what is the rivaroxaban dosage in this patient? You're going to go ahead.
Yeah, the thing is that is the point of the discussion. The major problem is we are already demonstrated that the triple drug regimen is now then indicated in this patient with a slight increased risk of the bleeding. But for him, the bleeding risk score came as low. That's why we are confident enough to give the triple drug regimen. So we started the ticagrelor, acosprin, and the rivaroxaban of the 10 milligrams. And the patient doesn't have any bleeding in episodes. And our aim is to continue for the triple and antiplatelet therapy for the 15 days and then reassess once again. If the bleeding risk is not there, we will continue for 1 month and then we will withdraw the acosprin, but we will continue the rivaroxaban and ticagrelor. I think with this, the studies are available recently on the triple anti-drug regimen. Probably we can discuss about whether this is a correct protocol or anything from the beginning itself we can drop off the acosprin or not.
And this is a complex solution. I think we should use aspirin for at least 1 year, 1 month. And the only thing is rivaroxaban dosage, I think 10 milligram is a prophylactic dose. We have to go for therapeutic dose since it's pulmonary thromboembolism. And there we have to use 20 milligram BID for 3 weeks, followed by OD dosage of 20 or at least 15. 10 will be only a prophylactic dose.
That's correct.
I think 20 milligram is recommended for after 1 month. After 3 weeks, 20 milligram is recommended for pulmonary thromboembolism. Yeah.
Yeah.
So
And
now,
I think that we still need antiplatelet on board, of course, if you're going to proceed with this case. I would think that I would try the right first, because if you do the left and then you can't open the right, then what happens?
Yeah, but the problem is, if you see that angiogram, I don't know whether it is seen very clearly or not. There is a diffuse disease of an LAD with multiple lesions, and there is a short segment of the CTO of the RCA, which is showing even a retrofill from that of the left system. So that's the reason with an so diffuse disease on the left side, and there is a good collaterals coming from the mid segment of the LAD, which is giving a good collateral supply to the RCA. So to preserve that, we have then stunted the LAD first, because have you seen the ECG? The changes are the more in the anterior territory, and so there is a slight doubt about a focal CTO lesion in the RCA. So we thought that is not the exact culprit vessel at the time. So we went ahead with an LAD and angioplasty. We stunted, but only the precaution what we have taken at the LAD angioplasty. Can I go to the next slide, please? That the stunting is done in such a segment that the major septal branch, which is giving to that of the collaterals, is avoided by the overlap stents. So we stunted within 2 long overlap stents to both the LAD territory, and you have see that after the stunting just now we done the previously that stunting, this is a good result, and still the septal branch is able to give the collaterals. Today now we will go to this an RCA now at present. Can I go for the first view of the RCA?
so ma'am, how many days back this LAD was done?
2 days back.
2 days back. Okay. So only worry in a PH patient when you are working on an LAD which is giving collaterals to a very big RCA, there could be an issue on table, but fortunately we have done well and patient has done well. So
yeah,
Yes.
the thing is the
it's a
culprit.
donor vessel. It's a donor vessel.
Yeah, agreed. But the
Yeah.
major problem is presentation is an unstable angina is because of the changes on the ECG territory, and the echo is also the anterior territory hypokinesia is predominant. So the culprit vessel is an LAD. That's the reason why we have to. But the only precaution what we have taken is there should not be any overlap. If at all we require a retrograde from collaterals from the LAD. So this is the present in RCA. And can you freeze the RCA, please? Can you show the first? Yeah, please, step by step. It's almost like a near total occlusion. If you are able to see it, Vijay, can you show that lines? There are the 2 lines, actually one external, one internal, and we are not sure which one is in continuity with that. But fortunately, there is a looking like a TIMI 1 flow distally. Okay. Are you able to make it out that?
Acute. Subacute.
There is a irregularity from the almost from the proximal segment of the neck. RCA, avoiding the ostium, and subsequently there is a filling defect, which is there are the two lumens are the same. One is to the external surface, one into the internal surface, and we are not sure out of the two layers which one is in continuity of the distal segment. So to confirm that, we went into different views because we wanted to make sure whether we should go for the CTO strategy or a simple acute coronary syndrome strategy. So please go to the other views. Yeah. So you see this lateral view. What do you feel about it? Can I have the comments from the panels, please?
I think, Dr. Jyotsna, there's a micro channel.
Yeah.
Definitely, there is some flow. I would, it looks like a recent occlusion. I would first attempt with a microcatheter with a workhorse wire. If it doesn't go, then you can escalate the wire to a field XT. That would be my
I think, Dr. Jyotsna, you'll be able to go through.
Yeah.
You just take a floppy run through and go, you'll be able to go through. Both the two channels are leading to the same vessel distally.
Yeah. But the problem is we are not sure when the two channels are the present, which channel will communication. Actually, we have the last about 1 month back, we presented a case of having the multiple channels. Once we have to gone to the one of the channels of the circumflex, that was the circumflex CTO, and that channel was leading to this coronary sinus, and another channel was in the true lumen communication to the distal LCX. So unless we poke them, we can't be very certain. That is, even though it looks like both the channels in the communication to the distal vessel may not be the true. So as Dr. Asha said, I also thought that it is better to go like at the CTO gadgetry. So we went ahead with the, can I have the next views? These are the multiple views to demonstrate there is some stasis at the distal end to demonstrate that probably that may be the true lumen going into the distal vessel. There is a very short segment of the CTO or ATO. We are not sure about it. By feeling the palpogram by the balloon, we can be very certain about it. So can I have the next view? So we have taken the double injections are also for the sake, assuming that that is a CTO, which is demonstrating the good collaterals from the LADs is still persisting. Next view. This is to confirm in the different views, the elevocranial. So subsequently, when we require to have the distal delineation of the vessels very well. So, so far and so good. As you suggested, we went ahead with the microcatheter. Next view, please. Yeah. No, there is the two more, the 3-4 views are there after this. You're not saved them. Yeah. Actually, we took the corsi, assuming that there is some calcium exactly at the site of the lesion. So we took the routine Cogar XT wire along with the corsair, and actually the corsair gave a support and we crossed it. I don't think they saved it, and there is a slight resistance at the site of the lesion. When we tried with an externally looking lumen to go, it was not going. Then with slight increase in the curvature, we could cross from the medial curvature, medial lumen, median collateral. So we went distally, and this is the site where actually we could pass the wire more distally. And the corsair was in the almost in the guide, you are able to see it. Next one, there are 3-4 the views are which are not saved at all. So when we took the corsair, there is, you see there is a slight resistance to go in. There is a jerky fashion it has gone in. So that was the site where we are able to see even the fluoroscopically the calcium presence. The corsair, I wanted to tell about the few of these microcatheters. What do you think, which one you prefer it? Like a fine cross, a Caravel or a Finite or the corsair? Nowadays a Pro and XS, all those things come. I would like to have the panel's discussion about it.
Yes, Dr. Betty.
Me again. I have no preference actually. No preference at all. Sometimes there's certain stock and sometimes there's none. I really have no preference.
Yeah,
So
I'm fond of using the corsair.
Prefer if you have side branch along or some bifurcation and then a CTO, then maybe a Caravel helps. Otherwise, in this situation, anything, I think anything should be okay in this situation.
Okay, so the Carcide, the Pro and the Carcide XS are the really the excellent catheters for the trackability. The previously the Carcide plain one was used even in the mild calcium is there was no problem, and most of the time it can go through that. But if there is a more than mild, at least a moderate calcium, the holding up for the tapered tip of the Carcide into the coronary lesion, into the calcific lesions are known to the knuckle. So that is an entanglement to the corsar is known to the knuckle. So of course, here we are expecting the mild calcium, not the significant calcium. That's why I was dare enough to take the Carcide instead of the other catheters. And the Carcide Pro, the trackability is so good. Only thing is the torque transmission takes a little bit longer for the Carcide XS than that of the Carcide plain. So this is the experience of mine for the Carcide. Okay, the next view.
Jyotsna ma'am, good afternoon. It's a very engrossing case. Please let us know when we can switch over to Vizag for a minute.
No, whenever you want it, whenever you want it. There is nothing else. Yeah.
Can we come back after 5 minutes and be done with their case?
Please go ahead.
Yeah, thank you, ma'am.
Yeah. So what is the length of the distal?
Shekhar, please do the needful.
Meanwhile, my guide came out all the standard problems. Can you hear me?
Yeah,
we can hear you.
Show the circumflex, Ramakrishna. I'm inside. I spoiled the. No, go back from the starting. Lavanya. Okay. No. Ramakrishna, show the circumflex angioplasty. So I decided not to wire the circumflex, the thing. I pre-dilated the circumflex, pretty simple, and I put a 2.523 stent. There is a concertina effect. Okay, and I post-dilated with a 2.5 to 22. So at 22, it goes up to 2.75. So meanwhile, I was trying to put the FFR wire and then I lost the guide. So the other thing is, the other question before us is, should we do the right in the same sitting? She's got a lot of spasm in the radial, or should we wait for the next? So this is what this is where I am. Can you show?
Can I just ask one question?
Yes, ma'am.
Your wire is still in the LAD when you were doing the circ.
Why are you?
Your wire is still in the LAD.
No, because I don't have much guide support. So the initial thing, you can see there is a lot of spasm, and so I decided to keep the wire there.
Okay, no, the question is actually not why. The question is that when you did the LAD, you double wired and you put one wire into the diagonal. But when you did the circumflex, there's actually a branch coming out, right? The AV circ. And it's a big branch, but you didn't double wire that. And you actually stented across the branch.
Yeah. Circumflex, see, I take it this way. That branch, even a surgeon is not going to graft it. So I'm not at all worried about that branch.
Yeah. I mean, I'm not worried, but
I'm not worried.
Just some thought,
but LAD, I had 2 diagonals, so I did not wire 1 diagonal. I wired only the second diagonal, which is larger. Okay.
Maybe it would have given you better support. That's what we're thinking. If you put 2 wires in the LCX.
Yes, I thought so too.
Yeah.
My wire. Oh, instead of being in the LAD.
Yes, that's right.
Yeah. Actually, that LAD wire is an FFR wire. So I did not change it. As you can see, I already showed you the post RFR was. Can you show Ram? The post RFR of the LAD was check. was 0.97. So I decided to do nothing for the LAD. I didn't dilate. I did not even chase that diagonal. So I am now in the circumflex and I'm trying to measure. And I'm also thinking, should I do the RCA in this sitting or should I take it in a second sitting? These are the questions.
RCA, definitely you can wait and do it in the next sitting because RCA lesion looks usually tighter than the actual lesion. But definitely in the second sitting, you can address it.
I think your result is very good for the circumflex. You really don't have to spend time trying to do the FFR, and I would do the RCA. Sorry.
Yeah, maybe that's a good idea. Already I destroyed the FFR
Yeah, it's
wire.
really very nice. I'm not worried about it at all. I wouldn't
Okay,
spend time.
I'll show the pictures. We'll show with we'll give the NTG and take the pictures of the circumflex and the thing and come out, and we'll try to do. I'll think about it whether I should do the right in the same sitting or I should.
How much contrast have you used? We just want to know that.
150.
Oh, then go ahead and do the RCA.
Yeah.
Yeah, I'll see if I can pass my guide through, I will do it. Otherwise, if the patient is in persistent pain, I'll go. Okay. So
Also,
the
only one
circumflex
thing,
is
Dr.
fine.
Sujata, with frail lady. With
I think, Dr. Sujata, you can take it in the next sitting.
Yeah.
If the spasm is there, you will only land up in complications.
Yeah.
Whenever the patient has pain, just stop it. You can always do it in the next sitting.
Yeah, there's I can do it with more concentration because basically, again, it's a bifurcation lesion. I have to what do you call do a provisional. I have to stent into the PLV, and then I have to measure. I have to.
I think best staged. Best staged.
So, yeah, great going, Sujata ma'am. Wonderfully done. And we are looking forward as you go in for the wires. Can we go back to Hyderabad by the time you're able to?
Sure.
Yeah, yeah. So coming back to you for the final this thing, we go back to the to Hyderabad. Is that fine with the chairpersons? Anything?
Yes, yes.
Yeah. So Jyotsna ma'am, we are with you.
1 minute. We will be back. 1 minute. Yeah, please inject. Yeah, enough. Yeah. You please, can you go back to the previous views where we stopped describing it? Go back to the views. That is, we have crossed and go back to the original views. Go back fast when we stopped the presenting to them, to that view. Inca back, still back, still back, still back, still back. Still back. Yeah.
Yeah, you were there when the wire crossed, right?
Still back. Still back. Still back. So you gave us more than 10 minutes to do so much of work. So this is the where we left you. And the next view. So this is the car side was removed, as we already know that there are the different mechanisms of the removing the most frequently used is the using the balloon to remove it. That's what we did it. And the microcatheter car side was removed. And if you see this, we have taken a 1.5 N balloon. There is a slight resistance to cross to the proximal segment, which we thought that there is some calcium is there. If you're able to see that, yeah, the next view with the slight manipulations, yes, it could take a turn and go down. And we are able to cross the lesion with a slight resistance. Almost at every bend, we have a resistance, but we could go to the more distally. Next, so then multiple dilatations are done. So you go next. Go on to the remove all these things and go to the next balloon. This is the angiogram after the doing the multiple dilatations with multiple dissections are seen and the plane of the dissections are still having a with the distal flow. So now what we have done it is to see that really what is the pathology and what is the degree of the calcium, because we have a resistance with the cord side as well as the smaller size balloons. We wanted to see whether the calcium is amenable directly for the NC balloons, or should we require a cutting balloon or something else, the calcium modifying measures. That's why we have done an OCT But before the OCT, I wanted to give a one precaution. Whenever the distal flows are not very good, it is not advisable to do it. Even though some change of the pathology can happen and the much more dissections are added, it is better to have the good flow distally than to do the OCT. Will have the better visualization. So we took the 2.5 balloon and multiple dilatations are done. Show all the dilatations. Next. Yeah, this is then after the multiple balloon dilatation. This is the angiogram what we have it with distal disease, which is looking like a significant with a minor dissection in the distal segment also, but we are not very certain angiocartographically. Of course, proximally we are able to see the dissections. So can we have the now the OCT run, please?
You're seeing the OCT run only, madam.
Oh, okay, good. But now, are you able to see the OCT run? Then run it. I'm not able to see the OCT run here. Okay, run it. Run from the proximal to the distal. We have the two runs. As you already know that more than the longer the length is there, more than 54, then it's better to have the two runs. As we know that the distal disease also is there, and with a slight doubt about the dissection, without a balloon dilatation there. So to exclude the spontaneous dissection or the wire-related problem, we had the first run to the mid-segment of the RCA and the second run from the mid-segment of the RCA to the ostial area. So this is the distal run. Are you running the first one? Yeah, please run it. So run it. First run it and then we can stop it and show to them. Yeah, go ahead. So this is the tightest portion which is showing a mostly the calcific, and there is a fibrous areas you are able to see, and some calcium also you are able to see it, especially at the 12 o'clock position and coming a much more proximal. Yeah, you are able to see a calcific nodule there, and then the coming much more proximally. Of course, is still come proximally. There is a calcific nodule which is a projecting. It's actually confined mostly to the 11 o'clock to the 3 o'clock, the maximum area. So at this stage, I think according to our algorithm of the calcification, even the simple balloon dilatation with the NC may be good enough, may not be required, even open NC. That's what we thought. What do you think, the other people? Yeah, you can have the whole run. And proximally, we are able to see a thrombus. So it is a thrombotic lesion. In addition to that, the dissections are seen. Come much more proximally. Yeah, you are able to see this red thrombus. And so, what do you think about it? It is a
lot of fibrosis also, Dr. Sarita, in the lesions.
Yeah.
Whether the proximal lesion may be better off with a cutting balloon. What do you think, Dr. Asha?
Yeah, a non-compliant balloon I will go with. If there is some under expansion with the non-compliant, I would go with the cutting balloon. First a non-compliant to get some opening, and if it is does the job, stop there. If not, I would upgrade to a cutting balloon or an angiosculpt. Definitely.
Yeah, the most problem is about the calcific nodule. At least you have the calcification which is present at the deeper or the superficially to the arc. Then it is possible to use these cutting balloons and everything. But calcific nodule is the very thing which is a slippery, and it may not be possible even for the rota sometime to ablate to that. That's what actually the discussion was going on in a shock meeting of the day before yesterday. So, but everyone is opinion is that both the IBL and as well as the rotablation is going to be helpful in the case of calcific nodules, but associated the significant arc of calcium when it is indicated. I thought the NC balloon will do for this, so we took the 2.5. First, we wanted to feel it, how that is the stiffness, but there is a good expansion with a 5.5 balloon, 2.5 balloon, even though it is not the same size of the vessel wall to say that the proper expansion is there. So after this dilatation, yeah, you can have then another run of it. Approximately, you had another run. Not only the calcification is a spotty, it is not so continuous at any time to really to require a calcium modification measures. So all the things are the thrombus is seen. So I think we are quite confident of doing after the balloon dilatation to take up the stent. So we measured the size of the distal segment, which is about the from EL to EL is about 3. So that measures about 2.75. And we took a 33 length to the distal lesion and we deployed. Next one. This is the two views proximally into the distal and from mid to the proximal OCT run. Next. See, after the so many balloon dilatations are also, go back to the previous view. See, there is a flow is not very good distally. And after seeing the thrombus, we started on a Therapy-1 infusion, and without any loading dose, we started an infusion because there is a significant thrombus burden. So what I mean to say it is, whenever you want to do the OCT, make it sure that distal vessel flows are the good. So go to the next. After the removal, of course, after the OCT, the good flow is maintained, and the distal segment is stunted with the at 2.7533 Zines. And next one, please. Yeah, this is the stunted tracking. There is no problem. And deployed the another stunt. Can I have another stunt? Yeah. 338. Give it. Prepare it. Get it. Next. So now we are taking a 338. EL to the how much is the proximal segment length? We got the size. Okay. Then we take the 3.538. So do you people think that it should be ostium should be covered or not required?
Not required. I think on your
Not
OCT,
required.
the ostium was not diseased.
And the OCT, the ostium is okay.
Yeah.
They show the ostial area of the OCT. There is a plaque in the neck. That is an ostium? Then there is a plaque in the ostium. There is very insignificant plaque. Yeah. 6.4. Okay, good enough. So we need not to come up to there. Good. And actually, if you go to the first view scene plus, you see it is like a funnel. There is a significant wide proximal. Yeah, there is almost disease free. Are you in the plain elbow? No, come to the plain elbow. Can I have the stent boost, please? Of course, this is a good view. After the stent boost, it become a very, we become addicted to see the overlaps of the stunts, which is much more frequently told in the BVS BVS era, where exactly the distal end of the next stunt and the proximal stunt overlap should be only the one stunt strut. So this, of course, gives a very good view for us to see that we are having a good overlap or not. Stent boost, are you ready? Yeah.
Maybe come back with the last result of 1 minute from Ziad ma'am, because it's 2 minutes left for the.
Sure. Please go ahead, madam. Please go ahead. Yeah.
Shekhar, just for the last results, we just have 2 minutes for the session left, and then we come back and see the last comments from the chairperson thereafter. Shekhar.
Okay. Yeah, it is exactly the balloon is covered and the thing is come.
Yes.
It is, we are not able to pass the guide because of the spasm. We decided to defer it for another day because I may have to put a provisional stenting strategy into the PDA, distal RCA, and also I need to do a second stent into the PDA if needed. So in view of this, I've decided to defer the procedure to another day. Right?
Sujata, can we just have the picture of your web system?
Ma'am,
Okay,
how is your
can you show
first
the last
diagonal?
2 runs
Yeah.
of the left system, Ramakrishna?
It's not the slightly is not sufficient.
So I already showed you the OCT of the left, and I have showed you the post PCI. This is the left system final runs.
38? No.
So can you show us without the wire pictures? Any
No,
picture?
I don't do without the wire. Yeah.
Ma'am, how is your first diagonal?
Longer children.
Did it start flowing or
3.42.
not?
No, it's not flowing.
Yeah.
Patient doesn't have any chest pain, as I told you, so I've decided to leave it alone. So I'll be doing the RCA in another 2 days.
Only one question from me, Dr. Sujata. When you are dealing with multiple vessels in a thin lady, would you think of taking a femoral approach? That's my, and you have to,
This is another question. See, we are trying for safe PCI procedures. So when we are doing safe PCI, in women who have a higher bleeding risk, it is clearly the radial and all the data from radial safe PCI always say that we should go with the radial strategy. It is okay for me anyway. See, to do it in 2 sittings rather than do it in the femoral approach and then land in problems of groin. So we've been able to do the complex, the left and right, do everything in both the in a what you call tortuous subclavian with the radial procedure. So next sitting we can easily do in the RCA.
any comments from Dr. Asha, Dr. Betty?
I agree.
Would request the chairpersons to please, it's around 2 minutes past 3 to wind up over here, and also wind up the moment we go back to the NIMS, so that we can proceed over to the next session.
Please go ahead, because it's beyond 3. I don't want you to waste your time. Please go for the presentations. Don't wait for us. Please go ahead. Anyway, we are already done than everything. Nothing else to be done. Please go ahead.
Can you just show us the final picture, madam? Can you show us the final picture, madam?
Yeah. Because we want to do the OCT also subsequently, but I don't want you people to wait for that. Test, please.
Yeah, so if there are no further significant comments, and keeping in mind the time which we have to pursue, I would like to thank all the chairpersons, worthy chairpersons and moderators for this session.
And the 2 live case operators, Dr. Shiva, for the excellent cases.
Oh yes, of course, Sarita ma'am. That was so engrossing cases, and so many learning lessons regarding RFR, Corsair, and CTO, and decisions in multiple thrombotic lesions along with the coronary event. So thanking Dr. Betty, Dr. Zakia, Dr. Asha Mehran, and Dr. Mirawat. Any last comments? And then I hand it over to Dr. Sarita for moderating the next session of bifurcation.
Thank you very much. I got to go. I see you guys. Thank you so much.
Hi. Thank you, Dr. Betty, for joining us.
Hi, bye.
Bye-bye.
Okay, nice meeting you girls. Happy International Women's Day. And have fun.
Yeah.
Same to you.
Okay.
So we'll move on to our next session, and that is the bifurcation session. We would like to invite our expert panel. Our expert panelists for this session are Dr. Miroslav Ferenc, Dr. Lim Ing Han, Dr. Mirvat Alisnav, Dr. Cecil Mary Magella, and Dr. Aisha Kader. So without any further delay, we will move to our first talk of the session, which will be by Dr. Miroslav Ferenc. Good afternoon, Dr. Miroslav.
Hi.
Nice meeting you again.
Hi, Sarita. Very good good afternoon from Germany, from Europe. As you know, we have really travels with some war during last weeks in Ukraine, and it's not really a nice time in Europe. We are deeply shocked what happens now in Europe. But let's back to the session. So I think it's a good idea to start with, to push women more in this complex PCI business. If you go to large meetings, you see mainly, I would suggest 80–90% guys, but we know we treat more and more also complex lesions in women. And I would like to share now with you my presentation. I don't know, just a second, should work immediately.
Dr. Miroslav Ferenc is going to be speaking about left main bifurcation treatment based on merits.
Can you see now the pictures? Can you see the pictures?
We can't see your slides.
Okay, but the host should allow me to.
IT support, can you please allow him to share his screen?
Your screen has already been shared, sir. But you need to open your presentation.
It's open already.
I think you need to unshare, sir, once. While resharing, please only select the screen option. Not any other windows, only the screen. Yeah,
yes, so we can see it now. Perfect.
Okay, wonderful. Yeah, I think this is really important topic. And to be honest, I'm working in the cath lab for many years, and in majority of cases, we can manage all left mains and bifurcation lesions very nicely. But all this, in the majority of cases, where I was extremely in troubles, were during PCI in women, to be honest. This make maybe 2/3 of my worst cases scenarios in the cath lab. And sometimes I was really, or many times I was really thinking, what should I do different, or which aspects play maybe more important role in during PCI in women. There's, I think, the point that the vessels are a bit smaller, and in many cases, I personally believe the vessels are more angulated, more tortuous, and especially if you have to treat bifurcation lesions, you have to take much more care. This is, so from my perspective, the point. And you see, we are here placed. Our center is now University Heart Center Freiburg Bad Krotzen. So I study medicine in Freiburg. It's a large university in Germany, one of the largest. And our center is close to Freiburg. So we have in Bad Krotzen, we have 11 cath labs, so altogether we have 15 cath labs and perform around 5,000 PCIs. We have many centers, smaller hospitals, and they send patients to our institution. So we are really in the country area, here Black Forest area. This is very small town, and you see this new complex. If you go inside, it looks very nice. And so this is a coronary unit with around 48 beds. Here's a valves unit and heart failure unit, and here's electrophysiology unit. And this is our spectrum. So we treat a lot of patients who are sent from around Germany to our center. So we do definitely more than 1,000 bifurcations, around 600 to 700 CTOs, and a lot of left main stenting. So that's why I think we do here in majority of cases really very complex subset of patients. And we use also, you can compare this number with your center. We do now in 2022 and 21, we are now close to 20% of FFR usage. And of course, we have to need a CHIP program, Impella program. So if you go to bifurcation, so for many years, we were really very skeptic how to approach bifurcation, because we believe the plaques are localized at the carina region. We know that's not true. In majority of cases, plaques are opposite to the carina, but because we have now more and more older patients with diabetes and renal failure, etc. Now we see more and more diffuse involvement of whole bifurcation area, also including carina. And so it means, we have to know how to manage this difficult anatomy. Earlier, we believed, okay, if we open one vessel, we close another one. But nowadays, we know how to manage this, how to approach such bifurcation lesions. We know how to use second wire. We know how to use kissing balloon. We know now how to perform perfect double stenting. And if we go to left main bifurcation lesions, we will find them in around 3 to 5%. So sometimes patients are quite young, and the point is, so should we send them to surgery, or should we give them the chance going by treat them by PCI? And according to left main stenosis, we should also take a look to the syntax score. And if you have isolated left main stenosis with a low syntax score, so you have green light for PCI and CABG. PCI green light because this method is definitely much less invasive compared to surgery. If you have higher syntax score, and then something between 23 and 32 intermediate syntax score, you can go, but still here CABG will be better. And if you have very complex anatomy, including left main stenosis and much more different stenosis in coronaries, then CABG should be preferred, must be preferred option. If surgery guys say, okay, this patient is too old and whatever, if they don't take them to the table, then we can still approach such patients with PCI. And this is just example to show you. Sometimes you believe, okay, this is difficult anatomy because of this angle, but if you're lucky, you can manage such bifurcation lesions with only one stent and kissing to the diagonal branch and to the circ, and checked by OCT. And in this case was very nice result also by OCT. So you can leave it in such anatomy with one stent. If you have such anatomy with mainly trifurcation lesions, so you usually have to use here double stenting as an option to treat, to stabilize such patients. And don't forget all the patients, and if they have really very severe reduction of LV function, so you should go in such cases also using protection devices, in this case Impella. So then you can concentrate your attention to treatment of this and lesion preparation to the stenosis in the left main. And this is another patient with subtotal lesion in acute coronary syndrome. So it was stenting after patients after stenting, and you see we treated these patients with onyx stent in stent here in this case, and drug-coated balloon for LCX. So this is option if you have wrist stenosis, which can happen and mainly happens in ostial LCX area. It will be not really very useful to go again with second double stenting, so try to manage to use only one stent, and for the side branch only drug-coated balloon. So we will find, if we approach left main stenosis, it's mainly in 80%, mainly distal left main stenosis. And you should also know the plaque distribution, which is, I think, also an important point. In majority of cases, the plaque is going from left main, from distal left main to proximal ostial LAD. This is in around 90% of cases. In less cases, the plaque is going to LCX, and of course, in 60%, a mixture of both. And diameter is also another important point. We have to manage, at least according to the European population, something between 4.0 and 5.75. That makes around 75% of cases, and definitely imaging is strongly recommended. And you have all this on the one slide. You see what we nowadays can do if we approach bifurcation lesions, including left main. You have this first option, which is mainly and mostly recommended provisional side branch stenting. It means you stent the main branch, make kissing if necessary, and that's it. This is a simple approach. If you have to more complex anatomy, and if you see after main branch stenting, there is still a huge problem in the side branch, you can use TAP, T-end protrusion, or you can use culotte as a bailout options. Of course, both technical approaches. You can use it also as primary double stenting treatment, and also you can go with Dickey crush. This means you definitely start with stenting of the side branch, and then follow 11 or 12 different steps. Very complex anatomy, technical approach, and you have to go really one by one step to achieve practically perfect final result. We know from Dickey crush study comparison, Dickey crush versus culotte, there was significant benefit after 1 year for culotte. You see, after 6 months, there was no difference, but after 1 year, difference came. So Dickey crush was better than culotte in left main stenting. Then Dickey crush 5 study, which I would also like to mention here in this session. So there was again benefit for systematic Dickey crush as compared to provisional side branch stenting. So clear message. If we go to left main stenosis, so primary approach could be Dickey crush. And finally, this is approach in Asia mainly, but in Europe, we try to treat still even distal left main using one stent. And according to to our data, we believe, and we know, we have information that in around 70–80% of bifurcations, we can approach them nicely with single stenting. And this is our strategy in Europe. And as you can see, we try still to manage distal left main with one stent and final kissing, final pot. That's clear. And if complex anatomy, then of course Dickey crush can be performed culotte or TAP. And of course, all these post-dilatations plays very important role. And we started in Europe a few years back with ABC main study, and this is the background now. The background was that we don't have clear benefit for systematic double stenting, and even we had some data showing that two-stent approach is even associated with higher all-cause mortality, and that's why we still believe there was also a way to manage left main bifurcation lesions with one stent. And that's why we tried to perform again randomized study, provisional versus double stenting, and of course, Dickey Crush was in double stent arm allowed. It was a single stenting compared with double stenting in around 30 European centers, and we use it exclusively here on Stent. Primary endpoint composite of death, MI, and TLR at 1 year. And why we use Onyx stents, because you have very good access to the side punch. I think this is I think very important point. Even if you have smaller anatomy and smaller stents, and then even more important is crossability point, maybe even in patients who are women. And you can go also with post-dilatation up to maximum 6 millimeters. I think this is important point. We compared provisional with a double stent approach with all the standard steps. And our patients were here in around 70 years, and you see around 80% male, so still in double stenting around a quarter of ladies. And syntax score was quite low, just 22-23%. And as you can see, there is still very good option to treat patients using radial approach and 6 French shift. Of course, here we had a larger number of stents, higher number of stents, and more fluoroscopy time, and procedure was longer if we go with double stenting. Nothing new, it's clear. And important point was, how often do we have to change our strategy from provisional to double stenting? And this crossover was in around 20%. It means even complex anatomy with Medina 111 or 011 can be managed in vast majority of cases using 1 stent. And you see in Europe, we use mainly culotte stenting. This was the preferred approach, and Dickey Crush was only in 5% of cases. And if we have to go to double stenting as crossover, you see again in majority of cases.
Dr. Miroslav, sorry to interrupt you, but we need to hurry up a bit.
Yeah, I will be ready. And this is the final results from the study. And you see there was a very clear benefit for simple approach. However, we didn't reach a significance level. And even in a secondary endpoint, there was no difference between both treatments, and everybody believed, okay, systematic will be much better. But you see TLR rate after 1 year, 6 point versus 9%. So this is the final summary. And in conclusion, so I think we still have very good option to treat bifurcation lesions in distal left with 1 stent. Onyx is one of the preferred stents. And we have to take into account that the procedure time, X-ray dose, and devices we use for this approach are lower if we go with a provisional approach. And this is what we personally in our daily routine now continue to use. Simple provisional approach. If there is a need, we go with culotte or TAP, and only in 5 to 10% we start primary with Dickey Crush. Thank you so much.
Thank you, Dr. Ferenc, for that excellent lecture. There's just a quick question. Dr. Miroslav, in the event that you do use a 2-stent strategy and the patient comes back with an ostial circumflex restenosis, what is your approach? And do you think that there is any role of a drug-eluting balloon at that time?
Yeah. Definitely, we go as a primary approach. We use drug-coated balloon. We use again imaging, maybe to see what is the problem. Is the recoil, or if there only neointhema, huge neointhema proliferation, and if there is a recoil, then we believe then we should know very exact diameter to go with post-dilatation to prepare the lesion perfectly. In some cases, even you can go with a shockwave balloon to crack still some calcified plaques behind. And you can use open OPN balloons also. Check with the IVUS and then go with kissing with drug-coated balloons. We still believe, I can tell you, so from my perspective, there is still a good option and safe option to go with 30 seconds inflation in both branches. So patients mainly accept 30-45 seconds for this prolonged dilatation.
Thank you, Dr. Miroslav. In the interest of time, we will move to our next lecture. I would like to invite Dr. Mirvat Alasnak. Dr. Alasnak is Director of the Cath Lab at the King Fahd University. Dr. Alasnak is going to speak about learning from case step-by-step DK crush. I would also like to, just a quick comment, I would like all of our speakers to please stick to the time because we will be followed closely by the live case session, which is waiting.
So thank you for organizing this session and the initiative, and certainly thank you for the invitation. I was tasked to go over DK crush with you today. So if we look at the background, most of the trials show a lack of benefit associated with systemic two-stent strategies, whether it's the Nordic, BBC1, Cactus, etc. And even when you have a true bifurcation with a large side branch, the EBC2 trial, outcomes may still be worse with systemic compared with, a provisional strategy. And you can see this from this publication in European Heart Journal in 2016, that out to 5 years, you clearly see divergence of the graph. The Medina classification is what we all commonly look at to identify true bifurcations from those that are not true bifurcations. But DK crush itself has actually evolved. And if you look at this, since 2003, people have been talking about crush, which has evolved to a mini crush, and then the contemporary DK crush that we're talking about now since 2013. And more recently, in the last 2 to 3 years, we're talking about a DK nano crush. So without boring you with the details, but this, the previous speaker has already discussed about, the different Medina classifications. DK crush 2 actually looked at provisional compared with DK crush itself, and MACE at 5 years was lower with DK crush as opposed to provisional. DK crush 3 looked at culot versus DK crush and again showed higher MACE at 3 years with culot compared to DK crush. And finally, DK crush 5 looked at target lesion failure at 1 year in patients with left main disease who underwent DK crush compared with provisional strategy. Now, mind you, the DK crush is done by operators who are expert, particularly in Asia. And I don't think many people have the patience for a proper DK crush technique. So what the contemporary DK crush or double kissing, double crushing technique is really about, both vessels are wired. And I think we all agree that irrespective of the strategy, that even if it's going to be a provisional strategy, it's wise to wire both vessels. Both vessels are wired and pre-dilated, and then a stent is positioned and deployed in the side branch first. And usually we resort to this when we have a side branch that's heavily diseased, that is significant or difficult to wire. But we do that with a balloon that is already parked in the main vessel to be ready to actually crush it when necessary. After a proper crush technique, what we tend to do is pull the balloon back and perform a proximal optimization to ensure that we have properly crushed the struts, rewire them, and perform our first kissing inflation. So we've done our first kiss and our first crush at this point. Then we take the stent that's going to be placed in the main vessel, properly sized to the distal reference, and we go ahead and deploy it. Now, some people deploy it with a wire retained in the crush segment. I personally don't do that. Again, proper proximal optimization permits proper rewiring of the side branch. Once the side branch has been rewired, you're able to do a kissing inflation and so this is your second kiss, final pot, and this is what you end up with. So when you're actually crushing, this is a really good animation over here that I'm going to move. And basically what you want to see at this point in time is you're inflating the balloon. So this is a model. Once you actually inflate the balloon in the side branch, after you've actually inflated it, what you do want to see is adequate crush. So this is, sorry. So if we come here, after the balloon is actually deflated, you need to see the crushed struts against the wall. If they're not adequately crushed, means take actually a bigger balloon and you see it right there. So you see the crushed struts over here. So actually I would go with a bigger balloon if I'm unable to rewire this. Once you've actually done and you've well opposed and you've done your proximal optimization, this is what it should look like. This is what, looking through a model, this is what your main vessel should look like, and this is what your side branch should look like. So again, you're wiring both vessels, you are doing your modification, plaque modification in the respective vessels. You've chosen to stent the side branch with some protrusion into the main vessel. Your balloon is already parked in the main vessel, you're crushing, you're doing proximal optimization, rewiring, doing your kiss at this point in time, and then removing the wire. This is what we do. We don't retain the wire. You do proper apposition of the stent, and once you've done it, then you can recross safely and do your kissing inflation. What you saw over here is what we call inflation of the side branch first, and then or sequential inflation in your kiss, but you do end up with a kissing inflation that happens simultaneously, and then your proximal optimization. And again, when you look at model, this is what you should end up looking at: two barrels that look adequately opposed, and you have appropriate scaffolding of your side branch. So this is actually one of our patients who came to us about a decade ago, had a occlusion, chronic occlusion of the LAD that you can see over here from the caudal view. What we chose to do is, fancy cross-boss, etc., and re-entry into the distal vessel with dual injections. And then we ended up stenting that entire segment. If you remember from the original caudal view, the circumflex was patent and it was fine, and all we needed to do was actually stent the LAD. Well, we stented the LAD, but we actually have stent struts, and we tried, it was in an era when we were trying to nail the ostium. Patient did well for several years and then came back again with what you see over here. So at this point in time, what you see is significant stenosis of a segment of the circumflex that was not stented previously, but you actually have overhanging stent struts from the LAD into the left main. And so we're learning from our mistakes as we go along. Your options over here are quite limited now that you actually have a stent over here. One option is to do culotte, given the side branches are relatively similar in size, or a DK crush, which is what we opted to do. So again, parked, both vessels are wired. We have a balloon that's already parked in the LAD left main, and we're, after treating and pre-dilating this segment, we're positioning a stent. We positioned the stent, we deployed it, but what we actually are also doing over here, now you see there are no more wires in the circumflex, and what you see is that we are, in fact, crushing the stent over here. After we crush it, we rewire, we do our kiss, we do our pot, and then we are going to do our second crush over here, where we're overlapping the stent back into the left main and LAD. And then we do proximal optimization before we attempt to rewire. So this is rewiring and then kissing in this still view over here. And we finally end with a proximal optimization, and we end up with these results. So these are the final results afterwards. And this patient actually came to us about 2-3 years ago, and he had chest pain, and we were very keen to make sure we look at the ostium. So these are the steps again, and I'm not going to belabor you with them again, but these are the general concept of how you can do the different stent, different two-stent techniques. It's actually on the early career voice of the American Heart Association, all of them: DK crush, tap, and culotte, etc. But I think what's important are 2 points that I want to mention over here: inadequate crushing and inadequate stent expansion. Many people are fearful of adequate crush. When in experience, when you crush well and you expand your stents well, you're able to negotiate your side branch. What we've learned over the course of time is the role of intracoronary imaging, particularly IVUS, not only in showing you that you have adequate stent expansion and so on, but if you're going to do it to guide the steps of your procedure, you can actually see inadequate crush, which you see here in the B panel. So going from proximal to more distal, the stent struts are not adequately crushed, and this is where you need to complete your crush in order to be able to treat the patient appropriately. So intracoronary imaging allows us not only to do, the standard sizing from trials such as the CRUISE trial and the ULTIMATE trial, but also helps us post-stenting to recognize edge dissections, recognize whether we've done adequate proximal optimization, and so on. But more importantly, as the stent struts and the stent technology is improving, and we're seeing thinner and thinner struts, and we're doing more elaborate procedures like DK crush with multiple steps where you're engaging and disengaging proximal optimization, wiring and not rewiring, there is a chance that these thinner struts end up getting compressed. And so we always have to be cognizant that as you see here in the panel, these are borrowed from Akiko Mehran. You can see that in panel C over here in green, a very well coaxial placed catheter, and you can see the struts that are very well opposed and expanded. But when you look at D, what you see now is the catheter is actually looking at the roof, and you start to see a gap between the yellow part, which is where the stents now are crumped and deformed, and the catheter itself. So what you see here is stent deformation that is apparent in the IVUS run that we see here from the ESC Congress 2021 from Dr. Maero that I borrowed. And so I think, as I mentioned, that the role of intracoronary imaging along with intracoronary physiology perhaps helps us determine whether we do need to treat the side branch or not, helps us determine whether we do need atherectomy or not, because as we treat these vessels appropriately and plan, strategize, the risk of compression, the risk of dissection, the risk of restenosis is lower and lower. And I think I'm going to stop over here and hand it over to Dr. Sarita and the rest of the team. Thank you again.
Thank you, Dr. Alasna, for that amazing talk. And the house is now open for a few comments, a few questions. So from the expert panelists, if anybody would like to ask Dr. Alasna.
Maybe just one comment from my point. I personally have done hundreds of double stentings, and what I can tell you, if we one day would go with a randomized study comparing all these technical approaches, if we use in 100% imaging, and if we would use perfect post-dilatation, really with adequately sized balloons, etc., I personally believe we wouldn't find a difference. I think the crucial point is, as you just mentioned, really go step by step, and lesion preparation and then post-dilatation steps are a most important point. And all the studies with TAP and culotte, I think this point was not done perfectly. What we do now in our center in Germany now is BBK3 study ongoing, comparing now DK culotte with DK crush. And this will be one more interesting study to see which technical approach will be better. I can tell you, I personally believe there will be no difference.
I agree with you. And I think perhaps only two very quick points to recap what you said is, unfortunately, intracoronary imaging was not, it was only in about 40% of both the EBC main and DK crush 5. So I think as we learn more about the role of intracoronary imaging in complex bifurcations, I think we will be seeing better outcomes. Not only does it help us determine strategy in terms of atherectomy and so on, whether it's needed, it'll also tell you whether you need 2 stents or 1 stent. It'll help us determine size, and it will help us optimize at the end. The second comment is about, as you kind of showed in your own presentation, that I think you have to look at the anatomy, you have to look at the syntax score, but you also have to look at the operator experience and volume when we make a determination whether we want a bifurcation strategy or not. It's wise to refer to operators with expertise, because a lot can go wrong in a bifurcation procedure. And it becomes very difficult when it's done wrong the first time, when patients come to you the second time around to see how you can fix it. And I think this is why I use this example, that, you know, a decade ago, we weren't very careful about when we position and target nailing the osteo. But when they do come back, it limits your options afterwards. As opposed to taking a stent all the way back to the osteo of the left main, you have more options afterwards to treat, for example, side branch disease. So I do think operators with experience are the ones that should really be doing bifurcation stenting.
Yeah, you're absolutely right.
Well appreciated, Dr. Alistair. Operator experience always remains an important point when you're dealing with sites such as the left main, which supplies a very large area of the myocardium. And imaging, yes, it is wonderful to have imaging. And unfortunately, in India, only about 30% of our centers have imaging. But yes, it is growing day by day. And it absolutely helps us to get very good results, especially when dealing with left main lesions. So thank you so much, Dr. Alistair. We'll move to our next talk. I would like to invite Dr. Fazila Malik. She's the Chief of Cardiology at National Heart Hospital at Bangladesh. Dr. Fazila, welcome. Dr. Fazila will be talking about bifurcation cases, data, and case-based approaches.
Friends and colleagues, it's indeed a great honor and privilege for me to be here today. I work at the National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh, and we started with a single cath lab in 1999. At present, we have 5 fully functioning cath labs, and we started doing left main PCI on a regular basis since 2007. And by September of 2021, we've done around 2,947 left main cases. Of these patients, 80% were male, the rest female. And regarding the age, around a third of our patients were below the age of 49. If you look at the risk factors, these patients had multiple comorbidities, and 55.5% of our patients were diabetic. Regarding the clinical diagnosis, a third of our patients came with acute coronary syndrome, including ST segment elevation myocardial infarction. The rest was chronic coronary syndrome. Well, as in many examples, for us also, in 81% of our cases, it was distal left main involvement. And for the distal left main cases, in the vast majority, we used a single stent technique. Only in 22.7% of our cases, which comes to 668 left main PCIs, we used a double stent technique. Now, regarding the double stent technique that we have used, the most common for us is still the TAP. We do a lot of DK crush. 30% of our cases was done with DK crush. Next comes culotte, 20.8%, and mini crush was done in 10.8% of our cases. Regarding the diameter of stent used, in 44% of our cases, we used a 3.5 millimeter stent, and obviously we had used stents which could be properly expanded in the left main, and for 26% of our cases, we used a 4 millimeter diameter stent. And in 95% of our cases, it was usually a second or third generation drug-eluting stent. And in 46.7% of our cases, we've used a zotolimus-eluting stent. We have managed to follow up these patients, and some we have been following up from 2007. We've done till date symptom-driven check angiogram for 266 patients. Of these, In 36 patients, we found they had developed ISR. We've managed to follow up our patients. In 2,803 of our patients, we have managed to follow up. 144 patients were lost to follow up, and our median follow-up time is 38 months. 86% of our patients are doing well, and our overall MACE is 9.6%. And over the years, obviously, we have, of course, realized that dealing with a left main can be very tricky. It's a very large vessel. And when we put a stent, we obviously size it according to the distal reference lumen. And so we have to choose our stent wisely. We have to choose only stents that we can properly expand and which will then expand properly and will not leave any malapposition in the left main. So with left main, you cannot make mistakes, as has been alluded by our previous speakers as well. And in left main disease involving both branches, the stent technique should definitely depend on individual patients' anatomical characteristics, the operator's skill, but a provisional strategy may be effective. And we also believe that the left main lesion may be complex, but one should try to keep the procedure simple. Like in this distal left main trifurcation, where the LAD was a CTO, after opening up the LAD, we took a single stent from the left main to the LAD. We did proximal optimization, and one cannot emphasize the importance of proximal optimization for good long-term results in the long term. Our patient tolerated the procedure well. The final result was satisfactory, and the result 3 years down the road was spot on. Now, this second gentleman, this case highlights the importance of imaging and also highlights the importance of preparing the lesion properly. Like in this post-CABG patient, all his grafts had occluded, and so we had to deal with the native vessel. And as you can appreciate, there is significant distal left main disease. The vessels are heavily calcified. His RCA was also diseased. So first we treated the right coronary artery. After treating the right coronary artery, we went on to treat the left. And as you can see, there was severe calcification of the left main involving the proximal LAD. And we had a challenge wiring the proximal part of the LAD because of the huge chunk of calcium sitting there. So we were able to wire with the help of a microcatheter. The wire went down. We changed our run-through wire for our rotor wire with the help of the microcatheter. After this, we proceeded to do rotor ablation because we knew our IVUS catheter would not go. We did a plug modification with 1.25 per. After this, we were able to take our IVUS catheter down. We saw that there was still a lot of calcium, more than 270 degrees. We went on to step up our burr and used a 1.5 per. After this, we again took our IVUS catheter, and we were very happy to see that the LCX surprisingly was free of any significant disease. The ostia of the LCX was free of significant disease. So what we did is, after the proper pre-dilatation, we took a drug-eluting stent, a 4-millimeter drug-eluting stent, we deployed it, did post-dilatation, proximal optimization, and the patient tolerated the procedure well, and we were able to finish the procedure with a single stent. But let's face it, in this part of the world, we see such severe disease, and that's why I think we have to sometimes go for an upfront double stent technique, and DK crush is one of my most favorite upfront double stent techniques because it gives great results, and it works like a recipe. You just follow the steps and you get great results. And Mirvat has done such a wonderful job of showing us how to do a proper DK crush. So today I won't go to a DK crush, but rather let's go to a case where both the vessels were large size. This was a left dominant system. As you can see, the patient had disease in the LAD as well as in the diagonal. Now, how do we tackle this true bifurcation, a Medina 111? And here we see a long segment disease of the main branch. The diagonal is a large size vessel, and we notice a very difficult angle between the LAD and the diagonal. And we don't want to lose this diagonal. So what are the possible strategies? Provisional stenting, maybe not, because if we lose the diagonal, it would not be a very good situation for us. If we go for a double stent technique, maybe we could do a culotte or a DK crush. But what if we did a tap, considering the LAD to the diagonal as the main branch? This way, we avoid rewiring that very challenging diagonal, and we take the mid LAD as the side branch. And that's what we did. So we first wired LAD and the diagonal. Here the LCX was also diseased. We treated that, but that's another story. So we'll focus on what we did for LAD and diagonal. So after pre-dilatation, we took our stent and deployed it very from the left LAD ostium to D2. We did
Dr. Fazila, I'm
yes,
so sorry to interrupt, but can we please speed up a little bit?
Right. We did proximal optimization. And the final result was we did a balloon assisted tap. I won't go into the details. And the final, we did proximal optimization, and this is the final result. We found that there was still a bit of malapposition. We corrected it. And I won't go into the fourth case, which was a culotte, as we don't have any time. So this was also another technique that we can do when both vessels are equal size, both the LAD and the LCX. And this was the final result that we got from our culotte. And the IVUS also showed that imaging is truly important when you do double stent techniques like this. So in summary, I would say that if you don't need to preserve the side branch, then obviously you go with a single stent. But if there's a likelihood of side branch occlusion, then we, first of all, if the likelihood is low, we can try provisional stenting, where we use a layered approach. We can go with a double stent if we need it. And if the likelihood of side branch occlusion is high and we don't want to lose that side branch, we can either choose an upfront double stent technique like the DK crush, or we can do a culotte if the angle is less than 70. And if the angle is more, then we can do a tap technique. And with that, I would like to say thank you for giving me this opportunity of presenting this cases about left main and bifurcations. Thank you.
So thank you, ma'am. It was indeed Dr. Shiba from Ludhiana. It's always indeed a pleasure listening to you. And in interest of time, we would have to cut on for the questions because now we have, yeah, thanks.
Yes,
so I would
actually, excuse me, sorry, I have to also leave. I've got a live case, I think, right after
that's
I'll just go and scrub for that live.
Yeah. So
Okay,
thanks to have you. Bye-bye, ma'am. Yeah, bye. And I would now like to welcome Dr. Aisha. I think Dr. Aisha has got her talk on left main bifurcation, a case-based discussion. All off to you, with request to please maintain the time because we have got another talk by Dr. Annapurna before we go in for the live case. Thanks.
Sure. Thank you very much. And thank you for the opportunity to speak in a panel among people that I respect very much. And as Dr. Ferenc has already alluded to, the left main is a different animal. And the reasons being, of course, that it is not an ordinary bifurcation because there is an extensive continuous plaque extension across the bifurcation with a highly variable and wide angle, which can be amenable to a number of strategies. And also the plaque extension also means that there is a great need for lesion preparation. So in approaching a left main case, I really like this formula that was just recently published by Dr. Goran Stankovic and Dr. Milosinovic on Asian intervention. You have to first think of whether you need to revascularize or not, or if the procedure should be deferred. And this is where intravascular imaging and FFR is particularly useful. Once you've decided on the necessity to revascularize, you then have to figure out if it is percutaneous or surgical. This would depend on the anatomic criteria of the lesion, as well as the clinical context of the patient, and of course, local expertise and experience, as has been discussed previously. Then we would move on to which left main bifurcation PCI technique, which is dictated by the complexity of the bifurcation and can be provisional or upfront, or an upfront two-stent strategy. So the data is continuously evolving, which I will not go into, but we have data from two main seminal trials of the left main bifurcation, that is DK Crush 5 and EBC main, and it's what I will refer to throughout the cases. As for which PCI technique, the provisional strategy or the provisional side branch stenting philosophy, so to speak, has been alluded to by the EBC, where this can also go on to a stepwise layered provisional single stent strategy, where you do a pot, distal side branch rewiring, kissing balloon inflation, followed by a repeat pot. The other is, of course, an intentional upfront two-stent strategy, which is dictated by the complexity, which in turn we can figure out by applying the definition criteria. But on the flip side, we also have these not so complex lesions, which is an 001 or 010 osteal LED or circumflex lesions, which are seemingly not so complex, but difficult to make decisions of. And this is where angiography often underestimates the left main bifurcation and where imaging is particularly important. So in order to illustrate this, this was a case that came to us last year. This was a youngish chap who presented with ACS. And as you can see on angiography, it looks like a 010 bifurcation lesion. But of course, we needed to do imaging. And as we know, more than 90% of cases, plaque localized to the LAD also involves the distal left main. So, which is why imaging has been recommended. We proceeded to imaging and found that indeed the distal left main also involved plaque, and therefore our strategy now turns into a 110. As Dr. Alasnag very correctly alluded to also, angulation is not, nailing the ostium is not encouraged, and indeed this angle particularly is not suitable. If at all, an osteal stenting may be considered in a rectangular angle with a perfect visualization of the side branch takeoff, which was not the case in our patient. And therefore, we proceeded to crossover stenting from the LAD back into the left main after adequate lesion preparation. This was followed then with distal optimization as well as a POT, which is proximal optimization. And once this has been done, we come to yet another unresolved issue, particularly in single stent strategies, that is whether to kiss or not to kiss. And according to this provisional strategy, side branch intervention is recommended whenever the side branch is considered suboptimal, but that is again another gray area. And even in the absence of a suboptimal side branch, we have the issue of floating struts and fenestrated restenosis, which is why really even in EBC main, I guess, POT and KBI were mandated by protocol. However, we know from Nordic 3 that routine KBI did not improve outcomes. We also have registry as well as sub-analysis of Excel data showing that routine KBI did not improve outcomes in 1 or 2 stent strategies. So this remains an unresolved issue also from data from the COBIS 3 registry. But nevertheless, we rewired, did a sequential pre-dilatation, followed it with a final POT. And as you can see, there's a very good angiographic as well as IVUS result. So in such simple left main bifurcation lesions, provisional is a reasonable way to go, but all left mains do not come in the same shape or size. For example, in this 84-year-old gentleman who presented to us with ACS a couple of months ago, he came in complete heart block with an ejection fraction of 50% and anterior hypokinesia. So we put in a TPM, and as you can see, this is very clearly a distal left main bifurcation, ambiguous osteal LAD and left circumflex, which needed to be imaged, but you can also see very clearly there is an osteal lesion in the principal OM, which is another bifurcation. So there's both a left main as well as non-left main. And if we apply this approach, we need to image, we need to consider the clinical criteria in this patient who is hemodynamically unstable and his comorbidities precluded an urgent surgery at the age of 84, which in our part of the world is quite old. And therefore, we then proceeded to percutaneous revascularization. Following adequate lesion preparation, we managed to get an IVUS catheter down, which, as you can see, shows plaque involving the ostia of the LAD and the left circumflex as well. And so in this setting, the question is whether it should be a stepwise provisional. Probably not, particularly considering the fact that the side branch is actually the left circumflex. It's a relevant side branch that needs to be protected because it also gives access to that very tight principal OM, which is supplying a large territory in that area. So the circumflex was not one we could afford to lose, and therefore, considering these double bifurcation lesions, we proceeded for an upfront DK crush. And what was done was the lesion in the principal OM was stented back across the left circumflex into the left main. This was followed by a crush and a kiss, as well as a pot. We then stented the mid diffuse lesion in the LAD, followed this with a left LAD back into the left main with a 3.5 by 30 drug-eluting stent, then did a pot, a final kissing balloon inflation, and a final pot with satisfactory angiographic and IVUS results, which I'll skip on to the last case in the interest of time. Because even among complex bifurcations, not all are the same. And we have spoken of both operator expertise as well as preference and experience. So in this case of a 65-year-old that was referred to us from another center, we can see that there is obvious distal left main as well as left circumflex lesions. There's also a very wide angle, so not the best case for a DK crush, although it's possible. And in addition, there's also some distal, some mid diffuse disease in the LAD that needs to be fixed. So considering this, following adequate lesion preparation, we then proceeded to IVUS as is customary in such cases. And then we stented the mid part of the LAD first, stented back into the distal left main with a 338 from the left LAD back into the left main, because we planned here to do a tap, which is amenable to such a wide angle. This was followed by a pot and then sequential kissing balloon inflation. Then we stented the left circumflex back into the LAD in the tap technique, followed this with a final kissing balloon inflation, a final pot, and a satisfactory angiographic result, particularly considering that the distal part of the circumflex was too diffuse to be intervened on. So I say that not all left main bifurcations are the same. They're different animal, they're also different species. And we know that except for perhaps the strikingly rather low use of IVUS between EBC main as well as DK crush, which is similar, the rest of it perhaps is even looking at different lesions in terms of complexity. So in conclusion, each case is different. Intravascular imaging is important to delineate anatomy, clarify complexity, as well as optimize techniques post-stenting. You need to classify the patient from a clinical as well as anatomic complex. Anatomical complexity would then require application of the definition 2 criteria, which would help us decide on a provisional versus a 2-stent strategy. And last but not least, data from seminal trials perhaps diversify the left main landscape, and it needs to be applied in terms of using different approaches to different lesions. With that, I'd like to thank you for the opportunity, and I'd like to acknowledge our cath lab and my mentors as well. Thank you.
That was indeed a great, please.
Thank you, ma'am. That was a great case. Your view on nano crush technique, ma'am?
That's very interesting. We've only done about a couple of nano crush techniques, but never in distal left main. And this is something that I've asked others on the panel before as well. And many are of the view that you can always miss ostia because nano is a very minute, it's nano to crush. So I don't have any experience with nano crush in the distal left main.
So in interest of time, because we have got another talk and then to start with the live case, I would request Dr. Annapurna's talk to be, Dr. Annapurna Kini's talk to be please played. Rajshekar, could we do that?
Good day from New York. I'm Dr. Annapurna Kini, Director of the Cardiac Cath Lab at Mount Sinai Hospital. Thank you for giving me this opportunity in this debate of ostial circumflex disease. So ostial circumflex disease, imaging guided PCI is my choice. No, I have nothing to disclose. So the case on the debate is a 59-year-old male with significant osteal disease, mild disease of the distal left main and LAD disease. In today's era, imaging-guided PCI is my choice. So the case that I want to show is a similar one, 65-year-old female who had angina class 3 for a few months and underwent a DES of the mid-RCA at an outside hospital and referred to us for high-risk osteal circumflex PCI, past medical history, hypertension, hyperlipidemia, insulin-dependent diabetes, and she had RCA PCI. Medication was Brilinta and other important good medical therapy. So if you see here, initial angiography, not significant disease in the left main. You see a significant osteal disease there. So when you have a left main bifurcation lesion, what are the things you need to take into consideration? Age of the patient, presence of diabetes, overall syntax score, and presentation of the patient. If there is no ACS, was there a significant ischemia on a stress test? Otherwise, you have to do FFR. And once you see just osteal circumflex disease, there are various ways of taking care of this lesion of osteal stenting. You could just do osteal stent itself or a provisional stent from left main to circumflex and then consider a tap if something happens to the circumflex, or you go ahead and do 2 stent technique to begin with. Of course, you need imaging always in left main to understand plaque morphology, maybe for stent sizing, and most important is post-stent optimization as shown by multiple studies. So in this particular case, we did, because of the calcium, we did rotational atherectomy here, 1.5 bar. After rota, this is how it looks. And then we had to do a cutting balloon, which was a 3.25 Wolverine, followed by we did a provisional stent where we did a 3-5-12 synergy stented across from left main to circ, proximal optimization followed by kissing balloon, and this is how the final result looks. This was the IVUS of left main as well as to LAD, left main to circumflex, and this is where we saw that there was no malapposition, no stent edge dissection, and good lumen after the stenting. This is the final angiography as you see here. So the randomized trial, if you go to left main lesions, has been a DK Crush 5 trial, which has been published if there is a simple left main lesion or a complex lesion. So as an interventionalist, it's very important for us to identify which are those simple lesions and which are the complex lesion, as shown here, presence of lesion in left main, as well as the side branch, the angle of the side branch, the calcification, as well as the percent diameter stenosis. All this have to be taken into consideration. So if you did in simple lesion, provisional stenting was the way to go. But very important is that close to half of the patient, even in the provisional stenting group, required additional stenting of the side branch, and that included even in the simple lesion. So as interventionalists, we have to be very clear which group of patient that we need to identify needs a simple provisional stent technique. Why? If there is a bailout stent technique, then the likelihood of having complication is very high, especially high rate of stent thrombosis in this group of patient. So this is our group. We showed from Excel trials subgroup where we showed that even if you do provisional stenting versus in a double stent technique, that final KBI is not essential. But very important, the message is that if you do single stent technique or double stent technique, final KBI was not essential. And doing left main, experience does matter. So if this particular paper showed that people with high volume center where operators did more than 25 left main procedures a year had a lower outcome. And we all know several papers have shown that IVUS guided imaging had a better outcome, especially if you're doing left main stenting. So we just released this Bifurcate 3D app to see in patients with left main disease or non-left main disease how to do the PCI with this animation. So if you take this case that I'm discussing today with ostial circumflex disease, what you do is you pre-dilate. Here we did a rotational atherectomy because of calcium. Otherwise, you can take a regular balloon, pre-dilate. Once you do that, you reassess if there's any plaque shift. There was no plaque shift in this case. You go ahead and stent from left main to circumflex. Once you do that, again assess for plaque shift. There was no plaque shift in this case. So you rewire and perform POT first. And whether you rewire before POT or after POT is again left to the discretion of the operator. And after that, you do a final kissing balloon like we show here. Now, you do the stent across circumflex to left main. But then there is plaque shift into the ostial LAD. What do? You recross, and then what you need to do is do PTCA of the LAD. Now we say with the NC balloon, many times NC balloon does not go, you can do a semi-compliant balloon, then followed by a NC balloon. This is how it happens. You perform POT and a final kissing balloon like we are going to show here. This is how a kissing balloon happens. Final angiography looks good. Now, even if you do PTCA, suppose the plaque shift in the LAD does not improve or does not get better, the various way of treating this ostial LAD lesion, what I'm showing you is a tap technique where is an intentional protrusion. A millimeter of the LAD stent is actually sticking into the left main. As we show here, we show you the different color stent. So you see a part of the stent is sticking out. Even in that case, you will do a final kissing balloon. And that is how this case was finally completed. So to conclude, simple left main bifurcation lesion, provisional stenting has to be done. And again, I am underscoring the point that as an interventionalist, our responsibility to identify patients who should get provisional stenting, which means a simple lesion, where it is a complex bifurcation lesion, then to begin with, consider double stent technique. Whether you want to do mini crush, DK crush, culotte, it's up to the operator. So you have to get proficient in any one of these technique. Keep doing this technique few times, and then once you get proficient, just perform this technique, whatever technique you think that you can get good at. And the app that we just released, which is Bifurcate 3D app, which is animation, like I showed you, all these techniques have been shown how to perform this technique proficiently. POT is a must because of the discrepancy of the left main size and stenting. And then, like I mentioned, operator experience is important. So keep doing this, whatever technique you like. And then after having done many cases, you will know how to do it easily. If you're done provisional stenting, also you need to learn what are the bailout technique. One I showed you is tap or culotte or reverse crush technique. All these techniques have been shown in Bifurcate 3D app. Go and look at it, how these techniques can be done. And imaging is a must to make sure there is complete optimization as well as stent opposition in the left main as well as LAD circ, and you should use a stronger duct. Thank you for your attention. And 3D Bifurcate app, like we said, it has just been released, and a guide wire app will be coming shortly. Thank you.
So indeed, it was a great session, and so much to discuss, learn with the changing cases. I would like to thank Dr. Miroslav and Dr. Mirabat Alisnak, Dr. Fazila Malik, Dr. Aisha, Dr. Annapurna Kini, along with our astute chairpersons and expert panelists, Dr. Majella, Dr. Limingham, Dr. Mirabat, Dr. Cicely Majella, Dr. Aisha, everyone. It was indeed a great session, but in interest of time, because we have a live case already lined up, we have to move ahead. We are doing 10 minutes late. Again, a big thanks and a great gratitude for making this symposium indeed an academic feast. Thank you so much. Thanks.
Hey, thank you, and all the best. Greetings.
Thank you.
Bye-bye.
Bye-bye, sir. Thank you. And we move over to the next session. I would like to welcome the moderators for the next session, who are none other than Dr. Roxana Mehran and Dr. Natalie Pinella. Would also welcome the chairpersons for the next session for the live case, Dr. Rajeshwari Nayak, Dr. Aisha Seder, Dr. Mashadi Mahapekar, and Dr. Sujata. She did a great case just now. We saw that, and we hereon move on to the next live transmission from Apollo Hospitals, Indore.
Deflated? Okay, give me a test. Yeah, okay.
Actually, we are thankful to the Dr. Roxana Mehran because of the early hours and she agreed to come to help us. Really, thank you very much, Dr. Roxana Mehran, please.
Thank you so much. It's wonderful and a pleasure to be with all of you. And welcome, Dr. Rao and colleagues.
Hello, I'm Dr. Sarita Rao, Senior Intervention Cardiologist, and I work at Apollo Hospital, Indore. So this is our cath lab where we do all our cases, and we are the pioneers in rotablation, intracoronary shockwave lithotripsy, and TAVI procedures in Central India region. So this is the console room of our cath lab, where we have performed more than 20,000 procedures in the last 10 years. And I have done the first TAVI procedure, the first shockwave lithotripsy, the first dedicated bifurcation, stenting in Central India in this lab itself. Hello, everybody. Am I audible?
Hello, good evening. Good evening, Dr. Rao. Wonderful to have you. Please go ahead and present your case. It's really an honor to be here.
Thank you so much, Dr. Mehran, and thank you so much for joining us. It is a real pleasure to have you. So our case, which we have here on the table, is a 55-year-old gentleman admitted with history of chest pain, intermittent chest pain since last 2 years, exertional with fatigue since last 1 year. He's a tobacco chewer. He's had antipsychiatric treatment, consulted outside. He has been diagnosed as CAD angina on exertion, class 2-3. He underwent an angiogram on the 1st of March. His angiogram revealed a 99% subtotal occlusion at mid-LAD with TIMI-1 flow. He was advised an angioplasty to the LAD. His echo has revealed a normal LV function. Ejection fraction is 64%. No wall motion abnormality. Next slide, please. Further, patient is now admitted at Apollo Hospital, Indore for further angioplasty and management on 3rd March. So the diagnosis is angina on exertion, class 2-3. He also has a psychiatric disorder, critical single vessel disease, discrete lesion at mid-LAD. We offered the patient drug-eluting stent and a biovascular scaffold stenting. Patient has opted for the BVS stent. Hence, we are planning to deploy a BVS in the LAD. Next slide, please. Okay, can somebody show me the angiogram? Yes. So this is the angiogram of the patient. Is it visible?
Yes, we see the angiogram clearly. Go ahead, please.
So this was the LAD of the patient. Next, please. At a separate origin. Next, please. Next. Right, so the circumflex and the RCA were free of disease. We are planning to implant a BVS. Now, can you show today's what we have done so far? I have with me in my team, Sister Neha is with me. We have Prem, who's the anesthesia technician, Dr. Vikas, who's the cardiac anesthetist, and Sanjay on the machine. And we have Raj on the OCT console. So we wired it. We've taken an EBU 3 wire it with a run-through guide wire. Next, please. This is a 2x10 balloon. Next. Next. This is post ballooning with a 2x10 balloon. Next. Next. We've taken an OCT run post ballooning. Can somebody show the OCT run, please? Can you focus on the OCT? Yes. So we've taken an OCT run. The distal diameter is 3.25. And the lesion morphology is predominantly a fibrous plaque. There is some deep calcium seen. Proximal LAD diameter is 3.5. The length of the segment is 24 millimeter. There's a small nodular calcium just proximal in the proximal segment.
So really interesting case of this very young man, and we saw the TIMI flow, and I was kind of considering, he presents with worsening angina, it's not an MI. I mean, of course, his enzymes were normal. Is that correct?
Yes, his enzymes were, it was normal, right? It was normal. His enzymes were normal. He presented with worsening angina. He's been having symptoms for the past 1 year.
Obviously, there's some disruption of the plaque, but in my mind, I'm thinking that with such a young guy, that what pharmacology did you use during this?
I couldn't hear your question. Could you repeat that?
The pharmacology, like what did you give the patient? Antiplatelet regimen.
So this patient was given ticagrelor and ecosprin.
Okay, so you did use a more potent agent,
Absolutely.
even though it wasn't an MI, but you were thinking that this is, the patient had TIMI 1 flow. I saw that it was a subtotally occluded vessel and a main vessel, so I agree with that. And then, of course, his ejection fraction is normal. But also the other question is the choice of BVS. Why BVS? Why would you think about BVS here instead of a drug-eluting stent where we have so much data and BVS, we're still unclear about its long-term safety, especially, and also its efficacy?
So that's a very interesting question, Dr. Roxana. So basically, in this patient, the other vessels were normal. One, and he's a smoker. And the second thing is that he's on a long-term antipsychiatric medication. So we weren't really sure how well he would be on his antiplatelet regimen. The second thing is that for the BVS, which we are planning to use, we are planning to use the MERES 100. We have a 3-year data, which is showing absolutely 0% scaffold thrombosis and a TLR of 1.8. And with the MERES 100, we've had very good results in many of our patients. So considering the fact that he's young, he's a smoker, his other vessels are normal, he's on antipsychiatric treatment, we don't know how he'll stick to his antiplatelet regimen. So keeping all these points in, we thought about using BVS. What would you say?
I mean, look, I don't have any experience with any of the BVS in India, so I think you have much more, data for yourself. And I personally am nervous about the safety, the late safety, even if I have some data, but it would be good to hear from all of the panelists. And right now, with your using imaging and drug-eluting stents, the current generation is they're so good. I mean, the stent thrombosis is extremely low. But I'm all for innovation and the next level of thing, and especially in a guy like this. I mean, we have so much data on shortening duration of DAPT, stopping DAPT in patients going to a single antiplatelet regimen. We don't have those kinds of data for BVS. So all the more reason that I would go the other way. But let's hear from the panelists. We have Dr. Shabra. Maybe Dr. Shabra could make a comment. And then we also have many others who are on here, Dr. Verpala, Dr. Nayak, any of them, Dr. Kader. Let's ask Dr. Shabra.
Yeah, surely, ma'am. Your point is very well taken. That is the first thing that strikes our mind. We've had our experiences with the use of Bioresorb, and we've seen empty number of stent thrombosis in the patients who were actually given bioabsorbable folds. But then, as in this patient, as Dr. Sarita is saying, ma'am, do we plan a different antiplatelet regime for this patient? Single antiplatelet would any case be a must, even if it is a BVS. What's your take? Sarita, ma'am?
So no, we are planning a double antiplatelet regimen initially for this patient, because the BVS would take 2 to 3 years to resolve. So for the first year, yes, we are planning double antiplatelet regimen for the patient.
So it remains almost the same as we would do for drug-eluting stent. A single antiplatelet in any case would be needed even for this patient. So agreed, we have enough data on MERES, but as Dr. Roxana is saying, we have that 3 years data with MERES, but yes, I do agree with Roxana. I would also have my concerns, but yes, this is a young patient on antipsychotics, so an individualization of a case is a different scenario.
There's also the very important thing of a patient's choice.
Yes.
So
yeah,
he has opted to go for a BVS.
So yes, individualizing the
I think it's really important when the patient is also making those choices, but we also have to be on top of this. Dr. Han?
Yes, hi. Okay, Dr. Sarita, good case there. Personally, we don't have any experience with the BVS that you're using. So I would just put a drug-eluting stent for this patient. However, you mentioned that there is a psychiatric concern. There's a possibility the patient may not be compliant. I presume there's a possibility patient may not be compliant to antiplatelet therapy, right? But as I know, the current generation DES, we can use short DAPT, 1 month DAPT, followed by single antiplatelet agent. So, well, I guess if you have a lot of experience with the bioabsorbable stent, perhaps, well, that may be the choice for this patient.
Wonderful thoughts, Dr. Lim. And what I would say is that, whenever we adopt any new technology, so the way to go is to try it. The only way that we can, learn about our successes, our failures, would be by trying a technology. And a young patient, rest of the vessels okay, a smoker, I would still be comfortable. I'm in favor of going in for a BVS. Dr. Sujata, your comments?
I'm not comfortable with BVS in this patient because, yes, I agree with all your thoughts that young patient, normal other vessels, but there's deep calcium. I'm concerned about, I would do a cutting in this patient, do a proper expansion. Only when there is proper expansion would I put a BVS. Otherwise, I would be very, very concerned about putting the BVS. I would have chosen a more simple case, just
for a
very,
BVS.
very simple. I mean, it's a little more complex for BVS. That's what I felt.
So we'll move over and I'll just show you. I've just taken, so the MERES 100 comes with a pre-dilatation and a post-dilatation balloon. So we've taken a 3.25 into 10 pre-dilatation lineage balloon that the MERES 100 comes with. And we've just dilated with it. Can you play that?
Is that a non-compliant balloon?
Yes, that's a non-compliant balloon. Can you play the?
And I assume you're going to be using at least the 28 millimeter BVS, is that right? And the sizing, there's a little bit of a tapering of this vessel. I think when you come more proximal, it's a lot larger.
So after the lineage.
Sarita, please let us know when we can move over to the second lab. That's also ready for the. Yeah.
So this is after we've post-dilated with the lineage 3.25. Can you freeze that? This is after we've dilated with the lineage non-compliant balloon.
Dr. Sarita, I just want to know what is the this BVS made of? Do you know the material?
It's made of PLLA and I think I have a slight dissection.
There's a section, I think.
There's a dissection.
Yes. I have a dissection. Can I have the stent?
It's quite contained.
Mm-hmm.
Let's let you work on the stent.
There's some
Let's watch this.
flow in the circumflex.
Dr. Shiva, you okay if we keep watching this, or you want us to go to
I
the
think
lab?
we can switch over to Dr. Fazila and we can come back to Dr. Sarita, ma'am. So,
Dr.
yes.
Sarita, we are going to come right back to you. You could do your
Yeah, I think we'll
implantation.
Yeah,
just,
thanks. So, Shekhar, would you please switch over to the next lab?
We'll be right back to you, Dr. Sarita.
Yeah, sure.
Let's go to the next lab.
Mr. Raj Shekhar, please switch over.
Yes, ma'am. We are waiting for them to turn on the video.
Okay.
Well, if they're not ready, I'd like to go back to Dr. Sarita, putting in the case. So maybe the support group could tell us when the other lab is ready. Let's go back to Dr. Sarita, if that's okay.
Sure, ma'am.
So
Sure.
we can watch it.
It's a live in box by Dr. Han.
Yes, that's right. I have a live in box case to present. Perhaps this is a good time for me to present.
Yes, ma'am.
Okay, great.
Yeah, I'd like to share my screen right now. Okay. Hello, everyone. Thank you for having me here. Very honored to give this presentation. I'm Dr. Lim Ing Han from Singapore. I work in Mount Elizabeth Hospital. So I have here a bifurcation case that I'm presenting, a 59-year-old Chinese female. She had angina for many years and presents with rest angina. Her coronary risk factors are hypertension and hyperlipidemia. She does not smoke, does not drink. ECG shows poor R wave progression. Echocardiogram shows a poor depressed EF with anterior wall hypokinesia. A nuclear scan was done showing viable myocardium. A cath was done in a regional hospital and showed left main disease and patient refused bypass, which is why we did a nuclear scan as well. She is, at the point that she came to see me, she was on optimal medical therapy. She was on dual antiplatelet therapy, Entresto, beta blockers, and statins. So here we see the angiogram for this patient showing a left main disease with Medina 111 lesion and a very tight osteal circumflex disease and calcified proximal LED disease. If you look at the AP cranial view, she also has a bifurcation lesion involving the mid LED and a very large diagonal over large D1 in a Medina 111 fashion. The RCA is free of disease. So here we have a 59-year-old female who is non-diabetic, comes in with rest angina, and she has depressed ejection fraction but viable myocardium. She has two bifurcation disease, one involving left main and one involving the LED and a very large diagonal. So the patient actually refused the bypass operation and comes as a second opinion case, and she requires revascularization. The strategy chosen is upfront two-stent strategy for the left main. As for the bifurcation disease and the diagonal, it is also upfront two-stent strategy because of the large, significant large diagonal that she has. Because this is a high-risk case, we decided to go for right femoral artery access with a 7 French XB 3.5 guide. There was also a discussion regarding whether there was a need for balloon pump support during this case, but the patient was hemodynamically stable at that point, and so that wasn't done. So with the left main engaged with the 7 French guide, BMW wire was placed in the LED. However, we experienced problems wiring the left circumflex. With the help of a crusade catheter, I was able to put filter XT wire in the left circumflex after about 20 minutes, and this was exchanged out for a workhorse wire. A Sion wire was placed in the diagonal. So first, I went ahead and performed bifurcation PCI to the diagonal LED lesion. The diagonal was pre-dilated with a 2.5/15 compliant balloon. As you can see over here, the lesion was pretty soft in the diagonal. The LED lesion was pre-dilated as well. And this is the angiogram post lesion preparation. This is a stent was placed, a 275/38 stent was placed in the LED distal to the left main bifurcation and covering, and to the distal LED covering the abnormal segments of the LED. Sorry. Okay, following this, the diagnostic shots reveal that the diagonal branch is heavily pinched, and at this point, a proximal pot was performed to the proximal segment of the stent in the LED before exchanging the BMW wire into the diagonal. So a lot of times we have to be very careful with this technique because we do not want to pass the wire underneath the stent struts in the proximal part of the stent. A 2.5/15 balloon was used to prepare the ostium of the diagonal, and a stent was placed, positioned in this angle in the diagonal, and the stent positioning is important. Many views have to be used to ensure that the stent is placed just into the LED without missing the ostium of the diagonal. The LED was further post-dilated to prepare to post-dilate the stent, and kissing balloon was performed in the diagonal LED lesion. Final pot was performed as well. Okay, so this is the LED diagonal lesion after the bifurcation stent using the tap technique. IVUS pullback was performed, showing that there is residual lesion in the mid to distal LED, which is slightly calcified. This would be post-dilated again later. And over here, you can see the wire coming in from the diagonal and the size of the stent in the mid LED. And here is the IVUS pullback into the left main, showing moderate calcification of the ostial LED before going into the left main. IVUS pullback was also performed from the left circumflex in preparation for the left main stent, showing severe disease in the ostium of the circumflex. It's a very short lesion within the circumflex. That's a wire coming in from the LED. So the upfront two-stent strategy chosen is again the TAP technique for the left main LED bifurcation lesion. 2515 balloon was used to pre-dilate the circumflex, as seen over here. The LED is the osteo LED is also pre-dilated with a 3015 balloon. A 40 by 22 millimeter stent is placed from the ostium of the left main to overlap with the stent in the proximal LED, as shown. Pot was performed before rewiring the circumflex. Circumflex ostium is pre-dilated with 2515 balloon, and the stent was placed in the 30 by 12 stent was placed in the ostial circumflex. The ostium of the circumflex was further post-dilated by pulling back the stent balloon to high pressure. And this is quite important because most of the restenosis usually occurs in the ostium of the left circumflex or the ostium of the side branch after stent implantation. Double kissing was performed in the with a 30 by 15 NC balloon in the LED and a 30 by 12 NC balloon in the left circumflex. Double kissing sometimes can be performed again at higher pressure if the stent is not seen to have opened up completely, and that is very important to do a proper double kissing before following up with a pot. The pot is important. The balloon for the pot procedure is really important to make. We're supposed to make sure that it does not crush the carina, so a short balloon is used. This is the final picture, and the pullback. The IVUS pullback shows from the LED shows an adequately sized stent. That is the junction of the left circumflex with the wire coming in. And this is at the left main, showing that the stent is very well expanded and very well placed. Final IVUS pullback shows that the stent is appropriately sized and appropriately positioned in the mid LED. And again, at the level of the bifurcation, the left main and the osteo left main. Measurements show that the osteo LED MLA is 7.89 millimeters squared, osteo left circ is 5.67, and left main 8.69. So based on the publications on the minimum achievable criteria for the MSA, this is an adequately done procedure. So these are the final angio shots of the left main bifurcation. And this is the final shot of the LED diagonal bifurcation. This case was done some time back, so I had the opportunity to follow up the patient at the longer term, which I will present later. But the important learning points for this case is that we should avoid some of the things to pitfalls to avoid are for whichever two-stent strategy that you plan to use, you must know the steps well. You must understand how to prevent and manage technical difficulties. Most bifurcations are Y-shaped and not T-shaped. Side branch ostium may actually be missed, and this is one of the biggest reasons for restenosis or stent thrombosis. So we should try. The other thing is we should try to minimize the metal in the carina, yet achieve good results. One of the things about doing the TAP procedure is whether it is essential to perform kissing before the side branch stent. But for sure, final kissing and pot procedure is really important. For creating the carina, we should also take care to not to protrude too much side branch stent into the main branch. And we should be very careful to understand which stents we're using, because different stents companies manufacture the stents differently. Some of the stents are on the dots on the stent markers, and some are outside, but others are inside. We should also ensure that the ostium of the side branch stent is properly dilated, because this is the most usual site of stent under expansion. And after kissing balloon, we should correct the oval distortion of the stent in the main branch with a report away from the carina. Other considerations are that appropriate stent size needs to be chosen. If you use an undersized stent and post-dilate to a large size in the left main, it can result in foreshortening of the stent or longitudinal compression of the stent. As I said, this patient was done some time back. So this is the echo pre-procedure showing that the EF is low, but post-procedure, 3 months post-procedure, the patient's EF has improved tremendously. On the top panel, we can see that EF in the short axis view, and the bottom panel is the 4-chamber view, showing dramatic recovery in ejection fraction for this patient. The patient came back for review a year later and underwent the CT coronary angiogram to review the appearance of the stent in the left main, showing excellent results. So that comes to the end of my presentation. I would like to say that long-term follow-up of left main PCI versus bypass in terms of death, MI, and stroke has been shown. We have the data, and the reason for increased IDR usually is due to distal left main disease with that results in unplanned revascularization. So in the EBC main, we know that crossover for provisional stent is 27%, and the types of strategy used was either T-stent type technique or Q-lot stenting. DK crush is superior compared to provisional side branch stenting at 1 year and at 3 years. So regardless of which technique that you're using, final kissing is crucial for double vessel stenting, and I would always try to use imaging if it's available. Thank you very much.
Thank you so much for a wonderful, wonderful case, amazing case, difficult case. If you don't mind, we're going to come back to you to ask questions about your case. I really want to go back to the true live case, which is in Apollo Hospital with Dr. Sarita, and then we'll come back to you, Doctor. Beautiful case, incredible case. Dr. Sarita, how are you? How's it going over there?
Good. So can you go back? So we saw the dissection and we decided to go in immediately. Can you go back, back, please, to where we stopped. So we had got to the point where we had dilated with the 3.25 NC balloon, which comes along with the MERES 100. Back, please, back. And then we went in. Yes, next, please, stop. Minus. Next. This is where we noticed the dissection. So we immediately went in with the stent. Next, please. We took a 3.25 into 24. We had measured the sizing across by the OCT. Now the MERES is very interesting because as compared to the absorbed stent, they have 3 sets of markers at the edges. And the distance between the balloon marker and the edge of the stent is 0.1 millimeter. And where you have the RO markers, from there to the balloon edge is 1.3 millimeter. So the stent scaffold actually extends beyond the RO markers. So the absorb had only 1 set of markers. The MERES has 3 sets of markers. Next, please. Yeah. And the way to deploy the stent is also slightly different. So you go up 1, count to 10, go up to 2, then you count to 10, and then you go up to 3, count to 10, go up to 4, and then stop. You wait for about 15 seconds, it comes back to 3. And then you go up counting all the way up to 9. The nominal pressure is 9. We do not go beyond that. After that, the MERES 100 comes with a post-dilatation balloon, which is of a size of 3.5. So after that, deploying the stent,
I don't know, for some
you've
reason,
gone in with the 3.5.
I'm just seeing these slides. I really want to see the angiogram.
Can you show the
I want to see the slides. There we go. Thank you.
Yeah. So now this is the 3.5 balloon, which we are post-dilating the MERES 100 with. Next, please. And then at the proximal edge, the markers give us a great idea where we are. And this is, next, please. Next, please. And then we've taken the OCT run. Can somebody please show the OCT? Raj, can you show the OCT? Yes. You can see those tiny little boxes. So MERES 100 looks like this on the OCT. These boxes usually open up. They're radiolucent at the center. They open up usually after a year when it starts degrading. So this is the MERES 100. It's well expanded. At points, you can see the diagonal and the septal takeoff. Dr. Mehran, what would you say?
Can you
It's
show
really, really
32?
good. I mean, you look like you have really good expansion. I'm just watching the whole thing. You might have, I see a couple of struts just now. I just saw hanging. Maybe you might need to post dilate there a
That's
little
where
bit
the
more.
diagonal and the septal are coming out at that point.
Right there, you see those? Yeah, and then just proximal to the diag. Yeah.
So that's the point where the diagonal is coming out.
Yeah.
Where we can see that.
Yeah, yeah, we see it.
Sarita, can you show 30? At 30, the MSA? At 31, 32 kind of thing, you know?
Raj, can you show it at that point, please?
No, a little more, 30, not 35, Raj. 31, 30, yeah, somewhere here. What is the MSA? 0.3. Okay. Do you want to dilate again?
So
why don't we dilate again?
This area is not covered by the stent.
Oh, it's not covered.
There's no stent there. Yeah, I
There's
think
no
that's
stent
it.
there.
Okay.
You can see, you can't see any of this.
Yeah. So okay, then no issues then.
What I'd like to, as I look at the angiogram, very distal in the distal LAD, I'm not seeing really great flow. I really would like you to have a good outflow for this stent, given what we don't know, which is long-term data on large numbers of patients. I really just have very little to know about this. So can you show us the angiogram now?
Yes, just a second. Can I have some nitro?
Whether you use nitro or you just have to have a better than what we see. It looks almost subtotally occluded very distally.
I think possibly because this was a chronic lesion. If you look at the initial angiogram also, we had very poor flow distally. So I think because it was a chronic lesion, maybe over time, this is going to open up better. Okay, Karni?
It seems as if there is another occlusion down there, no? It's not just, is it just an issue of the flow, or is there another occluded segment down there in distal LAD? Because we never saw a flow across this segment.
No, I saw there was one in the middle. There was a good flow there. There might have been just some embolization. This is a very, I think, rich plaque.
So this was initially post-ballooning with the 2:10. Can see it's a very thinned out segment distally.
Yeah, OCT did not show significant lesion, isn't it? Initially in that
I don't
area.
think she went all the way down there.
I don't think you pulled back that far down.
So I think there's a very thinned out segment distally.
Yeah, maybe you just keep giving some of these, you know, good drugs to keep the distal vessel open. Sometimes I might just bring a very small balloon down there and bring it back up, just a little bit of a dottering. If there was some distal embolization, nothing to do anything.
Are you showing the distal portion? So Raj is just showing the distal portion on the OCT. He was able to take it. He said it's a very small caliber artery. Can you show that distal?
Yeah, so over time, this will grow.
Over time, it will grow. Yes,
There is,
I agree with you.
Fibrous lesion.
Yes.
Okay, great. Wonderful case. Well, I hope that you're gonna, I gotta tell you, I'm very impressed with your, with you wanting to innovate and get into this bioresorbable scaffold, and I'm ready as well. I just would like to see more data. And I think it's always good to talk about that. And especially if you need 2 years of dual antiplatelet therapy in a patient like this, I might have gone to DES, but I applaud you for your work and in knowing the data and really paying attention to what the patient wants as well. And I think that's a really great case. Thank you so much, Dr. Sarita Rao.
Thank you so much, Dr. Mehran. Your words mean a lot to me. Thank you so much.
Beautiful, beautiful work.
Dr. Sarita, can I? Similar case, ma'am. I had a similar patient. It was a young patient. He was around 30, an opium addict with multiple substance abuse, received a bioabsorbable stent elsewhere and presented to me with, after 3 years of having had that implant, and he was re-stenosed. So this time he did have history of non-compliance, and I actually deployed a sirolimus eluting stent, actually, Ziad's expedition. He's doing thereafter fine. It's been now 5 years. So this is around 8 years back. So that was experience with absorb, not with
that's what I was saying. So the absorb was 150 micron stent, and this is 100 microns, which is very close to, for example, if you looked at resolute integrity, which we've been using for so long with excellent results, there is a 91 micron stent. This is a 100 micron stent. Absorb also came with a lot of other issues, like, you have to keep it at a particular temperature, transfer, all these things. So I think the fact that the strut thickness has come down, the fact that we do not need, it can be kept in ambient cath lab temperature, and the fact that we have 3-year data. We're also doing another trial on it, in which our center is also enrolled. And I think we are looking at the future of stents. So
yeah, well, let's see where we look forward to seeing some of the really robust data. Hopefully we'll see this much more. And thank you so much for your work and wonderful job. I want to go back to Dr. Lim's wonderful case just to ask a couple of questions. Maybe what we should do is just have everybody on the panel. It'd be great to have a panel discussion. Double bifurcation, very difficult case, beautiful results. You really showed step by step the use of imaging and how you move forward. Perhaps I think the one thing I wanted to ask you is, did you consider in that LAD diagonal, for the diagonal side, instead of another stent, did you consider drug-eluting or drug-coated ballooning for the side branch? There's some really good data. We're trying to reduce some. I mean, this is wonderful. You got a beautiful result. And when you see that kind of huge amount of work, then you'll tell us how much contrast you used and also what is your plan for dual antiplatelet therapies. All of that in 2 minutes because we want to finish on time.
All right. Yes, great. Thank you. Thanks, Roxana, for your question. So the procedure took a long time for the wiring of the left circumflex. That took 20 minutes, but the rest of the procedure was quite fast. I finished everything in 1.5 hours. So, for the LAD diagonal, as you can see, it was, I did not perform IVUS pullback before I implanted the stent. It was meant to be a provisional, single stent strategy with a bailout if the diagonal is affected. But the diagonal is a very big diagonal. And after the implantation of the LED stent, the diagonal ostium was severely pinched. And I wasn't comfortable with leaving such a pinched diagonal. And the TAP procedure was not too difficult because the ostium of the diagonal was not very calcified. So it just went on pretty straightforward. And so I could then carry on the case with the left main bifurcation stent. You're muted. You're muted.
How much contrast did you use for this?
I cannot access my data right now. I do not know. I don't think it was that much contrast. Yeah.
Okay, we should always record and present how much contrast we used in these, because I think it's important. But there was no CKD or any reason to worry about acute kidney injury with a
No, she was non-diabetic. She was not old, and she was only in her 50s. Yeah.
Good, great.
And this was
lastly, what dual antiplatelet therapies did you use for this patient?
So for this patient, she had aspirin and Plavix for 1 year, followed by aspirin long term. And during the procedure itself, because it was a long, complex procedure, I actually used double bolus integralin for antiplatelet therapy because I was very worried about the multiple stents and the multiple IVUS pullbacks. Other than that, usually I do not check for the 2C19 status for patients, but in this part of the world, the prevalence of that is quite high, up to 30 to 40%. So sometimes for complex cases, I would do the 2C19 test to see whether they are poor metabolizers of Plavix to clopidogrel and decide accordingly.
Wonderful. Are there any other comments before we close? This was really, really gorgeous. Two beautiful cases. So any comments I'd like to hear from all of you? Maybe Dr. Nayak.
Yeah, I just want to ask Dr. Sarita, what is the antiplatelet strategy she's going to follow in this BVS case?
Oh, are we back to me?
Hi, Sarita. A great case, a wonderful demonstration. I just would like to know what is the antiplatelets? How are you going to, strategy for this patient, antiplatelet?
So my plan is to keep him on eccosprin and ticagrelor, like we were discussing earlier, for a year's time.
How long?
I would like to keep him for a year at least. I don't have a very good distal flow over there. I don't have a very good distal runoff. I'm hoping the vessel will grow. I'm hoping that in the future, I might take a check shoot to see how it's running. And for a year's time, at least, I would like to keep him on a dual antiplatelet therapy.
Okay. Good. Well, this is wonderful. It's been a great session. Thank you all. What a great group. I see Dr. Mashadi here as well. So nice to see you. Did you have any comments before we leave? I want everyone to have spoken. Yes. And Dr. Cater as well.
For the side branch, Dr. Han's case, I would have also considered a drug-eluting balloon. At our center, we do use a lot of drug-eluting balloons for side branch, and we do have a very good result with that. And we even have a good follow-up of those cases. I think the future would be going with drug-eluting balloons, especially for side.
It's a great comment, and I think it was just something to consider. Dr. Cater, any comments? Last comments?
Yeah.
Thanks, Dr. Mehran.
Hi.
Well, let's go first to Aisha, and then we'll come back to you, Dr. Khar.
Yeah, sure.
No worries. Thank you, Dr. Mehran. Just a couple of comments on Dr. Lim's case. We would probably have gone directly to ticagrelor because given the amount of metal there was in that, and of course with the data for complex PCI. And additionally, I think you touched a bit about this on your presentation, but I was just interested in the panel's opinion of a pre-tap kissing balloon inflation, particularly given that circumflex was a difficult side branch to access. The kissing balloon inflation before you put in the stent.
All right, can I?
Yes, Dr. Lim, go ahead.
Yes. Okay. So this is as we do more and more of these cases. Some of the cases, if it's very difficult, I would do first. I'll do a pot. I'll do a kissing balloon before implantation of the side branch stent, and then finish off with post dilatation of each of the side branch ostium, kissing balloon, and final pot. So I would like to hear from the rest of the panel what their practice is.
No, I mean, I think you did a great job. You know, no one can challenge the beautiful result you got at the end. So what I loved about your case was how meticulously you used imaging. I just really loved it. You did a great job. Dr. Rashi Khan?
Yeah, I agree with you, doctor, because the imaging was really helpful in madam's case. And I think the results were very great. So whatever was done was perfect.
Excellent. All right. Well, I'm going to come back to you now. So give it back to you, Dr. Chabra. Thank you so much for having me. And congratulations on this Win Cars session. Really an honor to be here. Thank you.
Yeah, thank you so much. I had heard so much about you, Dr. Roxana Mehran, ma'am, but it's really been a pleasure, not just walking you, seeing you and talking and all just academics, but you've been really great moderating this session. It's really amazing and so much more to learn from you, and really an inspiration, and great for us to have you here. I thank you for having. Thank you for having moderated this session in an amazing way, making it so interesting and having involved everybody else. I also thank the performers of the live and live in box case, Dr. Sarita Rao, Dr. Ingham Lim, and of course, all the panelists who have done a great job, Dr. Sujata, Dr. Rashi, Dr. Aisha, and Dr. Mahapekar. So thanks for a great session, and bye-bye as we move on to the next session.
Hope to see you all in person real soon. Bye, everybody. Keep strong. You're all great. Fantastic.
Bye, ma'am.
Thank you. Lovely to see all of you.
Lovely.
Yes, bye.
Yeah. And now moving on to the next session, the session 4 of the day. We have 2 live cases lined up for this. A live case which is coming from NFH Bangladesh, and another live case which is being conducted at the Nizam's Institute by Dr. Jyotsna. So I would like to welcome the chairpersons for this session, Dr. Neelam Kaul, Dr. Rashi Khare, and Dr. Rupa Salwan. And we go ahead and we start with the live case transmission by Dr. Fazila Malik from Bangladesh, NFH. Good evening, ma'am.
Good evening.
Yeah, so it's great to have you all set in for the live case after an amazing academic piece that we've had. Please go ahead, ma'am.
Right. Good evening, everyone. And I'm really grateful that we'll be doing a live case. So today we have a rather interesting live case lined up for you. Let's go to the slides, please. So as you are aware, we are from the National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh, which is a 480-bedded tertiary cardiac care hospital. And we do left main cases fairly quite commonly. And let's go to the patient slide, please. Yeah, so as you've said, we have done already 53,000 PCIs in our 5 cath labs through the years. And we've done left main up till, can we have the next slide, please? So up till December of 21, we have done a total of 3,690 left main cases. So let's go to the patient's history. The patient is a 65-year-old male. He has stable angina. He's diabetic, hypertensive, and he had a previous PCI to his LCX done in 2019. His ejection fraction is 55. And can we see the angiographic pictures? Now, as you can appreciate, he has got severe calcified left main, 70 to 80% stenosis at its origin and distal segment. The LAD is also calcified, 80 to 90% stenosis in its proximal segment, starting from its origin. LCX has a 90% stenosis close to its, just after its origin. And the stent in the LCX, the good news is patent. So with this vessels, the RCA is not that diseased. relatively disease-free. So what would be your thoughts on tackling this case? Right. So very calcified, and you can see the tram track calcification. If we go back to the RCA, to the left picture, please. Can we have a look at the angiographs again, please? Yes. So just have a look. Can you show the picture on the pictures over here, please? We are showing in our live. Yes, please. So just have a look. Very calcified. Severe calcification, distal left main, including the osteo of both the LAD and the LCX, and the calcium extends from the osteo of the left, from the left main up to quite a bit of the LAD. So what would, does the panel want to have any comments?
It's really a very calcified lesion, ma'am. Are you planning for any pre-post PCI imaging?
Yes,
And
the thing is, with this kind of vessel, you would not be able to take your IVUS catheter or your OCT catheter in such a calcified vessel. That's what we have seen over the years. So what we did is we decided to prepare this lesion first, and only after that would we take our catheter. That was the plan. So we are taking our IVUS actually, so let us just go through what we did is, we first did actually rotablation for this patient. We knew that we would not be able to pass our imaging catheter. So what we did is we first wired the vessel with a run-through floppy wire, exchanged the wire with the help of a fan cross for a rota wire, and we took a 1.5 burr. And this is just like 20 minutes ago that we did this. And we did like 5 runs, each run 10 to 12 seconds. They did for plug modification. Now, after we did our rota run, we then went on to prepare the lesion further, because this is how it looks after our first rota run. Then after this, we decided that we really needed to prepare this lesion properly to take our OCT catheter, because we wanted to do an OCT. So we prepared the lesion then with a scoring balloon. This is a scoring balloon, a 2.5 by 10 scoring balloon. And as you can see, we went through the entire tram track of the LAD. Then we took our scoring balloon for the LCX. Now in the LCX, there was a bit of a struggle taking the balloon. And as you can see, there's a wasting, but we went on and we did our scoring balloon dilatation through the LCX as well. After this, we took our OCT. Unfortunately, our OCT right now has decided to play up. And we're really sorry for that fact. So our OCT machine is malfunctioning. This happens, I mean, it's a very unusual event, but we're rather saddened by it. So as we could not do our OCT, we've decided to take our IVUS catheter. So we were just at the point when we realized our OCT machine had conked off. And so we took out our OCT catheter out, and we were just taking our IVUS catheter in when you joined us. So we've just taken our IVUS catheter, and can we have a look at the IVUS, please? So our plan was to do an OCT, but as you can see, we've already done runs with 1.5 rota bar, 4 runs. We've worked with our scoring balloon 2.5 by 10, and now you can see this calcium there in the 12 o'clock position. But we've managed to crack quite a bit of calcium, I feel. So that's like almost more than 2 quadrants, and then it gets even worse. Here the calcium is quite tight, and it's 270 degrees of horseshoe-shaped calcium that you can appreciate. The entire thing is calcified. There's only 1 quadrant where you see some fibrotic plaque, but the rest is 270 degrees of calcium. And you have to understand that we've already cracked this first with the rota, and then with our scoring balloon. Otherwise, our OCT catheter IVUS would not have gone, and the patient could have become unstable. Here also a lot of calcium, 270 degrees of calcium here as well. This is quite a tight portion in the vessel. And so almost here, it's almost napkin shaped calcium. The lumen is quite tight. So we will have to work on this vessel. Even though we've done rotablation, we've worked with the scoring balloon. This lesion obviously needs quite a bit more preparation. And only after we've prepared our lesion properly will we attempt to do here we feel that this patient will need a double stent strategy, an upfront double stent strategy, and we plan to do DK crush here. You can appreciate the calcium here as well. And this is right at the, near the LCX ostia, and we'll soon. Yeah, so you can see the wire in the LCX, can't you? So the wire in the LCX can be seen. The ostia, it doesn't look that bad now that we've sort of opened it up with the scoring balloon, but obviously it had significant 90% disease. And so now we are gently, you can see the LCX wire, and we're moving into the left main now. And this is the left main, one quadrant of calcium. Now we go out. So that was our IVUS run, and we apologize that our OCT didn't work, but IVUS also did a great job of showing us the picture of the and the extent of the calcium. And with this kind of calcium, obviously you do need an atherectomy device, otherwise you might land up in problems. So now we are again taking another scoring balloon, a higher size. So we first took a 2.5 scoring balloon, 2.5 by 10, and now we're taking a 3 by 10 to prepare that lesion even further. Any comments from the panel?
Yes, surely, ma'am. I think it's an extremely calcified lung disease. And as you said that you are planning for, was this patient offered a surgery also, ma'am? What's the protocol in your center?
Well, yes, he was offered surgery as well, but the patient does not want to have surgery. And one of the reasons is that he cannot afford a prolonged rest. He has to, he's planning to travel somewhere. And so he wanted to have a quick fix. And in all part of the world, many patients are very reluctant to undergo surgery.
Ma'am, I would like to ma'am, I think because we had ostial lesions in both LED and the LCX, so IVUS is as far better as OCT.
Yes.
So it's good enough for us.
Yeah.
Even in ostial lesions, we prefer to do IVUS as compared to OCT.
No, for the ostial lesion of the left main, if you want, if you're tackling ostial left main, then obviously IVUS is better than an OCT. But for an ostial LED or an ostial LCX, an OCT would also give you great pictures, wouldn't it? So because you have to have dye, right? So it's with ostial left main that we have problems with imaging, but not with ostial LED or with ostial LCX.
And left main appears to be of good length, no, ma'am? Must be.
Yeah, left main is of a good length, and the ostia is, I mean, it's not that diseased or significant because there's no pressure damping. Can we go to the hemodynamics, please?
Right.
So, and we were actually going very high with our scoring balloon, and you can see, just go to the last picture that we took. So we went with up to 24. We went up to 24 with our 3 by 10. The last scene, please. And as you can see, the balloon has opened up quite nice. So we're quite happy, I think, with the result of a scoring balloon. And actually, you know, I feel more comfortable with scoring balloons than with cutting balloons. I mean, they're less bulky, and you can go up to very high pressures, and they do a phenomenal job. And also, so now what I'm going to do is I'm going to give a bit of nitro. And we're going to start the stenting process. So let's have a look. We don't need any more nitro. Let's have a look with the and seen a picture. Yeah. So I think we've given. So we'll take our first picture after the rotablation and scoring balloons. And as I have said, we've used 2 scoring balloons, first a 2.5 and then a 3. The vessel looks a lot cleaner, doesn't it?
Yes.
Yes, ma'am.
Definitely.
So now I think we, as we've done a fair job of preparing the lesion, let us go for the DK crush technique. And we'll, so let me position the wire first. Can we go to the epicranial, please?
Can we go and visit the second lab also, ma'am? Dr. Jyotsna is also performing.
And yes, yes. So let us work on the vessel and you can have, we'll tell you what we did.
Yeah, surely, ma'am. We'll be back in a couple of minutes. Thank you.
Right.
Mr. Shekhar, could we please switch over to the next lab at NIMS? So are we with NIMS now? Good evening, Jyotsna ma'am. Are we audible? Dr. Jyotsna?
Jyotsna ma'am?
Yeah.
Is it audible, ma'am? 1 second, ma'am. Let me have a word with Pawan over there.
So should we go back to the previous lab by that time?
Sure, ma'am.
Okay, so you take us back and when you're technically ready, just let us know over there. So ma'am, we are back with you. Some technical issues we are facing while connecting to Hyderabad.
Okay, so now what we are going to do is we're going to take you through the steps of DK crush. And as I always say, DK crush works like a recipe. So first of all, we're going to take a balloon. Going to take our stent. We're going to take our stent from for the LCX, and we're going to position the stent in such a way that there'll be 2 or 3 struts in the left main, and we'll position our balloon in the left main. So after that, we plan to position our stent in the LCX and crush it. So the L6 ostium was quite significantly diseased, and distal to it, it was also diseased. So now we are taking a 2.75 by 24 drug-eluting stent for LCX.
Shiva ma'am, we got feed from NIMS ma'am.
Right.
Right. So we'll be seeing you.
Yeah, surely, ma'am. We'll be back in a couple of moments.
Right. Bye.
So good evening, Jyotsna ma'am. Are you ready with your all charged and powered? Good evening, ma'am. Are we audible? Dr. Jyotsna ma'am?
Jyotsna ma'am, you're on mute, ma'am. Please unmute yourself.
Audible to you?
Yes, now we can hear you. Good evening, Dr. Jyotsna ma'am. So all powered and right to go with the next case. We're just coming from Bangladesh.
Yeah, that's good, madam. And thank you for the second opportunity. So the previous case of the RCA went on well. So now what we wanted to demonstrate is the bifurcation lesion with a recanalized vessel. So I would like to ask Dr. Manikrishna, our fellow, to present the case.
Slides. This is 50-year-old male, known case of diabetes from 6 years. He has history of acute coronary syndrome, that is inferior wall MI. On January 2022, he underwent PCI to RCA that was done with 3.5 stent, which was done this year only. Now he presented with typical anginal chest pain of 15 days duration, but his strop was negative and all his Routine tests like renal function tests are normal and HbS normal, 13 grams per deciliter, and all are normal. Echo-wise, he has RWMA, mainly seen in basal septum, and he has mild LV dysfunction and good RV function, and no MR and no pericardial effusion.
So basically this patient had a previous stunting to the RCA, and now he came with changes of the anterior MI, and then subsequently they developed the rest episodes of the angina. And if you see the first angiogram, that is demonstrating a significant lesion in the LAD and as well as the occluded diagonal. And if you see the retrofill of the diagonal, which is a very big vessel, almost the same size of the LAD and almost reaching to the apex. So now I wanted you people to discuss what is the strategy for this. And I will show you for today, to our surprise. In addition to that, we had some other finding. So I would like to have the panel discussion on the what type of the bifurcation we have to treat this case.
Do we have another cranial view, ma'am?
Yeah, please, can you play the cranial one? Test, please. Is that playing? Yeah.
Yeah.
So this is the cranial view, what you asked about it. Test, please.
So it seems to be a large diagonal with a significant distance right from the ostium of the diagonal up till the segment of the diagonal, which is occluded, also appears to be significant in length.
Yeah. So I would like to have the opinion of the panel and how we are going to do this case.
So we have Professor Dr. Ferenc with us, Dr. Neelam.
Yes,
Dr. Ferenc, what would be your view, sir?
Yeah, very good afternoon again. So I think this case is quite complex. We have a double composition. We have bifurcation lesion, which is here in this case. Let's say this is definitely a complex bifurcation because we have occlusion of the large dominant diagonal branch, and we have occlusion. So we have bifurcation and occlusion. And in this case, what I saw, there is some micro channels. So I could imagine you could be able to cross this diagonal branch with field XCR. So first of all, you have to save the LAD, which is here definitely still main branch, and you have to take care not to lose the flow in the LAD, and then using double lumen microcatheter, whatever you like, you could try to go into the ostium of the diagonal branch. My first choice will be Fielder XTR, and then the second one will be probably Gaia second, and then Confianza Conquest Pro. This will be my suggestion.
You think that the Conquest Pro is required for the diagonal? It is with the history of the unstable angina, is a likely possibility that less stiffer wire is going to be helpful or no?
I think I would try to go with soft polymer wire, which is Field XTR with tip load of around 0.67. So you will have a first impression how hard and difficult the crossing could be. And in next way, I would probably try to use Gaia second. What is always important if you have occlusion, the type B of scenario, if you are not able to come antegrade, think about, do you have any chance to cross the lesion from a retrograde way? And there is some, not sure, there is some connection from LAD, because it's not really
it's looking like an epicardial collaterals which are the supplying to the diagonal. Yes, there is a connection from the distal LAD.
So
Yes.
there is a chance. So you have to go here with 7 French guiding catheter XB 3.0 or 3.5. Maybe even 8 French to have option to place microcatheter and IVUS in position if you would have the problem with the crossing. But first of all, I would try antegrade.
Yeah. So the same strategy we thought of. First, we will try to do the antegrade, which is as you suggested. We wanted to take a hydrophilic in wire, but to our surprise, just I wanted to show you what is happened today with a repeat in angiogram. Yeah, please can you play the first one, Tarkar, please?
So sometimes it's possible that after a few days you have flow again, and that's easier.
Yeah, this is the caudal view, which is demonstrating that the left main is okay. There is a mild disease in the proximal circumflex, and the LAD, the proximal LAD and the osteoproximal is okay. After the diagonal, we are able to see the filling defects in the LAD. And this is suggested the partial recanalized vessel. Actually, we thought that in the previous angiogram, we are not certain about, we are not seeing this partial recanalized LAD. Now we are able to see very clearly. Actually, we realized, we thought that it is very easy to wire the diagonal LAD and it is difficult to wire the diagonal. Then we realized that immediately after the crossing in one of the channels, intra-coronary channel, there is no further progression of wire distally. Then we got the doubt, and again we took this view to confirm that the patient has a recanalized vessel. So now I wanted to know your strategies to describe about it.
So you go definitely, you save the LAD with some floppy wire. So then you go with microcatheter and you escalate the wire to Gaia or Miracle, I think. But what do you have, Gaia?
Yeah. Okay, good, sir. We also actually, with the floppy wire is available for workhorse wire for us is a Kogar. So we took the same one. We don't have the softer than that now at present. So we have taken that for the LED. We took the Kogar. Yeah. So please can you play from the beginning? Go back. Yeah. Next view. This is the caudal view demonstrating the significant disease in the proximal LAD. And of course, we are not able to make it out that recanalized vessels, intracoronary collaterals in here. The next view, filling defects. So this is the time where we realize that there is a difficulty in passing, and in the cranial view also is not demonstrating very well, except the caudal view. So the next view. So no, run it. So you can see that difficulty in going through the collaterals, that partially recanalized vessel. Even after going to the lesion site, we are not able to negotiate distally.
Can I make a comment? So you don't have any, you try to get a diagonal branch and you don't save main branch, that's correct?
Okay, we thought that first we can secure the LAD very easily. That's the reason why we started with LAD.
I think first aspect is extremely important. So I would suppose or propose to definitely to place the wire in LAD. If you make this attempt with this wire, you could have also some dissection and no flow in LAD. And then you have really huge, you could have very fast, huge hemodynamic troubles, believe me. And that's why my suggestion will be go for safety first, place the wire in the distal LAD. So if something happens, so you can still go ahead with balloon or stenting, whatever, right? And then try to first and second way, try to get diagonal branch.
Okay. So to our surprise, The next view, scene minus. Minus. Yeah, the minus. Yeah, from the here the way actually we are discussing the time, and we took the balloon support, and the wire was able to go into the septal. Then we are certain that yes, our channel is in the proper place, is communicating to the distal LED, and then with the support of the balloon, next we could go into the distal LED. Next, of course, we could wire. Next, go forward, don't go back. Forward. So we could wire the LED the first. So then we had the doubt that scene minus. When you had the doubt that it's so difficult to wire the LED through the partially recanalized vessels, we thought whether the balloon will give a support to us. But actually, angiocardiographically, what we have seen is only in the proximal, after the diagonal, a small segment of an LED showed that recanalized features. But if you see that balloon, almost it is gone up to the bent area and it is not able to negotiate. So then we were in the doubt whether that channel is in communication with a true lumen or not. So we passed the balloon and the balloon dilated, and we are able to then pass the balloon freely. Then next view. Then we started wiring the diagonal, and which is also is very, very difficult. And actually we are showing you the wire, the film which is already showing the crossing of lesion, but it took nearly for the 10 minutes for us to cross this, and we are able to do with the run through and with the balloon support. We are at that stage now. We are crossing still, and if you want, you can continue here, or you wanted to.
We can go to Dr. Fazila and return to you, ma'am.
Yes, please.
Should we be back to you, ma'am?
Yeah. It's up to you.
Okay.
You want to stay back, or you want to come back?
Yeah, we'll come back to you, ma'am, after having.
Sure.
Yeah, sure. Yeah. So, Shekhar, yeah, we're there. Ma'am, we are with you.
Yes.
So, yeah, Dr. Ferenc is also there. Ma'am had started a case of a very calcified lesion at the bifurcation, and ma'am was on to do a DK crush technique. So ma'am has already done the pre-dilation with the scoring balloon. Yeah.
I need a report, and then I'll report. Right. So let me go through the steps that we have done so far. As you see, we tackled the calcified lesion with rotablation, and then we use scoring balloon first, 2.5, then 3 millimeter scoring balloon. After that, we went to do the DK crush technique here. So we took our stent from left main to LCX, we positioned our balloon, and then we deployed our stent. And this stent, we positioned it in such a way that it was overlapping with the previously deployed stent. We then went on to crush our stent. We crushed our stent, we rewired the vessel, and let me show you our first case. So we crushed our stent. We then rewired the vessel after a proper crush. And if you do a proper job of crushing, rewiring becomes fairly easy. After this, we could take our balloon very easily through the crushed stent, and we did post-dilatation of our deployed stent. We opened up the strut, and then we did kissing. We went up to 12 atmospheric pressure. Here, there was a 3/12 NC balloon from left main to LCX, and a 3.5 by 15 NC balloon for left main to LED. We did our kiss here. After kissing, our stent, as you can see, went very, very easily. We positioned our stent. And as you can see, we've hardly used any dye here. That's what I love about DK crush. You just go on doing it like a recipe. We positioned our stent properly, and then we deployed our stent. And We then pulled back our stent and went up to a higher pressure. And this is where you have joined us again. So we have deployed our stent in the left, from left main to LAD. And now we are proposing to do our proximal optimization so that we can rewire the LCX and do our second case. So we will go a bit further. So we will position our balloon in such a way that it is just at the level of the carina. And now this is a 4/12 NC balloon, and we will go up to higher pressures.
Run that. Run that. I want to see the deeper. You're not even
and we go down.
We will go to RAO 40/40.
So now we are taking, so this is us. Now we will attempt to rewire the LCX. We will take a fine cross and a wire. And if hopefully, as we hope that we've done a proper job of proximal optimization, we will not face a problem. If you want to, and we'll try, let us rewire the vessel. Do you want to have a look now? So this is how the vessel looks at present. So we plan to rewire the LCX and then do our second case report, and we will again attempt to see whether our OCT machine is functioning. If it is, we will take OCT run. If not, we'll again go with our IVUS. And as you remember, with the IVUS, we had 270 degrees of calcium for most of the vessel, and we had like napkin rings also in different parts of the length of the calcified left main to LAD. So very heavily calcified vessel. And I think for a proper atherectomy was required. Otherwise, we would have been in serious problem. So let me first take my micro a bit closer. Right. So first of all, we'll take our wire. I might need to change this wire because this wire was acting up a bit. The wire seems to be a bit. So I take my micro and then I pull back my wire from the LAD. I do it slowly, but you see the head of the wire is a bit weak, so it might not go, but well, it decides to behave properly and it goes. And I do it through the middle strut. Now I'll get my micro out and we'll do our second case. And of course, we have to post dilate the entire length of the stent in the LAD as well, which we will do. So now we take our balloons for our second case. Oh God, we've sort of goofed up, it seems. While we were taking out our micro, the wire also came out. And this is one thing that one should do always when one is using a micro. They should have the fluoro on to see whether the micro, but the micro was behaving so nicely. I thought that it would not be a problem, but it decided to act up. So we will have to take our micro again and have a rewire it again. It went so easily, but unfortunately, while we were taking the micro now, for complex cases, I think instead of using the Nanto technique for micro removal, which we were doing, it's better to do balloon trapping and also always keep your fluoro on. But I didn't do that. So
right.
Let me just take the wire again. Hopefully it will go as it did the other time, and we so put my micro again in position. The last time it went more easily, maybe I need to change the strut. The wire also, as I was saying, is quite weak. So there it went again, and this time I will look. I can do a balloon entrapment, or I'll do the nanto again.
Usually, very important point is to use access support wire for such maneuvers. It will be very helpful.
We use our workhorse wire usually. So this time we didn't lose our microcatheter, and now we'll do our second case. We use a workhorse wire, usually a run through or a Chion blue.
Okay.
So let's take our balloons now.
What is sometimes helpful to use a very small 1.5 balloon just to make a channel and then to cross with large sized NC balloons, because NC balloons are no low profile balloons. They are a bit bulky and there is a problem with the crossing through the strut. So that's why in such options I use usually 1.5. Open the channel, and the next run with NC balloon is quite easy. And
absolutely, I totally agree with you. That is a great learning thing, and maybe we'll have to do that, because I was trying to go with a larger balloon.
One other point is this is a quite large left main, and there is some still option you cross so between struts, you know, the wire micro is going
right. So what I'll do is maybe I can do a report again. I can take out this wire and do a report through the LED. Yeah. Actually, we went with with 4 balloon to up to 20 atmospheric pressure, but maybe I'll take this wire out and do a report again.
Yeah, this is very important point for younger doctors.
We do not want our wire to go under the.
Yeah, not abdominal. Yeah.
You can go. What is really helpful to repeat the pot.
We can repeat the pot
larger
also.
Balloon, higher pressure. Then using the position of the balloon in the left main, you can engage a bit better and more coaxial your guiding catheter. Then you are quite close to the circ ostium, and then try to recross with new, fresh access support wire.
The guide is already engaged into the left main, no, which has been stented. I think the stent is in the somewhere in the mid left main. Am I right, ma'am?
Not sure.
Yeah. The LED stent is somewhere in the mid left main.
Yes. So. So this is a cine just because the wire again went very easily, and we just took a cine with the micro, and it seems like we are in the true lumen. So let's take our balloon again. Otherwise, we're just going to go for the pot again. As this is a live case and we want to finish the case for our audience.
We can come back to you, ma'am. Dr. Jyotsna is waiting for us. So maybe we'll get back to you in next 5-10 minutes. You can take your time and thank you, ma'am. Akash, can we move over to Hyderabad?
Yes, ma'am, done.
Yeah. Dr. Jyotsna, ma'am, we are back with you again. You have to unmute yourself. We can't hear you. Yeah.
Yeah. Am I audible now?
Yes, ma'am, you are audible. Yes.
Yeah. Now, as I already told you that with the run-through wire, we are able to cross the diagonal. Now, I wanted to know your opinion. What imaging we should be helpful for the this partially recanalized vessel as well as to the diagonal? As I feel that OCT is better, but I wanted to know the opinion of other people.
Yes, ma'am. OCT is definitely better images.
Definitely. We are dealing with a bifurcation lesion, and it's in the mid LAD, and OCT should give us apt results, especially when we are talking of recanalized vessel, and we have got a side branch which is huge and coming out. I think Dr. Ferenc would also agree with us. Dr. Neelam is also here.
Yes, I think OCT would be better.
Yeah, but all said and done, we had a tough time in passing the balloon itself. So we tried with a 1.5 balloon to dilate it distally, and now we are taking the OCT. As you're seeing, we are having a tough time to pass the OCT. But of course, this much of the length, we can see whether it is partially recanalized or not. But that doesn't give an information about the whole of the lesion.
Right. But we'll be able to see the passing out of the diagonal ostium and
yeah, it is across the diagonal ostium.
Yeah.
So I think we'll have it run here and see.
May I just ask you the question? So you are trying now to get OCT for LAD, right?
Yeah.
But okay, but your wire in a diagonal branch is now in correct position, right?
Yes, yes.
And did you perform pre-dilatation of this diagonal branch?
The pre-dilatation was done. Please go back to the scene minus.
Because I didn't. So how is the flow now in diagonal branch?
Yeah, scene minus. Yeah. Run it from here. No, previously. Yeah. So there is an angulated branch on the diagonal. We entered into that angulated branch also. Next. Yeah, that was an angulated branch. That is a bigger branch. And we reached to the most distal portion. Yeah, and then we did the balloon dilatations. Show the balloon dilatations. Yeah. We are in the middle of the OCT, sir. Just a minute. We will have the run and then I will come back to that.
Okay, ma'am. Yeah.
So are you ready? Restarting the machine. So I have to take it out? Okay. No, I thought it is occlusive. That's why I wanted to do it fast. Okay, then go back. We can show to them. Patient is an asymptomatic.
I personally believe your position of OCT catheter is not perfect at the moment.
Yeah. So we did the multiple balloon dilatations. You can show it. Scene minus. Minus. Yeah, this is the result in the epicrania area about 20 and the cranial of 38. This is the result in the diagonal. And then we thought that the wire is not in a proper position. Go back.
The wire, yeah, you have to place the wire in the distal main diagonal branch, and
yes,
you are still not in this position.
Correct, sir. So we did it in the proper position. Next views.
Here will be the use of microcatheter will be very helpful. So you go without microcatheter, what I saw, but the use of microcatheter will be much more helpful and
yeah, that's
would
true.
have more additional safety.
I thought if it is balloon support is not sufficient, I want to go. See, sir, this is the next repositioning of the wire into the distal diagonal. We directly and show that. Yeah, next view.
I think you're in right lumen. Yeah, it looks nice. Yeah.
Yeah, we position exactly into the diagonal. You're satisfied, sir? Yeah.
Ma'am, are we switching to NFH, ma'am?
Yeah, in a couple of minutes. Let's just have a look. Akash, just wait. I'll let you know.
So now I think we will have the OCT run now. Let us see whether it is get it or not. D5 should be ready. Guide test. Hands. He has an angina. Does he have the angina? Okay. Yeah, we will see now the OCT run. I'm sure we are not crossed the whole of the lesion, but I think either the information about that we are able to get it. And I wanted to know about the people about the mid LAD. There is another tighter lesion. Would you suggest the coverage from here to that, or otherwise should we take a separate stent for that? Anyway,
to be honest, for the mid part of LAD, probably FFR measurement will be much more helpful and easier.
Okay.
So by the time it is being done, sir, if we have an FFR which is negative for LAD territory.
No, but I have to send it proximally before doing an FFR to the mid LAD. Yeah, see? Or otherwise, then now it will be the proximal tighter lesion will be the affecting the second lesion. Freeze it. Yeah. What is the OCT showing? No. Can you focus on the OCT? Okay. Then run the OCT, please. So this is started from the bifurcation. Yeah. Then that is showing the left main. Then go more distally. Distally, go a little bit more. That is the calcification is seen on the 7 o'clock to 9 o'clock position, and further go. There is a tightest portion which is demonstrating the fibrocalcific lesion. Then next. See, the recanalization is started from here onwards.
It looks like a septal wall in the vessel. It's strange.
Yeah. Exactly like a mesh.
Yeah, exactly.
Yeah. Go. Go further. Go more distally. Okay. So the major thing is it is already proved that is partially recanalized. But I think now it's looking like there is some problem at the mid LAD also. Can we have another view? RAO 40/40? Before tackling this bifurcation, let us confirm that there is no dissection or anything. RAO 40/40. Completely 40/40.
So probably you have to repeat a pre-dilatation in the mid part of LAD and then try to cross much deeper with OCT cathedral. That will be my suggestion in this case.
Okay. Yeah, Sini? Yeah, freeze it. Step. What do you feel? Should I dilate it?
There is a definitely, okay, there is a wire in the vessel, so it makes now a bit difficult to make the right decision, but I think probably you have to pre-dilate this mid part of LAD when the second diagonal branch is approaching, and then to repeat OCT in this segment. Other option will be FFR, and if FFR in the distal LAD will be in the range, then you can leave it, then concentrate to the bifurcation with diagonal occlusion.
I think we will concentrate now on the bifurcation. So we will do the bifurcation first. Yeah. Can I have the RAO caudal view?
Keeping in rest in the interest of time, ma'am, we have to go to Bangladesh. We'll be back to you for the final this thing once the time is done.
Sure. Please, madam.
Yeah,
Please go ahead.
Yeah.
RAO caudal.
Yeah. Dr. Fazila, ma'am, we are with you.
Yes, please. Please. Yes.
Yeah, so we left you when you had wired the circ.
Right. So let me go through it again. So we wired the circ, and after that, can we have a look at the pictures, please? So this is our final shot that we took just now, and we're trying to take our OCT catheter again. So see whether the machine rebooted. So what we did is we rewired the SCX, opened up the strut, and after opening up the strut,
it is there. Huh?
We did a second case. Can we have a look at the second case, please? So this is the second case we did. And this time we did a sequential case. So we went up with high pressures for the LCX, then we went high pressures for the LAD, and then we did a simultaneous case where we went up to 12 atmospheric pressure.
Yeah, very good, Fazila. Very, very good point for teaching point. Which pressure did you use? Did you use 14 atmospheres or 18? Because there are still some people very skeptic.
Yes. So for the sequential, we went up to 18 and 20. And then for the final together, we went up to 12.
Okay, perfect.
And now we did, this is the report. The report we did with a 4.5 by 6 millimeter balloon. And this is the final angiographic shot that we took. And now we have rebooted our OCT machine, fingers crossed. We're trying to take it down again and see whether it works. If the OCT machine does not work, then we will just try to take an IVUS if we have time. Otherwise, you can see that the angiographic view looks fine. The hemodynamics are fine. So can you show the first picture, please? The one that we started with. So this is the first picture that we took. So very calcified, and this is the final result angiographically. So angiographically, from that to this is a vast improvement, but we want to see also whether how it looks in imaging. So we are taking our OCT catheter now. Now, one thing that we need to emphasize here is that with a heavily calcified vessel, it's really important to do a proper job of preparing the bed before we implant any type of stents or take any tools. And that's what we did. So we did it first with the rotablator. We took a 1.5 burr. Our aim was to do just plug modification rather than aggressive debulking. And after that, we took scoring balloons. And we took first a 2.5, 10 scoring balloon, and then a 3 scoring balloon. And and now
Fazila, what was, sorry to interrupt you, I think important teaching point. After rotablator use, what was your intention to use cutting balloon? Do you believe it was definitely necessary? Did you check after rotablator with IVUS? Because it's a costly device, you know, and it's not and bulky, so not always is crossing very easy. Sometimes you could have even troubles. So what was your point of to use, you know, what was rational for you to use on top scoring balloon? There is some data now published. It's a safe approach, but
for me, the decision was here because of the angiographic tram track calcium that I saw. So the calcium was so heavy that I was convinced that here I had just done plug modification. I had not done aggressive debulking. So with the plug modification, I mean, we've done lots of rota cases and we've published it also, more than 300 cases experience. And with us, we feel that, you know, after plug modification, usually you do need a tool. And in our center, we are very comfortable with the scoring balloon. The scoring balloon really does do a great job. And after the scoring balloon, only after using the scoring balloon, 2.5 by 10 scoring balloon, did we take the IVUS catheter. We took the OCT, it didn't work at that time. Now, touch wood, we had getting some images. Let's see whether it works or not. But when we did the IVUS catheter, we found that there was still a lot of calcium left. So then we took our 3 by 10 scoring balloon and again did balloon dilatation with that scoring balloon. After that, we were quite happy and we started our process of bifurcation stenting. Now, can you see our OCT images?
Yes, we can see. I think a great comment from you. I think alternative option to use cutting balloon or scoring balloon in this situation will be to use also what we use in our center is to approach then the next step to achieve much better lesion preparation. The next step will be in our center also to use shockwave balloon, which I don't know if do you have this option to use in your center?
Yes, actually we do have a shockwave balloon, and I think after the rotablation, rotatripsy, we're using a shockwave balloon would have been great, but we didn't use the IVL because of cost issues. That's the main reason. And
that's correct. It's a very expensive device. That's correct.
Yes. And with cutting balloons, the scoring balloons are a lot less expensive than the cutting balloons. That is another reason that we had already spent quite a bit of money on the rotablator. So we wanted to. So this is our You have to be very careful still, because even 2 years back, I saw such huge perforation in the ostium of the LCX from left main to the LCX. There was cut with cutting balloon, and then we had immediately tamponade. So yes, that's another issue after rotabation.
Delicate issue.
Yes. So we've, as you can see, the OCT images, the stent is pretty well opposed, and the ostia of the LCX looks fine.
It's a great job. So I think it's really a master lecture or master live case to demonstrate how important are different steps in lesion preparation, because if the lesion preparation is done adequately and perfect, and then stenting is usually quite easy. And of course, we have to finish with optimal post-dilatations, but then the case is done.
So
thank you.
Looks great.
So can we have the final angiographic view? Please go to the final angiographic view. Yes, so this is our final angiographic view.
Can we see LAO caudal, the spider view, please? One more.
So by the time they take LAO caudal view, now that you had raised a teaching point of how to go in for sequential and ultimate final kissing, sir, would you like to give some tips for our audience?
You mean?
For the sequential kissing and for the final kissing, I mean, how to decide the ATMs as per the vessel size.
You mean me?
Yeah, yes, sir. By the time I'm taking a shoot, yeah.
Very important point. First of all, if you have IVUS images and you can estimate diameter perfectly, you should know the best ratio will be given by OCT. In OCT, it's really 1-to-1. So IVUS can overestimate a bit, but it's minimal overestimation. So you will have your stent. Let's say as an example, your stent 3.0. Use 3.0 stent for ostial LCX and 3.5 for ostial LAD. Then you use 3.0 and C balloon for LCX. 3.5 balloon and C balloon for LAD, so 1-to-1, ratio is 1-to-1. And I think it's a good approach, which we now recommend from European Bifurcation Club, to go to start with a one vessel only, go up to 18, 20 atmospheres, then the second branch, and then finally kissing with then lower pressure, you need something between 12 and 14 atmospheres. And then again, because you have oval shape in proximal left main or proximal segment, and then you have to your final pot make a round shape. And there is some data from Japan demonstrating that the round shape is definitely better according to development of atherosclerosis.
Right. So thank you so much. In interest of time, we are already 8 minutes ahead our session. We can have a final shoot look, Fazila ma'am.
Yes, please. So that was our spider view. But just before we go, we would like
great result, Fazila. Congratulations. Perfect.
Thank you so much.
Very well done, case. Just wanted to ask.
So this is Smita, and this is Lipi. That's Nazmun, and this is Preeti, one of our technicians. But to be fair, we women were here, but we had some great men with us also. So I was saying, behind each great woman or team of women, there are great men. So please, the men come forward. So we had Dr. Abdul Qayyum and Moshe and Motasim. So Moshe is a chief technician. Motasim is a very bright technician. So we had a whole crowd, and actually it's teamwork. But for the International Women's Day, thank you so much for inviting us to do this case.
Thanks for being with us. Thank you so much, ma'am. Dr. Neelam, you were saying something. Though your video...
Though my video is not working, I'm so sorry for that. I just wanted to ask, ma'am, is it your usual strategy to recross using a microcatheter, or sometimes you do it without that also?
I usually prefer to do it with a microcatheter. That's my common practice.
I'm crossing initially without micro, and if I have troubles, then definitely with micro.
So thank you so much. And in interest of time, we'll go back to see the last result of Jyotsna, ma'am, just before we leave. Yeah. So
thank you. Bye.
Yeah. Bye. Thank you, ma'am. Thanks.
Thank you so much.
Thank you. Jyotsna, ma'am, we are back to you before we end the session. We are already running 9-10 minutes ahead. So would you like to show us some final points with the case, ma'am?
But actually, even though we are not finished, but actually we are about to finish, because we are got a good flow in both the LED and diagonal. Now we are going to do the stunting of the both simultaneously with a mini crush. I want to put a stunt into the LED, and diagonal we are going to deploy with the mini crush technique, and then deploy the diagonal LED. That is our plan now to do it. As suggested, mid LED was dilated, and there is not much of the disease in that area, and it is an expansion was full. Because of the significant calcium, more than 2/3 arc of the calcium is seen on the OCT, we had to take a NC balloons to dilate the LED, and there is a long segment disease. So our plan is to do the diagonal stunt deployment with mini crush with a stunt against the LED. Is it acceptable?
From my point of view, congratulations. You was able to recognize huge diagonal branches we can see, and I think this is definitely a case for double stenting. I personally would go approach this case with using Dickey culotte approach, but if you're better skilled in mini crush, it's fine. So I think this is definitely a case for double stenting, culotte or Dickey crush or mini crush. Congratulations from my point of view, and
thank you very much, and thank you for really helping us in each and every step. And I have to thankful to the whole of our team, Dr. Sri Krishna, Dr. Manikrishna, and Dr. Pradeep, and everyone is around, and of course the sisters and technicians. I can't name them because so many of them are there. So
many greetings to you from Europe, and hope to see you soon face to face in Asia. I would like, but yeah, we still have difficult time with COVID.
Thank you very much.
Thank you, great job. Thank you, congratulations.
Thank you so much. Thank you, sir, for a great session. Heartiest congratulations, Jyotsna ma'am, for another successfully performed case. And as we go in live, thank you, sir. Thanks a lot. Would be seeing you more even in future with WinCar's events. And yes, sir.
I would like, thank you, bye-bye.
Yeah, thank you, sir. Bye-bye.
Congratulations.
Bye-bye. Yeah. Thank you. Bye-bye, sir. Thank you, Dr. Rashi, Dr. Neelam, for having moderated this session. And of course, abundant thanks to Professor, I'm not sure if I am pronouncing it the right way. So thank you so much for being with us and giving us such important tips for bifurcation. We learned a lot, and we look forward to further collaborations. And
bye-bye.
Thank you, sir. Bye-bye, sir. Bye-bye.
Thank you so much.
Yeah, thank you. And And now we go on to the next session. And the next session for the day is on structural heart disease. I would now invite upon Dr. Sarita Rao to please come and be a co-moderator for the session. Dr. Jyotsna is still busy with her case. Would also request the chairpersons, Dr. Sujata, Dr. Lalita, to join in for the session. And we have the first talk for the day by none other than Dr. Ruby Satpathy, who will be talking on TAVI in 2022. All off to you, Dr. Ruby.
Thank you very much for inviting me. It looks like you ladies are having a fantastic session. And I'm making sure you can see my slides here. Give me 2 seconds. Can you see it yet? Not yet.
Yes, ma'am. Now your screen has been shared. Please open your presentation.
Well, good evening. And give me 2 seconds here. So great 2 live cases. I was able to attend for the last few minutes here and looked really great. Great job. Okay. You can hear me okay?
Yes, ma'am. You're very clear. Please go ahead.
Good. Okay. So without any further ado, we're going to talk today about TAVI 2022. And these are my disclosures. As you can see, I have had the opportunity of being involved in a lot of these research trials, which has led to the approval of these devices over the last 15 years. So let's start first with the case. This is a 76-year-old female with shortness of breath for 1 year, with hypertension, AFib, CHF, COPD, CKD that you normally see in your practice. She has aortic stenosis, murmur. And let's see if this will play. Perfect. Is it playing for you? Video is okay?
No, ma'am. Your slides
We are not able to
shown,
see your video or your slides. You're not able to see the slides?
No, your slides are not moving, ma'am.
You're still on the first slide?
No, your slides are not visible only.
Slides are visible, but the video is not playing.
Ma'am, it's in the folder, ma'am. We can see WCC TAVI in 2022.
Oh, okay. Hold on.
Ma'am, would you please unshare and share once again, ma'am? And when you share, please click on screen, ma'am.
I did. Let me try again.
Ma'am, right now your screen has been unshared, ma'am. Could you please share once again? Yes, and now we can see the slides, ma'am.
You can see it?
Yeah, we can see the slides. Yeah, from beginning.
Now you can see it?
It's loading, ma'am. No, ma'am. Could you please click once again, ma'am? From beginning, ma'am.
Do you want me, let me unshare and share again, maybe that'll help. Can you see my screen now?
Yes, and now we can see your screen, ma'am. Could you please click on the from beginning, ma'am, or slideshow icon? Yeah. Yes, ma'am. You're good to go, ma'am.
We're good to go now?
Yeah.
Okay, sorry about the technology. Sorry. Again, it's fancy when the technology works. When it doesn't work, it could be a little challenging, frustrating. Thank you for your help. I don't know why it didn't work the first time. But thank you for interrupting. Let me know if you can't see the slide or video at any point of time. So I'm going to go forward. This is where I was, the 76-year-old lady with standard comorbidities that we normally see in our practice. Is the video playing for you?
Yes, ma'am.
Good, perfect. Okay, let's get back to the case then. So this lady has a normal EF. You can see the aortic valve is restricted. The gradient is 25 per mean, and the EF is 60 to 65 with the velocity of 3.25 and the valve area 0.9. So this will fit in our paradoxical low flow, low gradient preserved EF category. So as you can see, she has a very small cavity with a lot of diastolic dysfunction from LVH, which is probably why she wasn't generating enough gradient. She does have MR as well. And you can see there is a lady has mild disease and there's osteodiag. We left that for medical management. This is her CT scan. And I have scanned the pictures of the aortic annulus, the coronary height, and the valve area, and everything looks TAVR doable. She had a little bit small iliac arteries. This is where we discuss, this is our valve conference when we sit down and talk about these cases. Obviously, options are SAVR versus TAVR. But we discussed that she has that mitral regurgitation, and if it doesn't get better, she will most likely need a mitral clip. Eventually, she had a flail P2 segment. But she was not a good candidate for double valve surgery with open heart. Let me see if I can play the video for you. Okay, here is the video. Let me know if you don't see it. Should be playing. So here is a balloon valvuloplasty here. And here is an Edward 26 S3. And this is before Ultra came. As you can see, we're positioning the valve and the coronaries look good. And here is the back in these days, we used to do TEE. So you can see I have a TE probe there. We don't do that anymore. I'll talk about that a little bit. And you can see on the bottom screen here, we have a beautiful valve that's functioning very well. Now the valve area is 2.1. Patient went home, attended a family reunion. 3 months later, we brought her back. And as you can see, I know the topic is not mitral valve today, but just wanted to share with you that she has that flail P2 and she had a mitral clip done. And this is the post mitral clip result. And she's still my clinic patient a few years later and doing well. Let me see if I can play the other video for you. So this is the color with the mitral clip. So that brings us, a few years later, she's doing well, having a good life. Now, who imagined 15 years ago that we'll ever be able to do this stuff? So when we have any new technology, it's always disruptive. Just like nobody thought back in 1993 that wireless would ever work. And here we are doing an international conference showing live cases and visitors from all over the world, thanks to Wi-Fi. And nobody goes to movie anymore because Netflix is here and Uber is here. The taxi service is going down. People are listening to music on their iWatch. So the change is here. This report was written back in 2001. The future of surgery is ablation over excision, image guided over visual, reconstruction without suturing, and access via natural orifice or blood vessel over incision. This is basically what we're doing with TAVR. It started with a napkin story. Dr. Anderson tried this valve in his garage with the surgical valve, as you can see, and with stents on both sides sewing, which basically is a heart team concept right there. And then obviously the animal model and the first human implantation back in 2002 by Dr. Crevier. The first TAVR in the US was in 2005, was done by Dr. O'Neill, who was my mentor. The patient was my clinic patient. I was a fellow at this time. I had the luxury to be part of taking care of this patient. And this is how TAVR looks in 2022. Again, for sake of time, I'm not going to go over all the detailed trial, but on 10 years, we have 8 trials, 8,000 randomized patients. We have studies in inoperable. We started to low-risk patients now. And 7 articles in NEJM, 2 articles in Lancet. You can't even look at any journal now without having few articles about TAVR. I'm just going to touch upon the last low-risk study, partner 3, which basically showed that TAVR was better than surgery in all aspects. And here is all the detailed data. Again, I'm happy to take any questions. So stroke was better, mortality better, rehospitalization is better. Patient goes home, less length of stay. So FDA approves TAVR for low-risk patients. So what I'm going to show a couple cases, which basically illustrates the point how we operated back in 2012 and how we operate now in 2019 and 22. This is a 72-year-old gentleman with hypertension. As you can see, we have gone from 88 to 72 in terms of age, and his STS is 2.86. The other lady that I saw earlier, STS was 8 or 9. And this gentleman got a TAVR. So here is again, a lot of times you can get by without doing BAV at all. Probably 20% of time we do BAV now. It's just, gentlemen, and that you can decide based on the excursion of the leaflets, the valve opening, and calcium distribution. And again, another illustration, a 69-year-old with almost a bicuspid valve, as you can see on CT, it's reverse 1 with moderate AR, STS 2%. And this is a Medtronic valve here. This is a self-expanding platform. As you can see, we like the depth of about 2. You don't want to go too deep, otherwise the pacemaker, the risk goes up. And here is the valve. And coronary access inside we'll talk a little bit later. In next 10 years after TAVR, it was a big topic 10 years ago, but now we know that it's very easily doable and there are some tips and tricks to it. So how does the SAVR versus TAVR discussion in 2022 look like? Obviously, there is a heart team concept here still. We want to make sure we do the right thing for that particular patient. So if patient is high risk, there's no question TAVR. If patient is intermediate risk, STS 3 to 8, TAVR if technically feasible or doable. For low risk patient, STS less than 3, we discussed both TAVR and SAVR, and pros and cons need to be discussed. And again, in my mind, when you're looking at low risk patients, there is a low risk and there's low risk. So there is a 65-year-old who could be 69, like I showed you with STS of 2, who certainly TAVR is better, but if you have a 55-year-old, I think still surgery is the right choice. I think the discussion about surgery with metal valve versus tissue valve is a big topic now. The indications for metal valve, the age cutoff keeps going down. And in our practice, it's almost like only 55 or lower. Anybody above 55, we have these new valves that are designed to have TAVR inside them 10 years later. They are frackable. Inspiris valve, and there are a couple other out there too. We try to do those, and so that when they're 80, they can still have another TAVR inside and don't need to be on the Coumadin. So what are the pros and cons of TAVR and SAVR? TAVR is less invasive, no requirement of cardiopulmonary bypass, easy post-op recovery, less stroke, less renal failure, less AFib. For SAVR, certainly the pacemaker is less, and I'll talk about that again. We're learning a lot. It's much better now than it was 10 years ago. Same discussion, less PVL. Used to be 6 to 8% when TAVR started, and now it's almost zero, non-existent. Durability is always a question. I always talk about not just that particular discussion at that time frame when they're 69 or 65, or more so when they're younger even. But this is called lifetime management of the valve, not just one-time management. When I sit down with patients, I always talk, you're 55, this is what we're going to do when you're 70, when you're 85. So we make the right decision for next 30 years of the patient's life. And again, vascular complication is still at Achilles' heel on the TAVR. Again, much better now, percentage-wise, it's in the 1%, 2%. And most of them are minor, but again, that's another challenge because of the large seat size. So who is not a good candidate for TAVR in 2022? Very young person, like I said, mechanical valve. Again, that age cutoff keeps going down. For our practice, it's more 55 or younger. Patients who have aortopathy, bicuspid aortic valve, it's still a place for mechanical valve or Ross procedure with a repair. Endocarditis, obviously the valve has to come out. The only way to do that is open heart surgery. And again, young people who have multivalvular heart disease, if the mitral or tricuspid, especially not treatable by transcatheter, you should probably pause and see if their surgical candidates get all at the same time. And again, with the CAD, if syntax is more than 20, CABG plus AVR. So the real TAVR discussion in 2022 is not anymore who is a candidate for TAVR. Should we do TAVR on an 80-year-old or 75-year-old? The real discussion with patient and family and amongst physician partners is more, minimalistic approach. How can we get by doing TAVR with less and less heart-line, central line anesthesia? They can go home same day or next day. When to use cerebral protection device? Again, in my practice, should be 100%. Is TAVR doable inside a prior surgical or TAVR valve, and how many times? And what is the durability of TAVR? And again, there is a relation between volume and outcome, and how many centers should be doing, and how many they should maintain from both operator and institution standpoint to maintain the quality. So this is how TAVR looked. Back a long time ago, we were doing TE, general anesthesia, surgical cut down. Again, when we started, we did 60% transepical because the seat size was 20%, 26 French. A lot of yelling and about 4 to 5 days hospital stay, to the point that we're doing all percutaneous. They're going home next day morning, less than 24 hours, and sometimes maybe even later, same day. We did that at the COVID time when we're so bed crunched. Cerebral protection device. Again, I do in my practice 100% of cases. I know that statistical significance and the p-value, there's a lot of discussion on the data, but there's clearly a trend. And in my opinion, if there is something out there that we can reduce even the 0.8 or 1% risk of stroke, why not? So in our practice, we attempt on all. Obviously, maybe 1 or 2% people don't get it because the radial artery spasms or the innominate is very tortuous that we can deploy. This is how the filter looks like. I have a couple pictures here so you can appreciate. We take an aortogram picture coming from the radial, wiring the innominate, first filter goes in, then wiring the left carotid. Again, bovine arch is off level, but I do it all the time. We seem to have almost 30% cases of bovine arch could be filtered fine in them.
Dr. Ruby, in interest of time, could you request you to please conclude it and wind it up at the earliest?
Yep. So, and then we talked a little bit already, the valve in valve shows great results. The durability of the valve still 10 to 15 years, same as surgical valve, more data coming. But that's surely it's more encouraging that it's similar to a tissue valve. So this is what we were talking about, that we did a documentation about who should do it and how many they should do per year to maintain the quality. As I talked earlier, the size of delivery system has gone down. Per close, we're doing more per close versus cut down. The improvement in the valve technology itself reduces the PVL and pacemaker. Cerebral protection device has reduced stroke, and imaging technology has improved so much that I think we were undersizing the valve again unintentionally 10 years ago, but with CT you can plan everything, and that is the main reason why PVL has gone down. TAVR in AR is a topic. I think in 2 years we'll have technology approved for his TAVR and pacemaker. I'll talk one slide here. Vascular complications are much less. Stroke is much less, and coronary obstruction, again, much less because we're better prepared for it. So again, without going into too much detail, as we know, vascular complication is reduced. And this is how cut down look, and this is how on the left side, the people, their groin look after they're done and they're walking in 3 hours. Again, all this curve improvement in the both Edward and Medtronic valve has the repositionable, recapturable, and less pacemaker rate. One thing I would mention that I think the Medtronic all pacemaker rate with TAVR has reduced. The further higher you deploy the valve, less depth, less pacemaker chance. And again, Edward valve and SAVR are about 5%, Medtronic is 10 to 12. But we have understood that if they have baseline right bundle branch block, they have increased risk. I talked about this already. So how to develop a program? Again, that's a topic by itself. I have had the luxury of developing twice now, 2010 in Omaha and 16 in Baptist. Volume is growing fast. This is the Wall Street projection that TAVI will be 12.2 billion market in 2025. And this is how it's going to look like. So I think it is my last slide. At the end of the day, I think we have to remember that patient is the point of care. It's all about patient, and we should do a shared decision making and do what's right for that particular patient. Thank you. And that is my last slide.
Thank you so much. It was indeed an amazing talk. It's always so good to listen from you what's all is happening in the TAVI world, I would say. And any comments from the chair, though we are short of time, but a comment or two?
I think she covered well, Shiva. I think we.
Yeah, I think, yeah. It's always so good to listen
Dr.
to that.
Ruli always does a very good job. Right.
Yeah. So
you all are doing fantastic. Again, I appreciate the opportunity. It's my honor to be a part of this conference and share my expertise. And I'm again so sorry about not being able to do the live kids this.
We will be having that coming year. So
I know
think
a little
we
bit
start
ahead of
with.
time. I just did for our national meeting. I'll be happy to do that.
Yeah, sure. So thank you so much. It was indeed a great case. And with the permission of chair, we can move ahead for the next topic for the day. And that's by on percutaneous tricuspid valve therapies, the new frontier. May I invite Dr. Sridhar Kasturi for the same.
Sridhar is not there on
yeah,
the
I didn't. Okay, then by the time he's
can
able to
move
join.
on to Sir Dr. Srinivas. Dr.
Yeah.
Srinivas is there, I think.
Yeah, right now.
Dr. Srinivas, you're there? Poonam? I think we'll go to Poonam.
Yeah, yes. So Dr. Poonam is there. Dr. Poonam's talk was on TAVR and CAD.
Yes, yeah. I can share my slides with you once.
Yeah.
Can you see my slides?
Not yet, ma'am. It looks like a fresh morning.
We can see her beautiful.
The globe.
Are you able to see now?
Yeah.
All right, here we go. I think that was so better. Okay. Thanks a lot again. I see so many wonderful faces. Dr. Rao, Dr. Chabra, and Dr. Lalita, Dr. Ziad, all of you. Thank you all for having me in this talk today. So I'm going to talk about TAVR and CAD. And these are my disclosures. So I'll start off with this quick case of an 83-year-old man who presented to us with chief complaints of angina, CCS class 3 and NYHA class 3 symptoms of shortness of breath. So he does have CKD and severe aortic stenosis with an aortic valve area of 0.7 and a normal ejection fraction. So this is his RCA, so it looks pretty good, except some mild disease in the mid portion. This is the LAD and Circ territories. And if you can see, the LAD has an osteal 70% stenosis right at the takeoff and some disease very distally. So in this patient, what would you do? Would you do TAVR alone? Would you do a PCI and TAVR as a stage procedure, concomitant procedure? Or would you do a TAVR and, a SAVR plus CABG? So before I show you what we did, I'm going to quickly run through the various subtopics under CAD and TAVR. I'm going to talk a little bit about the prevalence of CAD, outcomes of CAD in patients undergoing TAVR, revascularization if it improves outcomes, and if we're doing revascularization, what is the ideal timing? Now, TAVR, fixing these lesions after TAVR is itself a big topic, and I'm not going to touch upon that today. So frequently we see that CAD and aortic stenosis coexist, and the reasons for that are that two of them share common risk factors. And also they have a common pathogenesis, which involves inflammation, myofibroblastic deposition, and calcium formation, particularly in aortic stenosis. So this is the prevalence of CAD among patients undergoing TAVR from various registries and RCTs. It's about 30 to 80%. And more recently, with the low risk, Evolute low risk in the partner 3 trials, we've seen that the prevalence is about between 20 and 30%. Now, these low-risk trials, we have to remember, had patients with the age group in the 70s, and they do have a longer lifespan. And so though they have the prevalence is lower at the time of these trials, they still have a long lifespan. And so the risk of CAD always remains. Moreover, these trials actually excluded any patients with syntax of more than 22. So more complex CAD were completely excluded, and unprotected left main has always been an exclusion factor. Now, what's the outcome of having CAD in AVR? So on the left is surgical, and on the right is TAVR patients. So among the surgical patients, if you look, this is a group of patients that had aortic valve replacement surgically, and patients who are isolated AS versus AS and CAD. The CAD patients had worse outcomes. Similarly, on the right, among patients who underwent TAVR and had their lesions fixed either before or during TAVR, and were classified based on their syntax score. This is a prospective registry, so high syntax, low syntax, and no CAD. Those with a high syntax, greater than 22, their outcomes were much worse compared to the other two groups. So all this shows that CAD is not good in TAVR patients. And this is a meta-analysis of about 8,000 patients who underwent TAVR. And we see that the one-year mortality is higher in patients with CAD compared to those without. But what about all our registries, multi-center registries and randomized clinical trials? Really, from the registries, we have seen that CAD is an independent predictor of mortality in univariate analysis. But once multivariate analysis was performed, it did not seem to be associated with mortality. So there is not a uniform answer to this. It's probably that the more complex CAD is not good among our TAVR patients. Now, does revascularization improve outcomes in these patients? So from the surgical literature, it's very clear that if patients had 50% or more significant CAD disease, they underwent SAVR and CABG, their outcomes and survival is better. Even at 8 years, the outcomes were better. But we really don't have very many randomized trials. There's only one, that activation trial, which I will show you in a little bit. But this is a meta-analysis that was published in 2017. And there's another one I'll show you in 2019 of multiple patients who had TAVR and PCI before TAVR. So what these show is that there's not really any difference in the one-year mortality, whether patients had PCI before TAVR or not. On the other hand, these patients had a higher vascular complication rate at 30 days. And so one has to be very careful about performing PCI before TAVR in these patients. Again, remember that this is the other meta-analysis that also shows no mortality benefit at 1 year, whether PCI was performed or TAVR alone was performed. Now, this is the activation trial that was recently published, and this trial aimed to look at patients with severe aortic stenosis and patients who had at least one major epicardial vessel with 70% or more stenosis. So the trial was supposed to enroll more than 300 patients for a power of more than 80%, but they stopped early because the enrollment had slowed down. And this is a European trial, predominantly in Germany and 2 other countries. Now, of the patients enrolled, they were randomized 1:1 to get either a PCI or no PCI prior to their TAVI procedure. And their primary outcome was death and rehospitalization at 1 year. And you can see on the left, there's no difference in the outcomes of these two. Again, any bleeding was higher among those patients who actually had PCI. So why the difference? If CAD is bad, then why fixing it is not good for these patients? So the data itself, we don't have very many randomized trials, right? The trial that we had, the activation trial, was stopped early due to enrollment. And these were patients who actually had CCS class 2 or less angina. So patients with greater angina levels were not included in this trial. Moreover, this was not there was no physiology involved. This was all visually 70% or more disease. And we know sometimes that there's more CAD that can be visually not significant, but physiologically could be significant. So that was a drawback of this trial. Moreover, the short follow-up period is the other problem with the trial. Now, the definition of CAD among all these different observational studies has varied. Some said 70%, 80%, 50% even. So it was not uniform among all these studies that we've been seeing. The physiologic assessments were not used, like we talked about, and then the completeness of revascularization was left to operators' discretion, whether they fixed to a syntax score less than 8 or just, it was all based on the operator's interest. And then the endpoints of all these trials were not uniform, and then we need longer-term follow-up. So what if patients got complete revascularization? So let's say their syntax score residual was less than 8. So this is one meta-analysis that looked at complete revascularization, reasonable versus incomplete. So there's the residual syntax score in this group was greater than 8, and in this group was less than 8. And when they saw that there was a benefit to mortality when the residual syntax score was less than 8. And then similarly, these several single central registries that showed that this high residual syntax score, again, the numbers were different in different trials, they were associated with higher 1-year MACI after TAVR. So what do the 2020 ACC/HA valvular heart disease guidelines say here? It's in the second line, that in patients undergoing TAVI with significant left main or proximal CAD with or without angina, revascularization before TAVI is reasonable, and it's a class 2A indication here. What about timing? All right, so if you want to fix the coronary, does timing matter really? Again, we don't have any randomized trials to show that, and this is just one report from 2013 where they compared the timing of the revascularization. They just put together trials that looked at timing of revascularization, and you can see that really there's no difference between stage or combined or TAVR alone. This was another trial that was presented at TVT 2019 that combined data from 3 big centers, and they looked at PCI before TAVR and PCI with or after TAVR, and again, MACI-free survival was similar even after propensity matching. So there is pros and there's cons of doing the PCI before or at the time or after TAVR. And the biggest advantage of doing PCI before TAVR is that the coronary access is easier. And of course, during the actual procedure itself, you can expect less hemodynamic compromise, particularly in very proximal LAD and osteal RCA lesions during the rapid pacing. But the DAP may become a problem because of bleeding. What about PCI at the time of TAVR? This increases contrast loads and procedure time, but also if it was the less complex PCI, then reduces the complications while awaiting for TAVR, and then this need for multiple access is kind of reduced, and then same no risk during the actual TAVR procedure of hemodynamic compromise. And if it's after TAVR, we all know that the TAVR valve sometimes can be a challenge if the appropriate valve is not used, or if there's not enough experience. But later on, treating AS may actually even improve symptoms, removing the need of PCI. But these other problems should be kept in mind. So overall, then I must have confused everyone a lot, but this is a nice article that was paper published in Circ Interventions, where they nicely show that if your CAD burden is much higher than the aortic stenosis, like the valve area says 0.9 or something like that, and then you have triple vessel disease, and consider the surgical approach is really important in these patients, versus if they're not a surgical candidate, then doing the PCI before actually the TAVR procedure. Now, what if the AS is critical or very severe and the CAD is not too bad, then probably doing the TAVR valve first may be the better way to go. And what if there's really non-complex single lesion and then your AS is just severe, then probably you could consider, looking at the activation and the other stuff, probably you could get by with a TAVR and then reevaluate afterwards. So that's just what's in here. So if you don't have significant disease, proceed with CAD, proceed with the TAVR. If you have significant CAD in the proximal vessel, consider PCI upfront. Now you can think about subclassifying a little bit more, and based on the syntax scores, that if the syntax score is their high complex disease, then probably to revascularize them to a residual syntax of less than 8 before the TAVR procedure. So there's some other trials that are going on. One is the Notion 3 and then the FITAVI trial. Notion 3 is looking at TAVR alone versus FFR-guided PCI and TAVR. And FITAVI is looking at angiographically guided versus logically guided PCI in patients undergoing TAVR if they have at least one stenosis of more than 50%. Now, coronary re-access post-TAVR, again, post-AVR PCI rates are not inconsequential. They're anywhere between 2 to 5.7%. And it's really important to understand the valves and how to engage these valves. And I'm not going to go into depth. These are all several papers that have come out. A good paper by UD and group from Mount Sinai was published in 2018, which is really interesting. So in short, I would say the prevalence of CAD is about 20 to 80% in patients undergoing TAVR. And the presence of CAD, particularly more complex CAD, is associated with increased mortality, at least in these observational studies. And there's a need for more long-term followed-up RCTs to determine if revascularization of CAD may improve outcomes. For now, if you're revascularizing, it may be best to revascularize them so that their residual syntax is less than 8. Really no difference in outcome based on timing of revascularization based on what we saw in observational studies. And then there's obviously the need for long-term follow-up studies. So what happened in this patient, our 83-year-old patient, his syntax score was 21, so it was low risk. His ejection fraction was normal. His creatinine was 1.6. So his CC is class 3 angina, so he's not the typical activation trial kind of patient. So just given that it was an osteal LAD stenosis, which will have to be fixed afterwards, we decided to, after a heart team discussion, proceed with the PCI upfront. So he did get the PCI with a low contrast and then followed with his TAVR procedure. So he did get his TAVR valve and he's doing pretty well. So that's it for now, and I'll take any questions.
Did you do both the procedures simultaneously, or you staged them, Dr.
So staged them. He had CKD, creatinine is 1.6, and so yeah, just did the LAD PCI first and then brought him back in 2 weeks.
If it is simple, are you combining both at the same sitting?
We've gone away from combining both, just to keep it very simple and straightforward. And moreover, these days, unless it's a Prox LAD, Prox RCA or something very significant, we're not fixing it before. But we've gone away from doing a combined procedure.
Okay. If the proximal lesion is significant, you protect it and go for the TAVR, or how would you proceed with that?
So if it's a proximal lesion, we are doing the PCI before the TAVR. But if it's not a Prox LED, Prox RCA, or left main, so we just do the TAVR before and then bring them back to clinic and see if they have anginal symptoms. And if they continue to have angina, then we're fixing the coronaries afterwards. So I use mostly the Edwards valve if I'm thinking about, having to fix the lesions later on.
So any other, Sujata ma'am, you have to unmute yourself.
Okay. No, I'm just thanking Dr. Poonam. I thought you were not there, so.
Actually, a brilliant, in a very short time, she has covered almost everything about CAD and TAVR. That was a very nice presentation from Dr. Poonam. Thanks a lot.
Thank you so much.
Indeed, it was
very nice presentation, Dr. Poonam.
Thank you so much.
Shiba, what do you want to do? You want to go to the next session? I don't, Dr.
I think yes, because we are just left for 6 minutes for the next session, and we've actually discussed a good amount of TAVI and CAD and management, and we have our people having performed live cases back into action right on the forum. So we need to look ahead and move on to our next session, I believe. If we have the personnel already online. So if the organizing secretary permits, Dr. Sarita is there, and if she permits, we can go ahead with the next.
Go ahead, Dr. Shiva. Absolutely. We go ahead with the next session. We are just in time for our next session. And I would like to invite our moderator for the next session, Dr. Bhanu Duggal. We are going to have the left main bifurcation session. Our moderators, Dr. Bhanu Duggal. Chairpersons are Dr. Jyotsna and me, and our expert panelists for this session, Dr. Preeti Sharma, Dr. Rupali Khanna, Dr. Aisha Kedar, Dr. Shiva Chabra, and Dr. Priya Kalankar. So, Dr. Duggal, over to you.
Thank you, Dr. Sarita, for giving me this opportunity. And I'm delighted to introduce the very esteemed speakers in this session. And we will begin with Dr. Brilakis, who is the Director of Complex Coronary Interventions at the Minneapolis Heart Institute. He's also the Chairman of Coronary Artery Disease and a leader in complex interventions like CTOs, saphenous vein graft interventions, and leads a large group which carries out cutting research in this area. Over to Dr. Brilakis, please.
Wonderful. Thank you so much. It is a great pleasure to be with you this morning. And I think hopefully you can see my slides right now.
Not yet.
Okay, I'm sorry. So I'm sharing them as we speak.
Yes, we can see your slides now.
Thank you so much. So again, my task this morning is to discuss a little bit about left main. What is the latest evidence and practice for 2022? And I will do this by going through the various steps of percutaneous coronary intervention and how they apply to specifically left main PCI. So planning is key for everything, especially for left main PCI. And one of the key questions is for hemodynamic support, which might be a good idea, especially in patients who have an occluded or heavily diseased right coronary artery, those who have low ejection fraction and high filling pressures. Often the left main lesions are calcified and preparation might be needed. And then, of course, there is a bifurcation in the majority of left main lesions that sometimes might need some two-stent techniques, and often the ostium is involved as well. Because of the ostium being involved, quite often we may have dampening of the pressure waveform. And then when it comes to access, this can be done either through radial or through femoral access, depending on local expertise. If radial access is used, it is often better to use the 7 French guide with a slender sheath or sheathless to get better support and make it easier for treating the bifurcations. And then in terms of engagement, once again, if there is an aorto-ostial lesion, there could be some pressure dampening. And that is why having intermittent guide engagement or having a guide extension might help, or sometimes putting a wire into the aorta, a floating wire, to prevent deep engagement. This is an example of engaging and disengaging the guide intermittently to prevent ischemia that can cause potentially hemodynamic compromise. In terms of angiography, left main is notoriously difficult to assess. If there's arteriosteal disease, it is often important to be careful with injecting hard against the dampened pressure waveform. This is an example of a patient who was actually referred for doing PCI in the circumflex, but then when we did a pressure wire on the LAD, the FFR at the time was 0.75, and on a different projection, we now see that there is a significant left main lesion actually. So it was not a circ, but actually was a significant left main lesion. So doing physiologic assessment using intravascular imaging can help make sure we understand the severity of stenosis in the left main. What do we do for the left main in terms of surgery versus PCI in patients with complex disease, usually with syntax score more than 33? Then bypass is a good option if the patient is a good surgical candidate. For lower syntax scores, then either PCI or bypass can be done. For left main lesions in general, we wire both the LAD and the circumflex, and if there is dampening, it is best to have the wire preloaded in the guide so you can wire right away once you engage the vessel and then optimize the engagement. In terms of lesion preparation, there is often calcification, and before putting stents in the left main, one needs to be sure that there is good balloon expansion. Sometimes a atherectomy may be needed to actually prepare the lesion well. This is an example of a patient who did have heavily calcified lesions in the distal left main and actually required a atherectomy to modify the plaque enough. As mentioned before, about 2/3 of the left main lesions actually involve the distal bifurcation. And that is why bifurcation techniques are important. And also several of them involve the ostium. And when treating the ostium, one needs to make sure we do not miss the ostium by having the stent too deep into the vessel. At the same time, we don't want to have too much stent protruding back into the aorta because this will make the engagement tough. And then sometimes you can have under expansion or stent recoil requiring good radial strength stents. When it comes to bifurcation, the side branch obviously for left main needs to be preserved. It's usually the circ or the LAD. And then if the likelihood of losing the side branch with provisional stenting is low, then provisional is done. Otherwise, a two-stent strategy is used. I personally think the data is best for DK cross, and that's the technique I use for most of the bifurcations. These are some of the trials, the DK cross 3, randomized patients to DK cross versus culotte for left main disease. And actually, there was significantly better freedom from adverse events when there was randomization to DK cross compared to culotte. There's also the DK cross 5 trial that compared DK cross to provisional. And once again, there was better target lesion failure by using DK cross compared to the provisional approach. And this is, of course, done because sometimes you do need to put a stent on the side branch, and that was necessary in 41.7% of the provisional group. The provisional group did have restenosis, and the majority of restenosis was actually at the ostium of the circumflex. So if you had complex lesions, there was significantly better by using the DK cross technique compared to provisional. So based on this, one would think that a two-stent technique is the way to go. However, we were surprised earlier last year because the EBC main, the trial from the EBC bifurcation club, randomized patients to a two-stent technique versus one stent technique, and actually found the opposite from the DK cross 5. What it found is that in about 1 out of 5 cases, you needed to put a stent into the provisional arm. So 80% you did not. But then when you look at target lesion revascularization, stent thrombosis, and the composite endpoint of death MI or TLR, there was the same, whether you got a provisional approach or a systematic two-stent approach. So right now, there is some controversy whether you should go with an upfront two-stent technique or whether provisional is done. And again, it depends on the local expertise and the characteristics of the lesion. Very important for left mains is being able to post-dilate the stent to match the size of the left main. So typically, we put a stent from the left main into one of the branches, LAD and circumflex, and then you want to make sure that your stent is actually able to expand all the way to the diameter of the left main. So some stents can be more favorable for this. For example, the Megatron, the Synergy Megatron, can go from 3.5 all the way to 6 millimeters. So if there's a 3.5 LAD and a 5 or 5.5 millimeter left main, that can easily be done with this stent. These are some examples from some cases. So this is a patient who has distal left main bifurcation technique, but the ostium of the side branch does not seem to have major involvement. So as a result, the decision was done to proceed with provisional stenting. Of course, we did wire the circumflex, and it's very important to make sure the wire is not deformed because this may get entrapped when you pull it back. A stent is placed across the ostium of the circumflex, and then a nice result was achieved. The circumflex did not become compromised. If there is any question about the patency or the severity of the circumflex, then physiology can be done. As is true for every bifurcation stenting, the proximal optimization technique, the PO technique, is critical, because otherwise what might happen is you may actually get the wire to go outside the original stent, and that can crush the first stent after putting the balloon. So proximal optimization technique was done, and then this needs to be done with the tip of the balloon being at the carina. And when this was done, a nice result was done. In this case, we did put the pressure wire into the side branch, and actually there was no significant stenosis by coronary physiology. So having a nice result with a single stent in the provisional approach. This is another example. This is a patient who has a heavily calcified left main, heavily calcified ostial circumflex, and they are both large vessels. In this case, we did use a two-stent technique, and again, DK Cross is the one we typically use for most left main bifurcations based on the DK Cross trial data. It is not an easy technique. It does have several steps, 17 to be accurate. So one is to be very systematic in terms of going step by step to make sure that the stents are well placed and well expanded, and there's a final kissing technique. And then after doing a atherectomy, after doing DK Cross, we did get a nice result with good flow in both vessels as confirmed by intravascular imaging. As I mentioned, physiology is very important. Often the jailed side branch, which is the circumflex in most cases, may appear to be stenosed, but actually may not have significant stenosis. So in one study, about 42% of the circumflex seemed to be severe stenosed by angiography after stenting. However, when one did physiology, only 7% had an ischemic FFO. And this is an example. This is a patient who had provisional stenting from the left main into the LAD. The circumflex ostium does look funny, but here when you do physiology, there's clearly a big step up. So this is a significant lesion and does require treatment. And then when it comes to imaging, I will not say much because Dr. Kerry Mintz is going to present about this in a second, but one needs to make sure that adequate stent sizes are achieved, both in the carina as well as the left main and the two side branches. And finally, regarding hemodynamic support, it's used in the minority of cases, but should be considered for patients who have high wedge pressure, low ejection fraction, and comorbidities, such as occluded right or coexisting vascular disease. So to summarize, PCI of left main lesions can be complex. It involves bifurcations, it involves aortosteal lesions, it may require lesion modification, it may require hemodynamic support, but using a systematic step-by-step approach can provide with very good results. Thank you very much.
Thank you, Dr. Brilakis. I just had a, does anyone wants to ask Dr. Brilakis any questions?
Yeah, can I ask?
Yeah, sure.
Hi, Dr. Brilakis. A very nice presentation and very simplified way in left main bifurcation. One question, that EBC trial which we discussing. So if we, what's your opinion in DK Crush 5? They took that the patients were having a higher syntax score as compared to the EBC patients. It was like 31 or 23. And if we see the length of the lesion in the side branch, the EBC patients had a smaller length of 6-7 millimeters compared to DK crush 5. So can we say that if the patient is having a lower Syntax score and the lesion in the side branch is not very long, we can go with a single stage strategy? That would be a better thing. And if they are longer, we can go for a DK crush technique in these. What's your opinion on this?
Yes, thank you. This is an excellent point. And indeed, the lesions were much more complex in DK class 5. And I think it clinically makes sense as well. Once you have a lot of disease, very significant lesions on the side branch, long lesion length, as you just mentioned, if you have significant calcium, I think when you have all these factors, then the risk of side branch compromise is hard. And actually what happens sometimes is we try provisional, and then it's much harder to actually get a good result. If it's provisional and then it fails, then you have to, in EDC, they used a lot of TN protrusion, which is a bailout technique if things don't go well on the side branch. But if you use, for example, a reverse crush, if you stent from the main into the LAD, the circuit is compromised, and you're going to put another stent in a double kissing crush fashion. Now you're doing an inverse crush with the stent straps being crushed inside the previous stent, so less optimal than one would have wanted. So I completely agree with you. The more complex the lesion, the more likely you are to need to stent both of the branches. And I think in those cases, going up from DK crush or whichever technique is your favorite to stent bifurcation makes a lot of sense.
And one more thing, now recently a paper came up, DK culotte technique. So what's this, like the DK culotte people are like saying it's better than DK, the bench study which showed. So what's your stay on that? Because I have not much of a DK culotte. It's like, are you practicing this thing or?
Yeah, absolutely. And you make an excellent point. So as you know, the DK culotte is similar to culotte, but you have an extra, instead of having a single kissing balloon, which is at the end for the classic culotte, you do it twice in a very similar way, actually with DK crush. So again, I'm not, I have done, not a huge amount of culottes because I prefer DK crush, but I've done, whenever actually I'm doing culotte, I've been doing the double kissing anyway because it does make sense. For me, the main thing for these two stent techniques is the experience of the operator. So if you do this, my opinion is you should do the same technique for most of the time. Now, people say if you have the culotte, it's best for if you have similar size branches. The main vessel side branches are similar size, then culotte might be a little more appropriate. But in my mind, it's the experience of the operator. If you're very experienced at doing one technique versus the other and do consistently, you're very good at the steps and you don't miss something, you're going to get a good result, I think, with either technique. But if you skip stents, you take shortcuts, that's when bad things are going to happen. And I do agree actually with what you said. If you're going to use culotte, I would do it in the double kissing fashion. So I would do the first stent, get the side branch, do a kissing balloon to open up the struts to the side branch as much as possible, and then do a second kissing balloon after I place the second stent. And also try to minimize the length of stent that is in the double barrel in the main vessel proximal. So try to minimize, instead of having a large amount of stent, having very relatively short amount of stent.
Thank you.
Thank you.
Dr. Aisha?
Yes, thank you. And thanks, Dr. Brilakis, for that great talk. Just building on what was just discussed about double kissing for two stent strategies, of course, is best way to go. But what is your opinion on kissing after a pot if you're going for a provisional single stent strategy? That was mandated by EBC main, but there isn't sufficient data to warrant it to be done routinely. What are your thoughts on that?
Yeah, thank you. This is an excellent question. And actually, for the EBC, the European Bifurcation Club, it says it's kind of controversial whether you should do a routine rewiring and doing a kissing balloon inflation. My personal practice has been that if the side branch looks great, I would usually leave it alone. If there's any question, I will often do a pressure wire and then do a kissing balloon only if there is a significant disease. And the same for before, if there's no disease in the side branch, then I would typically not pre-dilate it, because then you risk dissecting it. And then if you dissect it, you are more likely to require a second stent, which will make the procedure more complex.
Thank you.
I want to ask something. Supposing you have an isolated circumflex ostial lesion and you plan for a provisional stenting left main to circ, and there is a mild plaque shift, but your FFR is normal. So in that case, what should you do for the LAD ostium?
Yeah, so the two options are to leave it alone because hemodynamically you're not significant. The downside of that is that then you may have a harder time reaccessing the LAD if in the future you end up having some disease. My feeling is that, with the contemporary stents, it's probably best to leave it alone rather than risk to dissect the ostium if your physiology is good. Now, if your IFR or the non-ischemic edix is kind of borderline, then obviously you'll be more likely to want to do something. And if you're going to do a kissing balloon, I will have a fairly short balloon and not go very high pressure, again, to minimize the risk of dissection.
Okay, thank you.
Thank you, Dr. Brilakis. A brilliant presentation. Just a small question. I wanted to ask, comparing mini crush versus DK crush in left main bifurcation. What is your take on that? Because is DK crush, yeah.
Yeah, no, thank you. That's a great question. Mini crush essentially is like DK crush, but has a single kissing balloon inflation, right? So it's the same. And the one downside of this is that then about 5-10% of cases, you may be unable to get your second wire and balloon down and do the kissing balloon inflation. So my opinion is that it's best to do the double kissing technique, although it's more painful, because then the chance of not being able to do your final kissing balloon is much less than if you don't. Having said that, again, in most cases, I think you will be able to do it even if you do the mini crush, you'll still be able to do a kissing balloon inflation. But again, just especially in more complex cases with calcium, maybe tortuosity, not favorable angle on the side branch. In those cases, I think it's maybe best to do the classic DK crush technique.
Okay. Thank you, Dr.
Brilakis.
Yeah. Anyone wants to, any other person?
Dr. Brilakis.
Yeah.
This is Dr. Rao. So basically, just one last thing. Do you feel that imaging is mandatory in all left main cases? And secondly, what is your favorite bifurcation technique?
I'm sorry, what was the first question? I didn't hear your first
question. Do you think that the use of imaging is mandatory for left main intervention? Because India is a country where 70% of the cath labs do not have imaging.
Yeah, absolutely. I understand the limitation. So ideally, I mean, to be honest, here, most people for left main would do routinely imaging routinely. I think, again, it helps you get a good result, helps you solve problems, helps you predict if you're going to need to modify the lesion with calcium. But I understand, if there's no local resources, I understand that this can be a problem. But if there's an option, my opinion is you should definitely use it, both to prepare the lesion, make sure it's well done, size the stents properly, and also to confirm at the end that you do have a nice result. For your second question, again, personally, I use two techniques pretty much for the vast majority of cases. Provisional, if the side branch is okay and doesn't have significant disease. If I'm going to use a two-stent technique, I do DK crush in the vast majority of cases. It does take a longer period of time. You do have trouble sometimes crossing in, getting the wire, the balloons, but I think the result you get is better. And then I think the chance of having events down the line is probably less when you really optimize the stents and have them well expanded.
Thank you.
You prefer coated wire for recrossing?
Actually, I use a workhorse in the majority of cases. Typically, these are large branches and the wires will go. If I have difficulty, then yes, then the next step is to use a polymer jacket, usually a Sion Black or Fielder FC or something like that. If this doesn't work, then typically we'll use a dual lumen microcatheter to get the wire, again, either a workhorse or a dual lumen, a workhorse or the polymer jacket wire.
So if there are no further questions, we'll move on to Dr. Gary Mintz. Professor Mintz needs no introduction. He is the pioneer of intravascular imaging, and I have had the pleasure to attend many of his sessions when I was at Cleveland Clinic. So Dr. Mintz has received many awards, a Lifetime Achievement Award, and has more than 1,000 publications, has authored many books. So over to Dr. Gary Mintz.
Thank you very much. Can you see my screen?
Yes,
yes, yeah.
Excellent. So thank you for the invitation and for the introduction. I'm going to talk about IVUS and left main bifurcation PCI. These are my disclosures. Going back to 1981, at least 7 studies have highlighted the inaccuracy of angiography in left main disease assessment. And I'll just point out one small study where in 51 patients, the unanimous correct assessment of left main severity by 4 experienced interventional cardiologists was only 29%. In terms of deciding whether or not to treat a left main lesion, there is more agreement between IVUS and FFR in assessing left main than non-left main lesions because of a limited variability in left main length, size, and the amount of myocardium supplied. Both have theoretical and practical limitations, and the long-term studies are equivalent for the 2 techniques. In this meta-analysis from Javier Escaned's group, the 30-month outcome, whether lesions were deferred based on FFR or IVUS, the criteria for FFR of 0.8, the criteria of IVUS, a minimal lumen area of 6 square millimeters, the outcomes were virtually identical. We based the decision with IVUS on the lumen area, not on the amount of plaque, because as Glygov showed in 1987, the left main grows to accommodate plaque. So focus on lumen dimensions, not on plaque burden. Let me share with you a case of a patient with non-alcoholic fatty liver disease and portal hypertension, renal insufficiency being considered for liver transplant. Here was his coronary angiogram. You can see some distal left main disease, not quite sure how much. The DFR was significant at 0.87, but the IVUS lumen area was 8.5 square millimeters with only a small amount of calcified plaque, probably a calcified nodule here, and the patient did not need revascularization before undergoing liver transplant. The other study that I like very much has to do with what is often considered to be a small left main. If you see a left main that it does not appear stenotic and is smaller than the LAD or the circumflex, it means that the left main is diffusely diseased and there is no such thing as a small left main. Complete assessment of the left main requires imaging from both the LAD and the circumflex back to the left main with at least one pullback to the aorta, because the IVUS catheter, if it makes a turn, can make the lumen appear artificially large. And you always take the smallest lumen area on the 2 pullbacks to determine left main lumen severity. It is not accurate to assess the left main circumflex from the LAD pullback or the LAD from the circumflex pullback. You have to do it directly. Plaque distribution from the left main to the LAD and the circumflex cannot be predicted by the Medina classification, and the flow divider is always spared. So here's an example of a left main lesion, pull back from the circumflex and the LAD. The lumen area in the circumflex here and here is larger than from the LAD pullback here and here, because the turn causes an oblique transducer position. Again, we do not look at the LAD from the circumflex pullback or the circumflex from the LAD pullback. Here you can see from the LAD pullback, the circumflex does not appear to have much disease. The flow divider, of course, is always spared. When the circumflex is imaged directly, there's a large plaque burden and the lumen area is borderline. This is the data from one study where we prove that you cannot look at the LAD accurately from the circ pullback or vice versa, the circ from the LAD pullback. And this is another study where we looked at the Medina classification, and irrespective of the Medina classification, about 60% of the time, the plaque is from the left main into both the LAD and the circumflex, sparing the flow divider. 14% of the time, the plaque at the ostium and the circumflex is focal, and about 14% of the time, there is no plaque at the circumflex ostium, and the other patterns are fairly minor. Here's another example. You can see here is the LAD. Here's the circumflex here, and here's the left main. And there's a plaque rupture in the ostium of the LAD that extends into the distal left main. Another example of an ostial LAD CTO, but the distal left main has a large plaque burden and some lumen reduction, and the plaque continues into the body of the left main. When treating an ostial LAD or ostial circumflex disease, we now know that you should do crossover. You can't nail the ostium, the LAD precisely, and a couple of studies have shown why. It's because the IVUS catheter and therefore the stent moves as much as 5 to 6 millimeters between systole and diastole. When we size the stent, we pull back from the LAD to the left main. We identify the distal landing zone in the LAD for the stent size. We identify the distance between two landing zones for the stent length. We look at the ostium of the circumflex to the proximal landing zone in the left main to identify the pot length. And we do the same thing in the circumflex to pick the circumflex stent if 2 stents are necessary. Brilakis already shared with you part of this study, but the main purpose of the study was to predict the patients who had an FFR less than 0.8 after single stent crossover from the left main to the LAD. So patients who had an FFR less than 0.8 in the left circumflex had a lumen area less than 4 and a plaque burden of more than 50%. And those are the cutoffs for deciding whether or not you should strongly consider a 2-stent technique up front. Manos also showed you this study, also from Asan Medical Center in Korea. We call it the rule of 5, 6, 7, 8 to determine the minimal stent area in these 4 locations that is associated with a reduction in restenosis. But here's the problem. When we planned the Excel study, we recommended those numbers a little bit larger because it's a Western study, but 1/3 of the patients did not have an adequate minimal stent area in the left main. And this is just one of the examples. So you can see the left main stent is woefully underexpanded. And we saw this in 1/3 of the cases in Excel. And here you can see calcification causing stent underexpansion. Also in Excel, we learned that in Western patients, the 5, 6, 7, 8 rule is not adequate. Rather, it's about 5.5 in the circumflex ostium, 7 in the LAD ostium, and 9.5 in the body of the left main. We also learned the importance of stent deformation. If there was stent deformation at the end of the procedure, the event rate was twice as high at 3 years compared to having no deformation. And here's a clinical example. You can see that after kissing balloon, the first set of inflations, the stent looks underexpanded. And so they did additional kissing balloon inflations and they got better stent expansion. But here, where there was 1 layer of stents, there are now 2 layers of stents. And the minimal stent area has decreased significantly. So this is stent deformation, and this is associated with a much higher event rate than the absence of deformation. What happens at the ostium of the circumflex? Here's pre-intervention, angiography, but at the IVUS looks like the ostium of the circumflex is quite frankly fine. Plaque burden of 37%, a lumen area of 10.4 square millimeters. So 1 stent crossover across the circumflex. The circumflex looks actually a little bit better here, but you can see that there's now deformation at the ostium of the circumflex, an elliptical shape, but the lumen is quite well preserved. The FFR is 0.91, and there are several reasons for that, because some of these are angiographic artifacts. In general, the circumflex stenoses are not associated with an FFR of 0.8 pre-intervention. So why should they have it post-intervention? There's an eccentric vessel deformation with little plaque shift, and plaque shift may be necessary to cause significant ischemia. Changes are very focal. The large vessel size in the circumflex supplying a relatively modest amount of myocardium. Here's another example. You can see pre-intervention. Here's the circumflex left main LAD, stenting from the left main to the LAD, and the carina is just deflected, but there's really very little change in plaque mass. The lumen is a little bit compromised, mostly because the vessel has, because of carina shift, but the lumen is still adequate. This is data from Bonkwon Ku's group in Seoul, Korea, Seoul National University. And if you have a FFR less than 0.8 after single stent crossover, the event rate is 3 times higher at 5 years than if the FFR is greater than 0.8. This is a fairly unrecognized study from Xi'an, China, that looked at a large number of patients, 563 left main that were studied both pre and post PCI after single stent crossover. The cutoffs of a post PCI FFR less than 0.8 were exactly identical to those from Sujin Kong. And they showed that if you start with single stent crossover and then take the patients with an FFR of less than 0.8 and place either a single stent or use a drug-coated balloon, the outcomes were the same out to 3 years. So in their study, there was no penalty for starting with a single stent crossover, especially if the IVUS study did not suggest that it was necessary. Let's now talk about outcomes. These are 5 meta-analyses of the randomized and trials and registries, recognizing that there are really only 2 randomized trials of IVUS versus angiographic guided stenting for left main disease. But in all of these trials, all-cause mortality and cardiovascular mortality were markedly improved. 60% reduction in cardiovascular mortality, 40% reduction in all-cause mortality. And I'd like to highlight 3 of the studies that were included in these meta-analyses. This is the largest randomized trial, 170 patients in each group. Cardiac death was reduced from 6% to 2% with IVUS guidance. This is, to me, the most impressive study. This is BCIS, the British Cardiovascular Interventional Society. It's a national registry in the UK, in this case, looking at left main PCI. Overall, at 1 year, there was a 34% mortality reduction nationwide with IVUS guidance. And the operators with the greatest left main PCI volumes had better outcomes and greater mortality benefit. In fact, the mortality benefit increased to 60% when the quartile of operators with the greatest left main PCI experience did IVUS guidance. Remarkable study. And the only study that looked at distal left main disease directly from Jose de la Torre Hernandez group in Spain. This is a multi-center study, and you can see that the combination of cardiac death, MI, and TLR in distal left main disease treated with single stent crossover decreased from 19 to 11% with IVUS guidance, and with a 2-stent strategy, a much higher event rate, but it decreased from 42% to 17%. And IVUS use was an independent predictor of events when treating distal left main disease. The question always comes up, what about IVUS or OCT? There's only one study, which is ROC2. It was recently published, and it showed identical outcomes with either IVUS or OCT out to 1 year, admittedly in a relatively small number of patients, 100 patients in each group, and they both did better than the angiographic guided group. I'm always asked, how does IVUS reduce mortality? People understand that it'll reduce stent thrombosis and in-stent restenosis, but why mortality? Well, this is an excellent study from Castrati's group, and he showed that if a patient presents with a left main stent that is restenotic, so left main disease treated with stenting, patient presents with restenosis, the mortality associated with in-stent restenosis in the left main, either at presentation or 5 years after treatment, is 30% all-cause mortality, which is 6% per year, 24% cardiac mortality, which is 4% per year. So if you prevent in-stent restenosis, you prevent mortality. And this is just my final slide. These are 2 review articles where I was a co-author, and we looked at, we went through all the uses of IVUS during left main PCI. Thank you for your attention.
So Dr. Mintz, thank you for the great presentation, and you elucidated very clearly where the use of IVUS for left main bifurcation stenting and how it helps in sizing and looking at the side branch for the bifurcation stenting. I open the forum to the audience and for any questions. We have 3 minutes to go.
Yes. Can I ask?
Yeah,
This is
Dr.
Aisha.
Topalia.
Hello, Dr. Mintz.
Go ahead.
Very nice presentation. Just a question, like in routine clinical practice, sometimes we see a very tapering type of left main, like ostia and the body is very big and in the distal part it's going tapering. And when we try to put a stent about 4.5, still sometimes in the body part, the stent hangs. We are not able to oppose it properly in that. So what's your experience that how much we should go ahead with these cases to oppose it in these cases?
Right. So malapposition has never been associated with adverse events at follow-up. The only problem with malapposition is if it's at the proximal edge, and if you have to rewire the stent, the wire can get behind the stent. So the answer is don't make it go away. You're not going to make it go away. By OCT, the rate of malapposition is 50%. So it's very, very common. But try to minimize it so that if you have to come back, the wire doesn't go outside the stent. If you give yourself a big giant target with a huge stent area, if there's malapposition on the rim, it's not so hard to, not so easy to get behind. But if you have it's floating with a large area of malapposition around it, then the wire can easily go outside the stent.
Dr. Mintz, this is Aisha. Thanks for that great overview. And so there's so much great data for the support of intravascular imaging in left main PCI, and yet it's not mandated by protocol, not in EBC main, and I doubt in DK crush either. So there's just 40% of IVUS use in the trials which inform our practice. So what are your thoughts on that? And why would you think it's not mandated by protocol? And how representative are the outcomes then?
Well, I think the outcomes, if you look at, I mean, again, I go to the BCIS registry. That's, 12,000, 11,000 left main PCIs with a 34% reduction. And the use of IVUS in the UK has skyrocketed based on that data. Now, why don't the guidelines give class 1 indication? Because I think the guidelines are simply wrong. I think the people who are writing them are prejudiced and wrong. I think there are a couple of individuals who have no idea what they're looking at, and so they don't want to be forced to use imaging because they're uncomfortable doing it. So they sit on the guidelines committee and they block it from being class 1. The data is overwhelming. It's overwhelming. If you can reduce mortality with a pill, if you take a pill and say, here, patient, take this pill, your mortality is reduced by 50%. Would you give them that pill? Of course.
Absolutely.
So then why wouldn't you use a technique that has been shown over and over and over again to reduce mortality with left main PCI?
Yeah. That makes sense. I just can't wrap my head around the trial perspective. I wonder if it is to make it pragmatic, if it is to enroll patients, if anyone has thoughts on that. Why do the trials not mandate it?
Which trials?
EBC Main did not mandate IVUS by protocol.
I see.
Which is why it was 40%.
Well, I think it's a mistake. If you look at FAME3, FAME3 was negative, right? We're not talking about left main. The use of imaging in FAME3 was 10%. So they were using inferior PCI technique against superior surgical technique. The only difference is whether you use an FFR wire. Had they had a high rate of imaging, FAME3 probably would have been positive in favor of FFR, or favor of PCI, I should say. Why the trials don't mandate it? I don't write the trials. There is actually going to be a large European trial of IVUS versus angiographic left main PCI. We'll see what the results are. You know, I'm sure it's going to favor imaging. Why don't the trials do it? Because there are people who are sitting and designing the trials who have no idea what they're looking at. And they don't want to be forced to use something they don't understand. People are not taught.
Dr. Mintz.
Yes.
Dr. Mintz, this is Dr. Rao. So I just wanted to ask you that for aorto-ostial lesions, we normally use IVUS. But recently, there was a paper where, you know, they used the telescope with the OCT to look at the aorto-ostial lesions. So I would like to know, what are your views on that?
Well, I think the telescope, or similar devices that allow you to clear blood from the ostial lesion, I think is interesting. I am agnostic when it comes to imaging. The only thing I will say is that there are no strict OCT criteria like have been developed with IVUS, but I don't think it really matters what you do. I think that the argument of IVUS versus OCT is a ridiculous argument. The argument is imaging versus angiography.
Thank you, Dr. Mintz.
So, Dr. Mintz,
another from the panel?
Yeah, no, only Dr. Mintz, like in countries where most of the cath labs do not have imaging. So, I mean, and the person has to be very familiar with the intravascular imaging, because most of the time there is a difference in the stent size, the length and the diameter of the stent once we use IVUS imaging, and it makes a difference in the mortality. But probably, I think it's because if it becomes mandatory, there are large number of labs in countries like South Asia, Southeast Asia, where intravascular imaging is not available. So it's basically
Very true, Dr. Bhanu.
Yeah.
Very true, Dr. Bhanu. And added to the fact is that in many of the countries like ours, it is the patient who pays for everything else that we use.
Yeah.
So
the
that
cost
also
would go
is
up.
an impediment.
Yeah.
Yeah.
No,
There is an additional financial burden of the patient.
Many of the insurance.
We love to do imaging.
Yeah. Many of the insurance companies also don't allow. They do not give acceptance. Yeah. For some,
they do not accept it. The
Yeah.
second is that, whenever I'm allowed to use imaging in a patient, I absolutely love it. The results are amazing. You are so able to oppose your stents. You are so able to get a good result. Especially in left main bifurcation, you're able to see that osteo of the circumflex, which you're already so worried about. Your stent opposition is perfect. The sizing of the stent is always perfect. Whenever I image, I see that I use upsize of the stent, which I would have normally used when I did only an angiographic one. The problem in a country like ours is two things. The patient pays for everything that we use. The insurance companies frequently don't approve it. And the third thing is that 70% of centers do not have it. That is the impediment. Otherwise, we love imaging.
Yeah, Dr. Sarita.
Sir, if I may ask you, I mean, we have got so much of other trials, which are there, which actually, when we study about malapposition and, dissections and so many other results that we are studying with imaging, their correlation with the clinical outcome of the patient has at times been controversial and dubious. So what are your comments as regards that? Is there a possibility that at times we are kind of, overreading this whenever we are treating our patients with bifurcation and in left main? Because the data still is dubious and slightly controversial. What's your take on that?
I totally disagree with you. The data is solid. Solid. Show me a negative study of imaging versus angiography. No, let me finish, please. Show me a negative study of imaging versus angiography left main PCI. Show me one.
So
it doesn't exist.
Not negative study, sir. What I mean to say is that when we have studied about data like IVUS and OCT, and we have studied about malopposition, and when we study—
No, malopposition is not important. I've already said that. Malopposition has never been shown to have adverse events.
Yeah, so that the correlation with when we talk about correlation with the clinical outcomes of these, I mean, is it not possible that at times, what we are getting good angiographically clinical results, and these patients actually, and people have shown so many times in their case reports and in clinical studies in a country like ours. Of course, I agree with Dr. Sarita and everybody else that if we have this readily available, we would like to use these imaging techniques. But then even with the use of these angiographic results, the luminal results that we see, the clinical profile of the patient, remains as it is even with the imaging. Sorry for but I thought, this is what we experience every day, sir.
No, look, I understand resource issues. I can't fix resource issues. I can only present the clinical and scientific data as clearly as I can. If I thought that there was questionable data for left main PCI guided by imaging, I would have shown you that questionable data, because I'm a scientist. I'm not a, I'm not a health minister. I cannot control utilization and I cannot control resources. I can only present the data. And if you just have to at least accept the fact that the data is not controversial. The data is unbelievably solid. Now, and then say, okay, the data is solid. We wish we could use it. We just can't. We don't have the resources. That I understand. But don't try to make the excuse that we don't use it because the data isn't that good. The data is solid.
So agreeing completely with Dr. Gary Mintz, and I would like my co-panelists to know that this is the National Health Insurance Scheme. If we are able to justify our the use of the IVUS, that is left main bifurcation, there's a package and you can use intravascular ultrasound. So Dr. Gary Mintz, we started the National Health Insurance Scheme about a few years back, and we have an unspecified package, and we are able to use intracoronary imaging very liberally now, especially when we are able to justify. Only thing we are not able to use it on tables. So this is just for my panelists to know. And so we are using it in nearly 30 to 40% cases. We have to send a justification, Dr. Sarita. Yeah, now Dr. Sarita, who's leading the whole conference. Any other questions?
We have to send this justification to whom, Dr. Bhanu?
So if no. So in Ayushman Bharat scheme,
okay, it's for that.
It's for that. So to activate the package, there's an unspecified package called 200.
Okay, right.
So my hospital doesn't cater to Ayushman.
So Dr. Sarita, any more questions? So I think Dr. Sarita, who's organized this wonderful conference, and all of us are here. It's over to her. She doesn't. She's a leading interventional cardiologist who has maximum experience in doing very good complex cases. Dr. Sarita, over to you.
I'll just share my screen. Is my screen visible and am I audible?
Yes.
Thank you.
Yes.
So today I'm going to be speaking about left main coronary artery unlimited possibility. So left main coronary artery disease, it portends a higher prognostic risk. As a result of the large myocardial territory at risk, ranges from 75 to 100%, depending on what is the dominance of the left coronary circulation. So our clinical practice guidelines, they continue to advocate a bypass surgery as a singular class 1 indication for myocardial revascularization. PCI has a class 2A recommendation in select patients with isolated left main stenosis involving the ostium of the shaft and without a coexisting multivessel disease and the risk of surgical bypass increase. PCI has a class 2B recommendation in patients with left main stenosis involving the distal bifurcation or with less complex coexisting multivessel disease as defined by a lower intermediate syntax score and who have an elevated surgical risk. So today I'll just present a few cases deemed high surgical risk candidates involving the left main coronary artery and demonstrating various techniques for the same. So this is a 50-year-old male, diabetic, hypertensive, admitted with complaints of shortness of breath and uneasiness intermittently. He had a history of chest pain with perspiration on the 30th of September, taking primary treatment at a local hospital, shifted to my hospital, diagnosis of CAD, anterior non-QA MI, and an ejection fraction of 45% was made. So this was the angiogram of the patient. The angiogram revealed an osteoproximal LAD, 70% stenosis, a mid to distal LAD, 100% occlusion. The proximal ramus also had an 80% stenosis. Proximal circ also had a 50% stenosis, and the mid RCA had a 70% stenosis. The plan was how many stents and what strategy to go ahead with this. So now the ramus was a very large vessel. So I planned to do a left main to ramus followed by an LAD tap and a circumflex provisional approach. Wired both these branches. Subsequent ballooning both the vessels. Then went ahead, stented ramus to left main. First part, stented the LAD. The LAD stent covering both the ostial and the mid lesion. Kissing. The second part. And this was the final result. So this was the hardware which was used, and we used a 4.530 Resolute on it. And post-dilated, the pot balloon was 5x6 centi balloon. And for the LAD, we used a 3x40 millimeter stent. And final port again was done with a 5x6. My second case, this was a 58-year-old lady admitted with complaints of chest pain and exertion last 2 months, increased since yesterday night, history of diabetic, hypertensive, pressure shoot, ECG non-STEMI, diagnosis of CAD, acute coronary syndrome, non-STEMI, TROP-I positive. This was her angiogram. So she had an LAD osteoproximal plating. Mid was 80% stenosis. Distal had a 70 to 80% stenosis. Circumflex proximal 60% stenosis with a single medium-sized OM. RCA had a proximal non-critical lesion. The large ramus was also mild disease. Now the plan. What was the plan? So in this patient, we decided that we would do imaging-guided isolated angioplasty of the LAD if I could find a clear space between the left main and the ostial LAD to place my stent. When I was to the LAD showed an MLA of 2.86 and with a plate burden of 77%, the POC was also showing significant fibrous plates and with an MLA of 5 and a luminal diameter of 2.2. I was to the circumflex lesion also showed a significant plate burden of 83%. So ultimately, imaging changed my plan, and I had to go ahead and stent left main, LAD, and LCA. Ramus, we had a provisional approach. This was the circumflex ostium, an 83% plate burden, left main ostium, and this was the LAD ostium with a 77% plate burden. This is the POC. So we went ahead, ballooned the LAD. The circumflex was also ballooned, followed by the LAD stenting. This is post LAD stenting, and followed by Angioplasty to the circumflex, the first part. Kissing balloon, second part. And this was the final result. So this was the hardware which was used in this patient. We used a 3 into 38 millimeter synergy stent for the mid-occipital lesion, and the left main to LCX, we used a 3 into 48 stent. Post-dilatation finally done with a 4.56 watt balloon. A third case, interestingly, all of these cases which I'm showing were done in the same month, admitted with complaints of recurrent chest pain, shortness of breath, and this gentleman was 81 years, transferred from another city to us because he was going into recurrent heart failure. He was diabetic, he was hypertensive, very elderly gentleman, very frail. Creatinine was 2.5. He had an acute anterior non-Q wave MI, and he had an acute and chronic kidney disease. He had a large right-sided pleural effusion, which we tapped, and his ejection fraction was only 15%. So the plan was to go ahead and do a shockwave lithotripsy and stenting from the left main to LAD. This was the angiogram, heavily calcified vessels, an octogenarian patient. You see the LAD has a proximal 80% stenosis, mid 50%. You can see there is a distal left main disease also. RCA distal at 100% occlusion. Now this is the lesion we planned to tackle. And he had severe LV dysfunction. So we did a shockwave lithotripsy and stenting from left main to LAD, and a provisional approach to circumflex was adopted. This is the IVL balloon. So the moment we took it in, we lost all flow. We went ahead, gave these pulses, pulled back, gave some more pulses. Post-IVL, this was the picture. Some more pulses of IVL. And then this is the stent placement. Followed by a pot. And this was the final result. Circumflex was flowing well, we left it alone. So this was the hardware used for this patient. We used a 3 into 40 millimeter left main to LAD stent. A shockwave balloon of 3 into 12 was taken. And post-dilatation was done with 315 and a 4 into 6 watt balloon. This is the final case, 77-year-old male complaining of chest pain. And at 2 a.m. in the morning, ECG showed a non-STEMI, hypertensive, TROP-I positive. Again, this patient also had very severe LV dysfunction. Ejection fraction was only 15%. They declined for surgery and a plan of stenting to left main to LAD, circumflex, and RC. This is the RCA. The RCA had a proximal 80% stenosis and a distal 70% stenosis. This was the left system, LAD ostial and mid stenosis. Left main distal also showing stenosis, circumflex osteostenosis. You see there's a distal bifurcation lesion. So the question was, what strategy? Should we go provisional or two stent? We wired both the branches. Left main to LAD after, so we stented the mid LAD lesion and then went left main to LAD, followed by a quad. The angle was almost 180 degrees, so we planned for a tap stenting, followed by a quad, and final result. So my take, a PCI for distal bifurcation left main disease is associated with worse long-term outcomes as compared to a CABG. PCI and CABG do have comparable long-term outcomes among patients with ostial and shaft left main disease. PCI is also associated with higher rates of target vessel revascularization, regardless of the left main lesion location. We do need to be very well equipped with all the necessary armamentarium to bail out such patients who are extremely high-risk candidates for a bypass surgery and who are adamant not to undergo a bypass, and are hospitals bound with recurrent heart failure and progressive cardiac dysfunction, as was in our patient. All you need is a cautious explanation to the kith and kin about what to expect, and left main interventions should be done, keeping only the patient in mind and always hoping for a fair wind in your favor. Ladies and gentlemen, Thank you so much.
Great presentation. Or anyone questions? We are open for questions.
Thanks, Dr. Sarita. That was a great presentation and really interesting cases. I was wondering about your access. Do you preferentially always go femoral? Is it for left main, and is it always a 7 French?
Okay, so yes, when I'm going for a left main bifurcation, I prefer to be safe. Most of these patients are surgical rejects, severe LV dysfunction, and I prefer to use a femoral access for my left main cases. And yes, always a 7 French.
Yeah, I noticed that you have used tap technique in most of your left mains. Is that your preferred technique?
Not always, but depending on what is the angulation. Also, I always try to go in upfront as a provisional approach. And when you're going in upfront as a provisional approach, the tap really works very well.
Yeah,
and
but
you have a good angle.
Many of them were, I think, planned 2 stents. Some of them were planned 2 stents. But yes, I agree that tap is fairly easy. And if you're dealing, it goes faster. It's faster.
It goes very quick.
Yeah.
So if you have a sick patient, you have a good angle.
When you have LV
and-
dysfunction.
Yes. So you would have noticed 2 of the patients that I showed that an ejection fraction is 15%.
Yeah, yeah.
And I did not put an IABP in any of those patients.
Yeah, I was
So
wondering, would you think that putting an elective IABP would, improve the coronary flows in such patients?
Like I told you, I was in a private sector hospital where the patient pays for everything. Now, I always have an access ready, and I have an excellent team with me. So if I need an IABP, it gets put within 30 seconds. No problem. I have an access ready. If I need it, I put it. But if I'm able to get away in the procedure without the use of an IABP, I go ahead and I do it. I keep an access ready though.
Because in some of the cases, there was slow flow LV dysfunction patients, which is expected. Yeah.
There were 6
So
patients,
yeah,
a lot
it's
of
really
flow, a lot of
Yeah.
LV dysfunction.
So
I told you. But let me tell you at the same time that these 6 patients who have these chronic diseases and who have a lot of LV dysfunction, actually they tolerate the ischemia pretty well.
Yeah,
The
so I guess
myocardium is already primed to it.
Yeah, so
tolerating
if
the
they are,
ischemia.
if they are having LV dysfunction for a long time, they kind of tolerate.
They tolerate it
better.
because
Yeah.
they have already become primed to tolerating that ischemia. They probably have some kind of lateral circulation backup. I don't know, but they tolerate it very well. And so I always keep an access ready. If I need it, I put it. If I'm able to get away with the procedure without the use of it, well and good for the patient. Saves them the money.
If they're paying for so much, IVP is nothing then.
Yeah, amazing talk as usual, Sarita ma'am. I just need to ask you, there is something which we need face day in and day out for people who are not very apt to doing left main interventions in their routine as an elective procedure, but kind of have to face patients who present with anterior wall MI, RBBB, and, thrombus running around in left main. What would be the take for them? Because time to unload is the new crux which is coming into now, because IABP was mentioned. So we are all aware of time to circulation and time to balloon and getting time of wire across in an acute MI. But now the crux is that if we have a patient who presents to us in cardiogenic shock, and maybe if we can unload the patient, with an ECMO, with an IABP or whatever, and that would give us better hemodynamics and maybe better results. So 2 things, your take on the time to unloading. And the second thing is, what would be your advice to young physicians, who are not apt to doing their left mains in routine? How should they proceed when they have to encounter these patients, suddenly with a thrombus running around in left main? What should be the technique that they should be following? Thank you. I think for the benefit of all, if you could give us a word.
Dr. Shiva, thrombus running around with left main is never a good situation. So if you're talking about
it happens, and it happens when
the situation, if I run into thrombus in this situation, then I like to use intracoronary 2B3A inhibitors. It helps improving the flow. It helps reducing the thrombus burden. The second is left main intervention should always be done by two things. One is don't be afraid to ask for help in the younger cardiologists, because you should have a backup when you're doing left main. And it requires experience, because it doesn't really give you time if the patient crashes. So
this is a primary patient coming for primary angioplasty in a setup, which is very common here. Patients come and how to salvage and what is the technique. That I feel that this should be discussed and offered, because this is what happens. It's not every time that kind of backup in the mid of night. It happens. It happens in real world.
Yes, I agree with you, Dr. Shiva. I agree with you.
But if you look at trials, even with the best of people doing the procedures, even if you have done a successful left main PCI in a acute myocardial infarction, still the mortality can be quite high, even after the stenting. So I guess in such patients, you just have to go ahead. You don't have an option. So
yes. So
absolutely, patient in cardiogenic shock, patient having no other option, pressures crashing, then you just put in your IABP and you do the best you can. Quick in and quick out.
And as Dr. Gary sir was saying that I'm a scientist, I'm not a health minister. I do agree, but when we have to work in a real world scenario, these things. So, but I think well taken. We have to understand the points which are there with data, and always great listening to you. Dr. Bhanu, we missed out on one lecture and somebody was calling. I think there was
Actually, I thought we'll finish sorry, I thought we'll finish the clinical. I should have just sounded. So Liza Lynch, she's it's a very interesting talk about, she's an engineer, she or he, I don't know. So, she has a chemical engineering background, has worked for about 10 years in the field of stent design, and she will be speaking about the stent design.
Hi, folks. Can you hear me okay?
Yes, we can hear you well. Lisa?
Thank you, everyone, for allowing me to speak today. My name is Lisa Lynch. I'm a Principal Research and Development Engineer in Boston Scientific. It's great to be among so many great leaders today speaking, so thank you for the opportunity. So as I said, I'm an engineer, and I'm going to focus on the synergy stent design and the role of the design with the thoughts of left main bifurcations. So when you think of the basics of stent designs for drug-eluting stents, platinum chromium allows us to reduce strut thickness while maintaining radial strength and radiopacity. On the bottom left there, the everolimus provides that therapeutic value. It's a proven clinical drug with over 30,000 patients studied in clinical trials and real world registry. We have a polymer PLGA on the stent that ensures the delivery of the drug and the controlled release of the drug. And then the delivery system for Synergy, it has a new enhanced delivery system with laser cut hypotube for better pushability while keeping that flexibility. And then lastly, in the center there, the stent architecture allows us to engineer and optimize on the radial strength and recoil while maintaining thin struts. So when we talk about platinum chromium alloy, it was engineered specifically for coronary stenting. And just a brief history here on it. In 1994, we had the introduction of stainless steel stents. They had good recoil and reasonable radial strength, but they had poor visibility, as you can see over on the right. And in 2003, we had both cobalt chromium and cobalt nickel. There was slight improvement in radiopacity over stainless steel, and they enabled thinner struts, but they had a very high recoil. So in 2006, it was an introduction of platinum chromium that has thinner struts, maintaining exceptional strength, the lowest recoil, and outstanding visibility. So the Synergy stent system has an enhanced platform with extra connectors on the proximal end, and those extra connectors is that part of that customized stent architecture. So when we design a stent, we have a certain conformability or fracture resistance, for example. We have to look at those. And there we have multiple test inputs like peak width and strut length and the thickness that need to be considered to get the right design outcome. So we look at different test inputs, for example, to get the right test outputs. That's how we think of it when we're designing the stents. Here's a demonstration of an axial strength bench test. The test image on the right shows how to cause 1 millimeter of deformation on the proximal 3 millimeters of the stent. So we compared against Science and Onyx here. And with the Synergy design, it has additional connectors on the proximal section of the stent. And then this test shows how much stronger Synergy is compared to Science or Onyx. And that's because of those extra connectors. So why does conformability matter? This paper that was published shows stent implantation can change the shape of the artery, and it can alter the shear stress patterns associated with restenosis. The analysis was done to show how vessel straightening can impact MACE, and less vessel straightening, which is associated with improved blood flow within the vessel, which makes sense when you look at those images on the left, and that contributes to lower event rates. So we wanted to see how we could bring that into a bench test. So this video shows the difference between Science and Synergy, a 3 connector design versus a 2 connector design. So we put the stents in the exact same tubing and just move the tubing to see the difference between flexibility. So Synergy then has enhanced flexibility and cyclic fatigue performance because of that. This is a video that shows how we make our stents. All Boston Scientific stents are manufactured in Galway in Ireland, and that's where I'm based. The video is a bit slow to load, I think, because it's a bit big. But the stents are laser cut from tubing in-house, and it allows the exact dimensions to be programmed, getting the exact design outputs. So it might not play for me because it might be a bit too big. Sorry about this, just give me a second. I'll just close the program now, 1 second. It's never a dull moment without technical difficulty. Apologies. That's frozen on me. That's great. Do I have any questions so far while I'm waiting for this to restart?
If I could ask one.
Of course, yeah.
So we're talking about left mains. And the left main, at least in my experience, is a little unique in 2 ways. First of all, it's one of the areas where chronic stent recoil can be demonstrated, unlike the LAD and the Circumflex. And secondly, it's the second most common location of a calcified nodule. So it's when you stent the left main, you are more likely to have either chronic recoil or strut fracture or deformation because of the architecture of the left main as well as plaque composition. Is there any thought to designing left main stents that are more robust?
It's a complex area. So to design, there is thought on it for sure. And it is in work in many different aspects of complex left main bifurcations. To give you an example, I'll just nearly have this open now. To give you an example, to design a new stent, especially a drug-coated stent, can take about 10 years. So what we do is we design, I'll ready to share that now. You should be able to see that now. I've just skipped the video. Unfortunately, you missed that video. So what we do is we try and build on an existing design because it's a quicker way to iterate a product. So, Dr. Mintz, what you probably were alluding to in your question is, would you like to see like specific stents for that specific area? You know, let's say like a bifurcated stent.
Well, I mean, I think that even if you know, one of the beauties of the left main is big.
Yeah.
So even if you took an existing Synergy and cranked up the thickness of the struts, it would make it more robust. And you really don't need a thin strut stent at the left main location. What you need is more radial strength.
Yeah, so I've got some great slides on radial strength. I'll talk to you about it. And what's actually important is the width here. And I'll the next few slides I'll explain that.
The Megatron, right? In the Megatron, having much more radial strength, right? So it's designed to have more radial strength for left main. So maybe Gary, maybe that's what I think feels that needs to some extent.
Hopefully.
Yeah, and I'll talk about radial strength now in a few minutes. So the Synergy stent optimized design reduces recoil by moving the strain outside of the peaks.
Could
so if you think about that,
I don't think we see your screen.
Oh, hilarious! Sorry. Okay. Now, am I back in the game? You can see that, yeah?
Yes,
okay.
We can see the screen.
So the Synergy stent's optimized design reduces recoil by moving the strain outside of the peaks. So if you think of that, if moving the strain outside of the peaks. So if you compare the three designs here, where the focus is distributed on bending, for Synergy, bending is focused to a small area adjacent to the peaks, rather than the entire area of the peak. So the less area that bending means, then there's less area to recoil rather, sorry. So this is a design feature that can be useful for left main bifurcation. So when we talk about, back to the lab again, about radial strength. So on the right here, we designed a compression resistant test to see the amount of radial force required to reduce the diameter of a deployed stent by 15%. And from this bench data, Synergy is top of class from a radial stent perspective, when we compare it against Ziads and Onyx, when we try to reduce the diameter by 15%. Okay, so keeping with radial strength then, it increases on overexpansion. So how does that make sense when it increases on overexpansion? So if you think of the cantilever design in the bottom right here, most of the radial force in a stent is in the width plane. This is why strut width is more important than strut thickness. Okay, radial strength increases with overexpansion for Synergy as the struts become more column-like. So therefore, resistance is stronger compared to a V formation design. So this can be the case with other stents to a point, but for our stent architecture, the stent material provides a more optimized design. Okay, so when we think of what makes a good bifurcation stent, so you're thinking about overexpansion for the tapered vessels, side branch access, visibility, strength, low recoil, and flexibility. Okay. So on overexpansion, on average, left main diameter is within 4 and 5.0 millimeters, and more than 70% of left main stenting involves a bifurcation. Okay. So for Synergy, the Synergy side branch access and maximum cell diameters are shown here. And on the left, the circular cell diameter, there's a balance between tissue scaffolding and side branch access. And most all stents have adequate circular cell diameter to be able to pass a wire and catheter over it. But then there's problems with the connectors. If you randomly position the connectors.
Dr. Lisa, we are 15 minutes ahead of our schedule. Would request you to please,
sure.
Yeah, thank you.
Yeah, I'll keep going. So we've all seen, Synergy, the drug-coated stent is on the outside of the stent. Its key features for early healing, and the aluminum polymer emphasizes suppression of the neonatal growth for arterial wall while promoting healing inside the vessel. I'll skip through some slides here. You might be interested in what the drug coating looks like from 0 to 90-day explants. The synergy coating is visible at 28 and 60 days. And then at 90 and 100 days, it's not as visible. And when you do cross-sectional areas in a swine model, what does the endothelization rates look like? So it's fully endothelized on the right-hand side after 30 and 90 days. And this is what the, 2 more slides and then I'm done. And this is what the synergy coating looks like under scanning electron microscope, which is just a high-powered microscope. And then finally, when you have a good stent design, you need a great delivery system to be able to deploy your stent. We have a delivery system that has a laser cut hypertube that has, you can see it at the bottom there, it has over 300 cuts over just 100 millimeters in length of tubing. And that allows superior pushability and to keep your flexibility. And that's all for me. Any questions?
Thank you so much. Thank you so much, Lisa. That has been a very interesting session, and we've learned so much from it. In the interest of time, we will not be taking any more questions right now. We're running 15 minutes behind schedule, and it has been an amazing session. Thank you to all the speakers, the panelists, the chairperson. Please stay on for the next session. We are now moving to our next session, which is the imaging session. I would like to invite the moderators for the same, Dr. Rita and Dr. Purvi Pavane. Our chairpersons for the session would be Dr. Tripti Dey, Dr. Beatrice, and Dr. Rupali Khanna, Dr. Preeti Gupta, and Dr. Sabida Kadam. So over to Dr. Rita and Dr. Purvi.
Good evening, everyone. I'm Dr. Rita. I thank Dr. Jyotsna, Dr. Sarita Rao, Dr. Shiva for this opportunity to moderate in this imaging session. This meeting has been excellent from the very start, and various aspects of complex coronary interventions have already been covered. We now move on to the last but not the least imaging session of the day. As we've seen in the previous session, imaging is the crux in the complex coronary interventions for good long-term results. I request Dr. Purvi to introduce the speakers.
Good morning, everyone. I'm a non-invasive cardiologist by training, but
Dr. Purvi, Dr. Ziad Ali is going to give us the first lecture on.
Yeah, I was going to introduce.
Yeah.
Thank you. Yeah, so I'm a non-invasive imager, but I'm happy to be here, and I've known Dr. Ali for a long time, through the virtual media. And he just gave a lecture at our institute, so really honored to be introducing him. So he's at the St. Francis Institute in New York, and his interest has been use of advanced imaging and physiology techniques to optimize stent implantations. He has published more than 200 articles, he holds investigator awards from multiple cardiology society. He also is on editorial board of 3 major cardiovascular journals. So, Dr. Ali, it's yours.
Thank you very much. It's nice to see everybody, and thank you again for the invitation. Today, I'm going to be speaking with you about calcium in the coronary arteries. So, are you able to see my screen okay?
Yes, we can see your screen.
Wonderful. Okay, so my talk is entitled Calcium, Grind It, Break It, Smash It, or Shift It using OCT. I'm the Illumian 4 Global Principal Investigator. I've been using OCT for either research or clinically over 15 years. And it's become a major part of St. Francis Hospital and Heart Center care. So what is the impact of coronary calcium? As interventional cardiologists, we kind of all understand that coronary calcium is the bane of our existence. It has a lot of impact. It can impact device crossing. In this situation, if we are able to sort of muscle in stents, it clearly damages the polymer, which is very relevant from the last lecture. It can also create pitting within the metal, and then the drug elution kinetics are altered. And probably the worst of all of these things is if you are able to manage to get the stent into the artery and deploy it, but it actually doesn't expand the lesion because of this very thick calcification behind the wall, leading to significant underexpansion. In this 13,500 patient assessment from CRF's clinical trials, you'll see that moderate to severe calcification has a significant relative risk of 1.62, and this is moderate to severe calcification. When it comes to severe, this hazard ratio goes well above 2. So it is, in fact, clinically very relevant, and only in-stent restenosis and CKD have higher risk than calcification in terms of 1-year target vessel failure. Let's think about some of the fundamentals of angiography. Moderate calcification is when you can see calcium on either side of the artery during cardiac motion, but severe calcification is identified as calcium that's on either side of the artery with no cardiac motion. This is probably the most relevant study to set off our lecture for today. This is 440 patients, all of whom had angiography, OCT, and IVUS. What we learned from this study was that in these 440 patients who underwent assessment, calcium was identified in 82.7% by IVUS, 76.8% by OCT, and although this is somewhat counterintuitive, it's because the depth of penetration of IVUS is greater, but only in 40.2% of the angiograms. And that's very relevant because the angiogram remains the gatekeeper. Only severe calcification identified on angiography was associated with stent underexpansion. So the angiogram remains the gatekeeper. We need to identify at least moderate to severe calcification to determine if any further imaging or ancillary techniques need to be performed. By OCT, calcium can be identified as a well-demarcated signal poor region that occurs within the vessel wall. Here you can see it by this cookie cutter type appearance within that vessel wall. Moderate calcification is 180 to 270 degrees, and greater than 270 degrees is considered severe calcification. So as a result, compared to angiography, the OCT is able to pick up lesions very, very avidly, but compared to angiography, the specificity is lower. And what you'll notice here is we're able to pick up calcium when the arc gets to about 100 degrees, when the length gets to 4 millimeters, and then when the thickness gets to 0.5 millimeter. This is very relevant because we use this information to create a calcium scoring system, which we call the rule of fives. When you have calcium that's greater than 0.5 millimeter thick, 5 millimeters long, and 50% of the vessel arc, the stent is much more likely to be underexpanded. So as a result, we recommend more advanced lesion preparation in these patients. Here's an example of calcium-dependent lesion preparation. You see a significantly calcified lesion in the OCT. The atherectomy actually reduces the thickness of it by debulking the calcium. And then the balloon actually fractures the calcium. And when we push the stent actually pushes these two plates away from each other, leading to excellent expansion. What about treatment? Well, this really depends on the timing of vessels. So you can see in this example, in patients who have a calcified lesion compared to a non-calcified lesion in a non-culprit artery, the non-calcified lesions actually do better. The calcified lesions actually do better. And the reason is calcified lesions are stable. They don't rupture. They typically do not lead to ACS or STEMI. And typically they manifest as stable coronary artery disease. But as soon as we put the stents in, everything turns upside down. In this meta-analysis of 11,000 patients, all-cause death goes up, target lesion revascularization goes up, stent thrombosis goes up, and major adverse cardiovascular events go up as soon as we place stents into patients with moderate to severe calcification. And there's only one explanation for that, and that we do a poor job on managing patients with calcification. So what are the goals of therapy in coronary calcium? One is to cross the lesion and modify the plaque. When we want to cross the lesion, it enables us to upscale balloons and stents. For plaque modification, we need to debulk calcific plaque, induce calcium fracture, and maximize the luminal gain. We have balloon-based strategies, non-compliant balloons, and then sort of more fancier balloons such as scoring, cutting, compartmental, which really have varying efficacy. As you can see by the guidelines, the only clinical utilization for those is to reduce slippage. And then we have ultra high pressure balloons, which are being used, but the evidence for which is really very anecdotal. Non-balloon based strategies include laser atherectomy, rotational atherectomy, orbital atherectomy, and now, of course, intravascular lithotripsy. And I've included that non-balloon based, even though it's based in a balloon. The evidence only exists for rotational atherectomy, which shows in heavily calcified lesions, it may actually facilitate the technical procedure. As you know, the evidence for clinical benefit in randomized trials is lacking. So here's the best description of it. Intravascular lithotripsy is really smashing the calcium. You can see it's very much like a karate chop. It's a huge amount of energy delivered to the artery in a very short period of time, and that force can fracture calcium. Laser is a little bit like a jackhammer, and what it does is the pulsing, right, the fluency actually leads to significant hits on the calcium and lead to fractures within it. Grinding, rotational atherectomy is very, very much like a drill, as is orbital atherectomy. And then NC balloons are really tearing the artery by you pushing very hard and tearing the interface between the calcium and the fibrous tissue, or trying to break the calcium. There are limitations of existing technologies, as you know. The limitations are balloon-based. It's insufficient force to actually break the calcium. Wire bias can be a big problem from atherectomy and actually end up coring into the normal artery. A laser, because of its energy and its unpredictability, can lead to perforation, especially as its focal energy. And then finally, IVL is problematic because if you have a subtotal lesion, you might not be able to get across it. So there are limitations with anything. This is not the Swiss Army knife, and therefore we really need an algorithm. The algorithm uses the angiogram as the gatekeeper. We try to cross with an imaging catheter. If we're unable to cross, we use orbital or rotational atherectomy. And then we really use an imaging-based strategy with either OCT or IVUS to determine what the optimal strategy is in order to modify the calcium. You need to know what a calcium fracture looks like on OCT. It's not very subtle. In fact, on OCT, it's extremely clear. You can see the calcified segment, which is this cookie cutter appearance within the wall, now has a fracture within it. And here you can see another calcium fracture. So let's see in uncrossable lesions, what are our possibilities? So for uncrossable lesions, we really are going to use orbital or rotational atherectomy. For deep or medial calcification, we're going to avoid using atherectomy type devices, and I'll show you why in a second. You need to focus on sort of NC, IVL, or ALCA. And here's an example. So here's a patient where the calcium is deep. When we say deep calcium, we don't mean that it's in the media. We just mean that it's covered by a layer of tissue. And here you can see there's a layer of intima on top of the calcium. And then when we perform the atherectomy, all it does is cut the soft tissue and it doesn't modify the calcium at all. Okay? This is very, very important to understand because the bulk of debulking will be in the soft tissue and the calcium will not be impacted. Laser, however, or intravascular lithotripsy will work. Here's a uniform calcification in 360 degrees. Despite the presence of fibrous tissue on top, it's able to penetrate through the artery wall and fracture the calcification. Laser is also able to do this. So this focal energy or focused energy can lead to fracturing of the calcium, as in this situation, in a single plane in a very thick part of the calcium, allowing stent expansion. Now, what about eccentric calcification? It's important to remember that eccentric calcification is difficult to modify because of the physics. When the calcium is less than 180 degrees and you inflate a balloon, this is the mechanism of the balloon. It ends up tearing the interface between the calcium and the balloon itself, and you end up with a very deep dissection with completely unmodified calcium. The mechanism of action of atherectomy is indeed wire biased. You can see wherever the catheter is sitting, that's exactly where the cuts occur. But you can also have unfavorable wire bias. Here's a heavily calcified left anterior descending with lots of angulation, and you can see what has happened in the OCT. It's basically cut a huge hole in the artery wall as a result, and that's led to, luckily, a contained perforation because of the mechanism of wire bias. Here's an example of rotational atherectomy, which hasn't worked. In nodular calcification, the rotational atherectomy, the wire bias is actually away from the calcified nodule. This is pre-rota and post-rota with almost no debulking. And by doing a careful assessment of the angiogram, you can see why. You'll notice that the calcium is on the opposite wall and the wire bias is on the opposite wall. And what's happening is the atherectomy burr is simply slipping right by this nodule and not impacting it. And so as a result, a better choice would have been orbital atherectomy, and this could not have been determined without OCT. And you can see that the orbital atherectomy goes in and actually cuts this vessel and cuts the nodule off, actually giving it a significant debulking, allowing the devices and the stent to expand. So this is the algorithmic approach that we like to use for calcification. I think this is how you learn whether you should break it, shave it, cut it, smash it. And overall, we need to remember that angiographic severe calcification can lead to stent underexpansion and is associated with clinical impact. We need the angiogram as the gatekeeper, but then using an algorithmic approach by incorporating IV imaging is very important. Device choice is dependent on the intravascular imaging findings, and there's no one size fits all. You got to study the imaging in order to optimize device detection, and calcium fracture or nodular debulking really should be identified prior to drug-eluting stent deployment. I thank you very much for your attention, and again, thanks very much for having me.
Excellent lecture, Dr. Ziad.
A very
Rita,
nice session by you, Dr. Ziad. I would just like to ask you, what is your experience with lithotripsy in nodular calcium?
It works excellently. I published the results, or presented the results, I should say, at TCT in 2021. And the bottom line is, even though patients with nodular calcification have overall globally more calcium, if you simply split patients in the DISRUPT CAD study who had nodular calcium versus non-nodular calcium, the minimal stent areas and the stent expansions are exactly the same. In fact, we're now learning that there are 3 types of nodules. There's a nodule that's sort of a popcorn that sits on top of jelly, so that's a nodule that's in lipid. There's a popcorn that sits on top of a heavily calcified base, sort of sitting on a glass shield. And the glass shield can be broken by the IVL and actually allow you to push the popcorn out of the way. And then the last one, which is the real problem, is the glacier. And the glacier is really thick calcium all the way through. And as of yet, we do not have a good way to modify it. Those calcified nodules typically are pushed away and lead to the D-shaped eccentric calcified lesions.
Nice talk, Dr. Yeah. Hi, it's Dr.
ahead.
Pali here. Just for the documentation of the fracture on the see the calcium. So if you see the DISRUPT CAT study, the calcium fracture was noted in only 60 to 70% of the cases. And they say there is the micro fractures which happen, which sometimes may not be able to see on OCT. So how relevant it is to have to document that the fracture is there, and we should, if it's not seen, should we go ahead with other strategy to document it, that either go for NC balloon again after that or not?
So it's a great question. So I think documenting calcium, there's 2 ways to do this. The pragmatic approach is to perform your atherectomy and then see if you have your NC balloon expanding in 2 different orthogonal views. That is your stent expansion, right? The calcium fracture and the amount of calcium fracture is going to determine for you how likely you are to expand. Now, if you go back, remember when we did the calcium fracture, that was on a cross-sectional level, not on a lesion level. There's no situation where there's no fractures at all. So fractures are almost unanimously present when we do some type of calcium modification and identify it using intravascular imaging. So to be more pragmatic and to answer your question, if you don't see calcium fracture and you don't see the balloon further expanding or giving you full expansion, you really need to go back with the second modality. Yesterday, we did a live case to APSIC. We performed orbital atherectomy, got some fractures, but the balloons weren't expanding fully. So we actually went back and added intravascular lithotripsy and then got a full stent expansion.
So you will depend more on the imaging part to document the fracture. If you suppose you are able to see the balloon which is dilating in both the orthogonal views, then also you will prefer to go for additional modality.
If I see the NC balloon fully expand in two orthogonal views, I'll just put a stent in. You can't make it better. But if the balloon is not expanding and you don't have fracture, you have to do more work.
Could I ask a question building on that, actually, related to intravascular lithotripsy? So we've just been introduced to the technology, and these are considerably just a little bulkier than the regular NC or scoring balloons. And we're also mindful about not being able to just open up balloons randomly. So about sizing, say I took the biggest NC that I could, and there was dog boning, and my next step would be IVL. Would I size it to exactly the NC? Would I size it to a little smaller, a little bigger? If you could give us a practical.
So yeah, great question. So ideally, if you've performed intravascular imaging, your IVL balloon should be sized 1-to-1 to the media. Okay. Now, if you can't do that, right, because you don't know, then you should size it 1-to-1 to your angiographic assessment. But you have to understand the mechanism here. So what the IVL is trying to do is you're not trying to create barometric pressure with the balloon. The balloon is there to squash the intima, kind of like a pillow sitting on top of a plate. So if you took a pillow and you put it on a plate and you hit it with a hammer, the plate would not break, right? But if you take a pillow and you squashed it and got someone to hold it and then hit the plate, it would break. So the balloon is designed to push the intima and get the electrode as close as possible to the calcium. And so anything that would create impedance, right, like this big pillow in the middle, is minimized so the maximum amount of energy is delivered to the calcium. So let's say, for example, you have a very long lesion and the proximal is 3.5 and the distal is 3.0, but it's tight. You could use your 3.5 larger balloon, inflate it at very low atmospheres, squash the intima, break the calcium, but don't go up higher with your lithotripsy balloon. You know, the lithotripsy balloon is almost, it could be any size. All you're doing is to get the interface between the calcium and the electrode.
Can I ask you one question?
That's great.
If a moderator permits, I just want to know, there is a concept, people are using rotatripsy cases, like where if lithotripsy is not work, you can use a rotablation. So can I have an answer, like from the OCT images, can we judge that this patient is not going to the calcific arc, or is there any predictions that we have to keep a rota standby?
So usually it's the opposite way around. Okay. So when you have an uncrossable lesion because the balloon is too thick, people perform rotational atherectomy in order to deliver the lithotripsy balloon. Yes. I actually am not aware of any cases where someone performed lithotripsy, could not expand the stent, and then did rotational atherectomy.
Okay.
That I don't know of. It's certainly possible, but I think it would be very much less likely. So, you know, I gave you an algorithmic approach, but I'll give you a pragmatic approach if you can afford it. Like, let's say in India, the IVL is the same price as rota, right? If you can cross it, just shock it. Okay, just cross it, inflate your balloon, and then move your balloon, give 30 of your pulses right in the most heavily calcified segment, and distribute the remainder of your 50 pulses along the calcified lesion and put your stent in.
Okay.
In case, can I ask a question? Simply, it was a great talk, and we are really getting through the lot of questions which we really face in day-to-day practice. So there is a situation where we have done debulking by other methods, and we try to get the stent in, and we got the stent in, and it was inflated, but it is not completely opposed and completely this thing, because of some nodules, calcium nodules, which are there even after. So is it possible in that situation, after we put the stent, to go in with this IVL and then do the IVL inside the stent and get the nodule broken and then we can expand the stent to the optimal position.
Yes.
Yes.
Could you tell us a bit about
Dr. Tripti, we've done that many times. So many times we've gone in.
So there's no reason you can't do that. There is a theoretical risk that you'll, in a freshly deployed stent, that you'll damage the polymer, which it probably does. But the lesser of those two evils, to leave a severely underexpanded stent and risk stent thrombosis versus risking a little bit of polymer damage, the balance is obviously to expand the stent. And remember, in heavily calcified lesions, you typically don't get a lot of neointimal hyperplasia early, right? Because the cells have to crawl in all the way from the edges. Your cells can't crawl through calcium. It's like a concrete wall. So if you end up in that situation, yes, the simple answer is you can take your IVL balloon, deliver your shocks, and expand the stent.
How much shock we can give in a nodule kind of situation, heavily calcified area? Maximum 80 pulses are there in one balloon. So is it possible to give all the pulses in that situation?
Sure. I typically don't do that because what I like to do is deliver what I call a power surge in about 30 to 40 pulses in the heavily calcified segment. Now, what you want to do is look at your angiogram, and as you're delivering the pulses, if you see the lesion start to yield, the calcium is breaking, okay? A great example is, imagine I take a plate right in front of you, and I crack the plate. If I crack the plate, I'll hold it, the plate won't fall apart, but you need the NC balloon to break it, right? The cracks are there. You need to expand it, you need something else. So typically I do about 40. If you see the balloon start to move, the fractures are present, then I use the rest of my calcified pulses throughout the rest of the lesion. But if you wanted to and the lesion was not expanding, I deliver all 80 pulses.
Right.
We have some new technology coming.
Could I just
There's
ask
going
a
to be
question?
even higher energy. So that's going to be quite exciting, right? So you'll have a potential for more energy in truly recalcitrant lesions where it's very, very thick. So there's more on the way from IVL.
I have one more question, please. Yes, thanks. About ISR and the off-label use of IVL. How do you size it then? Of course, guided by imaging, but again, it's difficult to navigate.
So anytime you're using intravascular imaging, what you want to try to do is find an area outside of the calcified segment where you can see the media to the media, okay? And when you can find the media to the media, you're going to round down to your closest size. So let's say you have a very heavily calcified lesion, you need to go 7, 8 millimeters or 10 millimeters distal. You find the media to media, it's 3.7, you round down to 3.5, use your 3.5 balloon.
All right, and same applies for ISR as well. Great, thanks. Thank you.
That was a very interactive session. I think, thank you, Dr. Ziad. We'll move forward. I'd like to request Dr. Hetan Shah to present her case. C2 and complex case is my experience. Dr. Hetan Shah is a professor of cardiology at KM Hospital and consultant interventional cardiologist at the Jaslok Hospital, Mumbai, India. We all know ma'am very well, and over to you, ma'am.
Thank you very much. I think there is a typing mistake. Akash, can you share my screen? Actually, my topic is OCT, because this is an image-guided seminar. And OCT as a decision maker, it is about our experience at KM. Can you go to the first slide? Yeah.
The slides are visible, ma'am.
Yeah. Akash, will you run this slide? Next slide. Yeah. I will discuss a couple of cases, and then it is a short discussions about how the OCT is a game changer in addressing the coronary lesion. I will start with my first case. A 60 years male, a diabetic, tobacco chewer. He had a history of infeval MI in 2007, underwent a PCI to RCA, but the details are not available. And he presented with the recent onset crescendo angina for last 1 month. Next. So ECG shows evolved interview wall MI. The echo shows preserved ejection fractions with no renal wall motion. Next. So he underwent angiogram. The left system was unremarkable, but the right angio shows a linear multiple filling defect in the mid and the distal segment. With the distal segment, there is a tight lesion. And the visible stent you can see in the images, but next we have to zoom. Next, yeah, we had zoomed. You can see the multiple linear filling defect in the mid and the distal segment with the tight lesion in the distal segment. So what are the possibility? Next, yeah, either it could be a mimicking multiple linear defects are like either we are dealing with the pseudo dissections or a spontaneous coronary artery dissections or a intrastent restenosis or a coronary arteritis, or a second last possibility is a thrombus, a partially recanalized thrombus. This partial recanalized may be either because of the natural hemolytic process of the thrombus, evolving thrombus itself, or with the help of thrombolytic therapy. So the limitation of coronary angio occurs over here, like the diagnosis is not specific. There are multiple diagnostic dilemma. So we have to take a imaging help, either in the form of OCT or IVUS, to know the histopathology better, and with the high resolution force, we decided to go ahead with the OCT. Next. And these are the OCT imaging, where we can, first as the distal lesion was very tight, we have to pre-dilate the lesion so to make a smooth passage of the OCT catheter. And then we run the OCT catheter, and which shows there is a partial recanalized thrombus. Next, with the dissection flex. Yeah. Can you run it, Akash? Hello. The previous. Run it. Yeah. You can see the distal inflation sign. There is a dissection flap also. And you can see a multiple partial recanalized thrombus. It looked like a honeycomb appearance, or a Swiss cheese, or a lotus root appearance. And next. So this is an entity called spontaneous recanalized thrombus. And that etiology is either because of emboli or a recanalized thrombus itself, or it could be because of in a patient with a Kawasaki. There is a congenital deformity of such lesion also. It is known as a woven coronary artery, where the coronary intima is intact and the patient is usually asymptomatic, but with a normal coronary flow. Here the coronary TIMI flow was disturbed and the intima is not intact. So it is we are dealing with the spontaneous recanalized thrombus. Next. Yeah. Then we stented the lesion. The stent, it is distally 4/38 and the proximally 4/23 Zans prime was deployed. With the when post PCI we had to post dilate the stent. Next. And this is the optimal opposition of the stent. So OCT not only help us into the diagnosing the histopathology of the lesion, but also during the PCI about the ruling out the malpositions or underexpanded stent or age dissection. Next. And quickly 2 minutes I will run through the second case. It is again a young ACS, a 43 years male, a diabetic, had a recent crescendo angina, EF of 45%, and enteroseptal wall territory, there is a hypokinesia. Next. ECG shows NST changes. Next. You can see in the LED, there is a lesion in the proximal aspect. Next. And this is, I'll just give you the picture at the site of the lesion. You can see a very nicely demonstrated a plug rupture. We at KM, we are doing the study of less than 40 years young MI OCT, and we found the more of dyslipidemic patients and the lipid arc is more. And this plug rupture, you can see very well characterized on the ECG, on the OCT imaging. And OCT, so in a ACS, next, help into the delineate the vulnerable plaque or a plaque morphology, whether the plaque is either having a erosion where the integrity is maintained, or a plaque rupture or calcified nodule. But the vulnerability of the plaque, we have to identify with the maximum lipid core and the fibrous cap thickness. If it is less than 65 micrometer or lipid arc is more than 90 degrees, then they are more prone for the vulnerability. Next. And also, these are the images of the plaque rupture, plaque erosion. Next. Where the integrity is maintained. So you can prevent the stenting, the thrombus and the calcified nodule. And one important other message I would like to say, that the culpritness of the vessels, whether the vessel, which vessel is culprit and the non-culprit. In the non-culprit lesion, you can find the mismatch between the visual and the functional imaging. And then the lipid arc will be, the index will be short, and even the lipid core will be the short. Next. So I would say, I just conclude my talk that OCT not only helping us to customize the look of the PCI, and especially in the patient with the recurrent ACS or young ACS, and also in a patient with the stent, more prone for the stent failure. So here it helps in understanding of underestimated coronary artery lesions and the planning for their customized treatment strategy. Thank you. This is all. I just conclude. Sorry, the imaging of the stent malpositions. Next. Okay, sorry. Just quickly 2-3 images. Yeah. And in a patient with a decay crush, where 3D reconstructions imaging, you can nicely park your wire through the distal stud. Next. Yeah, this is a coronary pathology, either aneurysm or arteritis. Next. Yeah, this is a bifurcation lesion. We are in a very good section on that. So OCT help 3D reconstructions with angio-co-registration will help you for a better outcome in a all bifurcation stent technique. Next. Yeah, you can park your stent in a desired stent segment. Park your guide wire accordingly. Next. Yeah. So it helps, and we can customize the outlook of the patients with the ACS as well as in a post PCI segment. Thank you.
Dr. Haitham, thank you so much for your talk. Just for the information of everybody, we are running 20 minutes behind schedule. So we will be limiting the number of questions. I see that Dr. Sabida Kedavas has joined us. Just one quick comment from Dr. Sabida, and then we'll go to the next talk, please.
Hi, thank you. I'm sorry I missed a bit of your presentation. I just had my own presentation. But a great, whatever I've seen so far, great presentation. So what is your experience on using OCT in like ACS scenarios? Is that something you routinely do? Like when you have a patient present?
Yeah, if it is a young ACS, because here we have to prevent unnecessary and we have to give them a maximum result. So in that case, young ACS, we have an excellent outcome, and we are soon going to publish the study. It is more of in India, we are seeing a decade earlier and more of a premature atherosclerosis. So it is not only the thrombus, but also the lipid core and dyslipidemia, the plaque rupture pathology is more common, we found, compared to the Western population.
Dr. Rita, could you go to our next speaker, please?
Yeah,
I
I'm
request
going to be
to introduce Shiba.
Yes. Yeah. Thank you, Rita.
Thank you.
Next speaker is Dr. Shiba Thakur Chabra. She's a professor of cardiology at Hero DMC Heart Institute and Dayanand Medical College, Ludhiana, India. And she'll be speaking about OCT, PCI evidence and beyond.
A very good evening. Rather, I would say that we are almost nearing the conclusion. And are my slides visible?
Yes, Dr. Shiba, they are visible.
And I'm audible. Okay, so we've already discussed enough about OCT throughout the day, and I would rather say that after having seen all these cases, this is the time to conclude that where is the evidence and what is beyond now? Well, we all know that OCT tells us about the normal plaque, the fibrous plaque, a highly attenuating red thrombus or a lipid plaque versus a low attenuation in a white thrombus or a calcified plaque. We are also aware that we need to, whenever we have to do an OCT in the patient, we need to understand that there's a pre-PCI OCT and a post-PCI OCT. The pre-PCI OCT is inclusive of the understanding of morphology, length and diameter of the lesion and the vessel, and the post-PCI OCT studies about the medial dissection, apposition, and expansion. We are aware of the usually talked calcium, we've discussed it in enough length, more than 180 degrees, more than 0.5 mm thickness, more than 5 millimeters in length, and how we address it. We've discussed about the lengths which are measured by using an external elastic lamina to EEL measurement versus the luminal measurements. We also know that we need to measure the diameter and choose the post-dilatation balloons according to the proximal and distal reference diameters. The impact of calcium has been discussed much more. Dr. Ziad Ali was here and he discussed about the severity, calcium type, thickness, deep, superficial, nodular calcium. We've also discussed that how OCT sees to the thickness of the calcium vis-a-vis IVUS, which just gives us a dark shadow, and how the calcium thickness is key in predicting the stent expansion. Dr. Haythan was just now mentioning whether we have an OCT scoring system. Yes, we do have it. We all know more than 180 degrees arc gets 2 points, vis-a-vis 0.5 mm and more than 5 mm of thickness and length of calcium, which get 1 point each. And that is what leads to the Shalosa OCT algorithm. Just as Dr. Ziad made it very simple, that after having seen this calcium and after having calculated this score, we know that we are dealing with a higher score. We need to see whether our balloon is crossable or not. Once the balloon is crossable, we do consider an IVL, and once it is uncrossable, we go on to the other debulking techniques like a rotational or an orbital arthrectomy. And yes, of course, when the score is less, we can consider our usual non-compliant scoring and cutting balloons. So this understanding with the OCT that we have is there, and it helps us to get better stent implantations, better expansions, better lesion preparations, and of course, post-stent evaluation also. Dr. Haythan has shown us enough cases, just like a similar case. This was a case which had an LAD, which was, not showing a lesion on a routine angiogram. The lumen was more or less clear with mild haziness, but this is what the OCT revealed. It showed us a thrombus, which when aspirated was followed by a morphology of plaque rupture. So plaque rupture, once we have seen, we know that we need to go ahead and treat this lesion in an acute MI, and we need to place a stent vis-a-vis when it is just a simple erosion or white thrombus, which can be, kept on medical therapy also. So deciding when we need to stent our lesions and how they would behave post-PCI, identifying dissections, especially when they are present in more than one arc, studying gross malopposition when it's longer than 3 mm or more than 0.3 mm from wall, and looking at expansion once we have more than 90%. That is the result that we are looking at. We have discussed about bifurcation cases in detail. Of course, OCT gives us a great understanding and help in strategizing the management of bifurcation. PCI, it helps us to understand the procedural complexity, understand the side branch compromise, the ostial locations and the ostial dimensions, to look at any main vessel complications. So we know that predictors of side branch complications via a bifurcation, especially when defined by OCT, can be a carina to tip angle of less than 50 degrees and the branch point to carina tip length of less than 1.7 mm. So gone are the days when we were just using the midpoint of the bifurcation division. We now have OCT defining us the carina tip angle and a branch point to carina tip length, which can predict the side branch complication. With OCT, we are also able to define the port and the length of the port that we might be needing and the stent lengths that we might be needing in our bifurcation patients. So having said that, OCT allows precise identification and mapping of the side branch ostium, especially when we use it with angiographic co-registration. So we know about the pre-PCI and post-PCI results that we have in our patients and the consequences that patients might ultimately have if they are having stents which are less expanded or not opposed. So what are the recommendations and what are the evidences? And that is what we are here to discuss about. Well, the 2018 ESC guidelines, they upgraded OCT to a class 2A level, just same as IVUS, and Professor Ziad Ali is here. We know about the Lumen 3 study and are also aware that OCT guided PCI resulted in similar MSA as compared to IVUS guided PCI, and it led to greater stent expansion than angiographic guided PCI and lower rates of dissection and malopposition than both IVUS and angiographic guided PCI. Having said that, we need to understand that whether this actually improved the procedural outcomes, and this is what it was. At 1 year MACE, when it was studied, there were no significant differences in 1 year rates of TLF, which were present in OCT guided, IVUS guided, and angiographic guided PCI. Well, let us have a look at more studies. The opinion study, which was done in IVUS guided versus OCT guided, has shown similar rates of target vessel failure at 12 months of follow-up. These studies have, of course, shown that OCT does change the decision pre-PCI and post-PCI. 71% pre-PCI decision change in the physician management, vis-a-vis 52% in the post-PCI in the studies like Optico study was reported. The Lumen 3 also found that, OCT changed treatment decisions by having more stent expansion in around 5%, 70% increased detection of major malopposition, and another 26% increased detection of dissection. And clinical outcomes were also reported to be better in OCT guided management of the PCIs which were done, especially in the CLI OPCI, which showed improved clinical outcomes as compared to angiography alone. The clinical outcomes in the meta-analysis and pan-London registries have also shown that the incidence of all-cause mortality when the PCI was OCT guided was significantly lesser than as compared to the angiographically guided PCI, which was done. There have been studies, and we have been studying maloppositions, dissections, looking at the coronary arteries. The clinical outcomes did not really correlate much when stent malopposition was looked at, and whether it should actually be taken as a major criteria is still not clear and being evaluated further. So if we look at the several evidences and studies that we have with the use of OCT, we have data like CLI, OPCI, Lumen 3 studies, which have documented a decreased risk of cardiac death, and which have shown that the median MSA by OCT was comparable. It was non-inferior to IVUS, but it was not superior to IVUS or angiography guidance either. Well, if we look at the registries and the meta-analysis, significant reduction in the MACE and cardiovascular death has been reported by the use of OCT, and also significant reduced mortality in OCT-guided PCI has been reported in pan-London PCI cohort, as we just now saw. So we are looking at 1 year follow-ups also after OCT, like target vessel failure we just now saw, as it was an opinion study, and it was around 5.2% in OCT-guided PCIs compared to 4.9% in IVUS guided, again showing a non-inferiority with the use of OCT as compared to the IVUS. We are looking further to, we were talking of left main bifurcations, and we were talking of data, and we were talking of the evidence that we have for the use of imaging in left main bifurcations. Of course, IVUS has stood the test of time, and we have several trials for that. But the coming trials like Occupy, October, these are the trials which are going to look ahead for complex lesions, which we've been talking about since morning. The CTOs, the longer lesions, the bifurcation lesions, the lesions needing 2 stent techniques versus 1 stent technique with kissing balloon inflation. So we are looking forward to these trials, and the evidence is more and more to spring. OCT has its own shortcomings of, blood and catheter lumen, flushing, catheter prolapse, pseudo erosion, pseudo, thin cap fibroathromas, and so on. We have discussed pre-PCI and post-PCI in detail, quite in great number. Before I end, where is the future? What is beyond that we are looking for PCI? Well, we all know the contrast that we are using and the issues of arrhythmia that we have with it in OCT. And we know about the low molecular weight dextran, we know about the normal saline, we know about the ringer, and the arrhythmogenic issues with that. So the future is looking towards having a non-contrast flesh media, which might have a similar biocompatibility, viscosity, and blood clearance compatibility with optical transparency, so that we can use the material which is more friendly, less arrhythmogenic, and more nephro-friendly also. The future in OCT also looks at describing the functional capacity of the vessels. We are using FFR, RFRs, separately with OCT. So probably the future is here, and the future is looking at not just having an increased acquisition speed, not just at having a good spatial resolution with micro OCT, which can define, cellular levels, subcellular levels of the vessel. Look at the macrophages, which will not just have even a better penetration depth, rather than just have a good resolution, but also look at optical flow ratio. That is the fractional reserve along with the OCT performed, and the fusion study is there. So whenever we look, we always look at the future. Having said that, I would like to thank you all for hearing, and let's see where OCT takes us in the coming times. Thank you.
Excellent lecture, Dr. Shiba. Thank you for summarizing it all for us, including all the data. So that was excellent. I now request, if there is a question or two, we could take it from the chairpersons in the interest of time, because this is the last session on OCT. So we could really have a question or two.
May I ask
Dr. Yes, Dr. Preeti. I was just looking for.
Yeah, ma'am. When we do imaging and in our target to chase normal to normal, we mostly end up putting longer stents. And as we had studied in our practice, that the shorter the stent, the lesser the chances of the ISR. So what are your comments on that, ma'am?
Yes, surely. You're right, that when we were studying and we were not having OCT, we remember, studying those, what are the chances which cause more restenosis and more thrombosis, a longer stent, a narrower diameter. So I think we have data enough which does tell us that target vessel failure and the need of re-interventions, that the data does favor that, and that, Lumen 3 and other trials have shown that no doubt the length would be more, but at the same time, maybe the diameters would be better. So though EL to EL measurements are better done with IVUS, but luminal measurements, can be done. And if we are able to get EL and EL, then why not? So it's always good to park your stent. It might be a longer stent, but it would be anyways better if we are parking it in a normal segment rather than park and place it in a segment with plaque and, later on have issues springing up.
I would like to ask one more question regarding this plaque extension. So normally we see in OCT a lot of plaques extra, more than our angiographic as we have discussed. And in that context, if we have a non-occlusive plaque, like it's a very huge kind of, burden of the plaque burden because of a lot of athyroma, Bruel type of, but it is not causing obstruction to the level of FFR positivity. So this kind of vulnerable plaque, what we say, like you said now, micro OCT will give us a more vulnerability to the plaque. So in the future, in these vulnerable plaques where we know that they are going to rupture very soon, or they will produce acute coronary syndromes, and they may even produce sudden deaths also for young people, because there is no obstruction in young people. Mostly they die suddenly because of rupture of these kind of non-occlusive plaques. So do you want to say that we need to passivate these plaques by putting, thin strut, newer technology stents with less kind of...
This is really very interesting, and this has boggled our times for long times. We know that it's the vulnerable plaques which rupture. It's not the stable plaques which cause stable lesions which cause problem. So I would I need to have enough data before I can say, but whatever I have read is about TCFAs, the thin cap fibroathromas. So the thin cap fibroathromas, there was an IVUS guided study, and they actually did not find much benefit when these were addressed. However, when OCT was done and thin cap fibroathromas were studied, they were vis-a-vis associated with more clinical events in the patients. So I would at this point of time say that if we are having something, and we need to identify the plaque morphology. If there is a documented rupture, then definitely we have to go ahead and stent it. However, if it is just an erosion, we need to manage the vulnerability, and vulnerability can be managed with our statins, with the endothelium stabilizing drugs.
Can I comment one thing? Just continue with Dr. Tripti.
Yeah. Do you mind, Rupali? Yeah. Rupali, do you mind if I just make one comment?
Sure.
Yeah. On CT scan also, we identify these vulnerable plaque, particularly in stable angina situation. The only current practice that is supported by evidence is use of preventive therapy. So, statin, PCSK9, whatever there is. Now, when you take the ACS patient, everything changed, and probably what Dr. Chabra said is applicable there. You go looking for a plaque rupture. But, now in United States, we have many AI supported software on CT scan where, it can identify the vulnerable plaque readily, but that doesn't mean you go ahead and put the stents on those patients. Thank you. Go ahead, Rupali.
Yeah, I totally agree with Dr. Purvi that the same thing. If it's finding a TCFA is not an indication for going for stents. There was one study which compared, as you said, on OCT, that TCFA with minimal lumen area less than 4. When they combined these both things, then they found that putting a stent would be beneficial in this case, especially in erosion study. It's not always erosion should be left like that. If erosion, you are seeing the luminal compromise, you should put a stent in this case, because they will have a increased MACE events in future.
Yeah,
so I think it should be the MLA.
It
should be the MLA which should be the deciding factor in addressing these.
So this erosion,
otherwise your PCSK9 and statins, they are
once
good enough
MLA is less, and then there is no doubt that you have to go ahead and stent it. You cannot be leaving that. But of course you have to look at when you're in you're in a fix whether you have to stent it or not. That is the time when you can look at this morphology of rupture versus erosion.
Thank you so much. Everybody did so well. And Shiva, your talk was excellent, extremely well taken, and very contemporary and for our clinical practice and the future of OCT, as you said. I think OCT is going to be really the game changer for all our clinical practice. That's great. Thank you so much.
Yeah, thank you.
And we go to our last speaker.
Yeah. Dr. Zakia Khan, HOD for and honorary cardiologist at Fortis, Melbourne in India. I request you, ma'am, to present the tips and tricks in left main, PCI. This is the last lecture of the day. Over to you, ma'am.
In the interest of time, I thought, interest of the session, I thought I would rather talk about OCT only because it's imaging symposium rather than talk about left main. So I'll just present a case of OCT. Can you see my screen?
Not yet.
Not yet, ma'am.
Not yet. Now, can you see my screen?
Yes, ma'am. Your screen has been shared.
We can see your screen.
So I'm today going to present a case which is an IVL case utilizing.
Sorry to interrupt you, ma'am. Sorry to interrupt you, ma'am. Your slideshow is not begin, ma'am. You have to click on the slideshow.
Okay. Again, same thing.
On the bottom of the screen, you can find the icon, ma'am, for the slideshow.
This is
Yes, ma'am.
now.
Not yet, ma'am.
I think it's a protected view or something of that kind.
Ma'am, I guess you are unshared the screen, ma'am. Could you please share once again and click on screen, ma'am? When you click share screen, click on screen and click on share.
Just a second. Screen share. Your share. Now can you see?
Yes, ma'am. Perfect.
Yes.
Yeah. So this is an octogenarian elderly lady who presented to us with unstable angina. And she had significant infralateral ischemia at rest. There was wall motion abnormality in the inferior wall. And on the angiographic findings, you can see here that the RCA is heavily calcified, tightly stenosed. She had also undergone an open heart surgery with an ASD closure almost 25 years ago. The LAD also showed a tight calcified lesion, as you can see. So this patient had significant RCA disease, significant proximal LAD disease. All the lesions were significantly calcified, and she was elderly and a post-operative case. So we did not do the case on the same day. We said we'll plan the case with all the armamentarium on our board. I planned this case with OCT guidance so that we can decide what kind of plaque modification we need to use. And we did the OCT of the RCA. You can see that the OCT is here. OCT catheter is in. Before passing the OCT catheter, I had to dilate the lesion with a 2 mm balloon because the lesion was too tight. It was not permitted the OCT catheter. After dilatation, I will show you the pictures of the OCT. This is the OCT run. You can see that the artery is significantly calcified, and at the lesion site, there's significant deep calcium in the artery. The lesion diameter, the vessel diameter turned out to be around 3.5 distally and 4 proximally. So we used 2 overlapping stents the RCA, 3.5 down and 4.0 proximally, and you can see the result. This is a good angiographic result of this patient, and you can see the post deployment CT run. See that the stent is very well opposed and a well expanded stent. Expansion to almost 95%, and no evidence of any malapposition. Then we proceeded with our LAD. Now you can see visually LAD looks very calcified. The lesion was dilated with a 2 balloon and OCT was done. See the pre-PCI OCT. Again, significant calcium. This lesion was also dilated with a 3.5 IVL balloon. Here we gave 30 pulses, in the RCA we gave 50 pulses. So we technically used one IVL balloon in 2 arteries. This is post-stent implantation. We post-dilated the LAD stent with a 4.0 balloon. With a good MLA, good MSA, and good expansion. I'll show you the angiographic pictures. See that the LAD stent is well expanded. So in this particular patient, both the lesions were dilated with an IVL balloon, which was 3.5. In RCA, we gave 50 pulses. In the LAD, we gave 30 pulses. And we were able to use large stents with a very good outcome. So when you're dealing with elderly populations, elderly patients, and patients with post-operative state, I think we should be prepared with complexity of lesion, and imaging is always a boon in such patient. In this case, we were successful in treating complex lesions with the IVL shockwave, which was image guided to prevent further complications. Thank you.
Thank you, Dr. Zakia. I invite the chair for any final questions.
That was a great case, Dr. Zakia, and you have done a very excellent job for such an elderly lady and giving her maybe extra 20 years of life. But I was just thinking in cases where we see a lot of calcium, mostly post-dialysis and the renal failure patients, and there one IVL balloon may not be enough for going for the this thing, debulking with the calcium. So the cost goes so much. So what could be the, mix and match where we can reduce the cost and use only one IVL balloon, because second balloon has to be again built for the patient in those kind of patients.
As Ziad Ali was saying, that you could divide your pulses, in a larger area, give less pulses in a larger area. Maybe then you could save more on the balloon, and maybe you could combine with a cutting balloon in certain areas where you feel the calcium is not that bad. So combination of cutting balloon, cut and crack kind of a thing. You cut, crack, and at times you could even use high pressure balloons. So I think you may have to use combination of modalities if you are restricted with finances. Many of us have ox balloons that are OPN balloons, ox cutting balloons we could use in such patients.
Yeah, thank you, Dr.
Well, since there are no more questions, in interest of time, since this is the last session, I think last talk for the session, it's very apparent that intravascular imaging is the way to go for coronary interventions in many situations. So I thank all of you to join us, and I thank the organizers to invite me. I definitely learned a lot, which may be, which may impact my practice as well. So thank you everyone for joining, and thank you, Rita, for moderating this session with me.
Thank you.
So on behalf of WCC, I would like to thank everybody who joined today for an amazing session. Great conversations, great deliberations, and excellent job by all of the faculty, the chairpersons, the panelists, the speakers. It has been a scintillating experience. Thank you, everybody, for a wonderful first day to our meeting. Do join us tomorrow for the second day of our meeting. Our president, I think, is also here. Dr. Jyotsna Madhuri, are you there?
Yeah, just I wanted to add a few words along with you to thank each and every person. The success is just because of those people's knowledge, and we acquire the more knowledge than distributing the knowledge. And thank to each and every person, especially to the Sarita and to the Shiba, who are there continuously from the beginning to the end. And everyone is added their wisdom to our knowledge. Thank you all. And please join us for tomorrow to have a more discussions in a different allied sciences also. Thank you all. Good night.
Thank you. Good night.
Thank you. And good night, everybody.
Bye-bye. Good night.
Bye. Good night.
Bye.